a CME on bladder cancer hosted by the Center of Excellence in Urology at Caritas Institute of Medical Science under the aegis of Association of Southern Urologists. A CME that serves as a beacon of knowledge and innovation in the ever-evolving field of medicine.
As we know, bladder cancer is one among the top 10 prevalent cancers worldwide. The CME will interview sessions addressing recent advances and practices spanning the entire spectrum of bladder cancer.
Today, we are privileged to witness an assembly of brilliant minds, each contributing to the intellectual tapestry of our medical community. I am Dr. Aparna J. Nair.
And I am Dr. Navneet Ranjit, and we are hosting this session today. Now, before we delve into the rich array of topics our esteemed doctors have prepared for us, I invite you to join me in expressing our sincere appreciation to the collective efforts that make events like these possible. The commitment and passion of the medical community are truly awe-inspiring. It is an honor to be among such dedicated professionals.
Without further ado, let us embark on a journey through the fascinating realms of research and practice. Our first speaker is no stranger to the pursuit of excellence in healthcare. Dr. Gauri Shankar Nair, Senior Consultant Radiologist, Hind Labs, MRI, Kottayam. Our distinguished guest will be shedding light on role of MRI in bladder cancer. We welcome you, sir. Now, I would like to extend my warmest welcome to Dr. Vinod KV, Consultant Urologist, SK Hospital, Trivandrum. Dr. Suryaprakash Wadi, Consultant Urologist, Laparoscopic, Robotic and Transplant Surgeon, Yashoda Hospital, Hyderabad. Dr. Somsharan Bidkeri, Consultant Interventional Radiology, Caritas Institute of Medical Science, to chair the session. Please join me in welcoming these doctors to the stage.
Good morning, everyone. First of all, let me thank Bud sir and the organizers of the CME for inviting me to present before such a learned community. The topic assigned to me is MR imaging in carcinoma of urinary bladder. Recently, there has been a lot of staging systems, classification systems, which have come up in MR imaging of malignancies of the different parts of the abdomen, like LIRADS, ORADS, VRADS, PIRADS, etc. I've been practicing MRI or reporting MRI for over 20 years, but when we were studying, all these things were not in place. Now recently, like latest lot of classifications have come up. Since I am the first speaker, I have to delve through the basics of the carcinoma bladder. I will just browse through the basics of carcinoma bladder. A few facts, it is the most common tumor of the urinary system and 10th most common tumor cancer in women. It's 4 times more common in men than in women. Mostly 95% of carcinomas of urinary bladders are urothelial carcinomas, which are classified by HSCC. We are concerned with this particular version of the carcinoma bladder only, HSCC classification. Before coming into MR imaging of carcinoma of bladder, we should know that anatomy of the bladder wall, which is the innermost mucosa, the muscularis propria, which is the most important segment as far as radiologists are concerned, as well as clinicians. That is the detrusor muscle and outermost serosa with the perivesical fat. Now, assessment of the detrusor muscle is the most important thing in imaging of carcinoma bladder, which is essential for staging, management, as well as prognostication of bladder cancer. The staging of bladder cancer, which can be divided into two, which is muscle invasive and non-muscle invasive, T1 to TA, TIS, T1 and T1 is still lamina propria, From T2A onwards, there is invasion of the detrusor muscle. But in diverticular, since there is no detrusor muscle, it will go from T1 to T3. Staging in diverticular is difficult by imaging. The lymphatic spread of bladder cancer also depends on the detrusor muscle invasion. If there is no detrusor muscle invasion, there is superficial tumors rarely spread to the local nodes. When it is more, the chances of lymphatic spread is more. If there is a single node, it is N1, multiple nodes N2, that is regional nodes. Common iliac nodes will make it N3 and paraiotic nodes will make it distant metastasis. So the purpose of treatment, it is either non-muscle invasive or muscle invasive. That is, non-muscle invasive is TA, TIS and T1. Muscle invasive is T2 and above. As all the audience must be knowing, the first line treatment is NMI BC, is transurethral resection of bladder tumor with either BCG or not BCG. MIBC requires radical cystectomy. So this is the most important point in MRI of carcinoma bladder. The traditional staging tools, that is the clinical examination, cystoscopy and TURBT. But there is a lot of drawbacks for the traditional methods because of the inadequate biopsy. There may be false negative in relation to detrusor muscle invasion, and mostly it is subjective also. It all depends on the experience of the doctor also. So there may be understaging, and incomplete tumor resection is always associated with more chances of recurrence. So, and bladder carcinoma, as we know, it is a highly economically, it costs a lot for the treatment, and the results are generally poor. 5-year survival is relatively poor. Now coming to the main portion of the topic, that is the multiparametric MRI. Now this is currently the ideal modality for T staging of bladder cancer. We can use either 1.5 Tesla or higher, that is 3 Tesla, that is standard for evaluation of the multiparametric MRI of urinary bladder. It is not invasive, so multi-channel phased array coil is enough. There is no need for if it is an ultrasound. Transurethral ultrasound may be very helpful in assessing detrusor muscle invasion, but this is not invasive compared to transurethral ultrasound. The 3 sequences which are used are the T2 diffusion weighted and dynamic contrast enhanced imaging sequences, which are the key components of the examination and evaluation of bladder cancer. Now the main component is the VRAD scoring. It is proposed by the European Association of Radiology in 2018. This is basically a staging classification which tries to provide information regarding detrusor muscle infiltration. So while the MRI is very important in a bladder wall assessment, we have to know that bladder wall stratification cannot be identified on MRI. We can only identify the T2 hypointence detrusor muscle lining. Muscularis propria is only identified, the rest of the layers cannot be identified. So this is the disadvantage of any imaging modality. So this is a T2 weighted image showing the detrusor muscle lining of the urinary bladder. Now while doing MRI, the bladder should be adequately distended also. So if there is inadequate distension, there may be folds in the bladder wall which may give rise to false positive results. The second sequence is the diffusion weighted image. Diffusion weighted image requires a high B value diffusion weighted images, 800 or 1000, but very high values like PIRADS, for PIRAD scoring 1400 B value is required. That is not required for VRAD scoring. And this is the ADC map of the corresponding diffusion images. And in dynamic contrast enhanced imaging, the most important factor to know is the detrusor muscle will show only delayed persistent enhancement. Early enhancement is confined to carcinoma bladder. So if there is a mass lesion which shows early enhancement, and if there is muscle infiltration, that muscle will show early infiltration, early enhancement. Otherwise, muscle will only show delayed enhancement. Now, this is how VRADS is scored based on T2 diffusion dynamic contrast enhanced imaging, DWI, that is diffusion, and the corresponding ADC map. It is very easier to score VRADS 1 and VRADS 2 lesions, which are either like small lesions with stalk with hyperintense inner layer. That is, if it is less than 1 centimeter, that is T2. Now, T2 is known as the structural component of VRADS, that is structural, and diffusion and dynamic contrast enhancement provides functional information. Those two are the functional component of the VRADS scoring. And always, if there is discordance between T2 diffusion and dynamic contrast, we should take DCE and DWI as the primary sequences in comparison to T2, because there is in T2 there is a chance of overstaging of the bladder tumors. Now, VRADS 3 is the difficult part where we it is an equivocal score. VRADS 1 and VRADS 2. VRADS 1 and VRADS 2, there is no muscle infiltration, but VRADS 3 is equivocal. But 2/3 of tumors in VRADS 3 category will have muscle infiltration in pathological studies. VRADS 4 shows muscle infiltration, and VRADS 5 will show perivesical infiltration. Now, this was the same thing which I covered. So, if it is less than 1 centimeter tumor, it is VRADS 1, and if it is muscle infiltration, VRADS 4, perivesical infiltration, VRADS 5, and VRADS 3 is the difficult category where there is no stalk and there is no interruption of the lower line of the detrusor muscle. The examples of VRADS scoring. Now, this is VRADS 1 lesion showing a less than 1 centimeter lesion without infiltration into the bladder wall. VRADS 1, and this is VRADS 2 lesion which shows a stalk. This is hyperintense on diffusion and enhancement with no definite infiltration into the bladder wall. This is VRADS 2. And VRADS 3 means it is a broad-based lesion, no stalk and no hyperintense inner line, and it is equivocal, where we don't know whether it is infiltrating into the bladder wall or not. So, when we give a VRADS 3 score, further evaluation may be needed. VRADS 4, there is obvious infiltration into the bladder wall, and VRADS 5 will have perivesical infiltration also. Now, when to do multiparametric MRI? Should be performed before TURBT. If TURBT is performed before MPMRI, there will be inflammation or the trauma related to the procedure, which may complicate the interpretation of multiparametric MRI. So, ideally before or 8 weeks after, that was given in the literature. Even I think after 2 weeks also inflammation may subside. Patient preparation should have adequate bladder distension. It should not be over distended or under distended, and we have to give this thing, preferably antiperistaltic agent is preferred. Now again I am going through the VRADS 1 to 5 scores. If it's necessary, I will go through it, the cases. This is again VRADS 1 with no less than 1 centimeter tumor. VRADS 2 with a stalk more than 1 centimeter, enhancement and diffusion restriction. This is also known as the ingium sign in diffusion weighted imaging, where there is a hyperintense superficial portion of the tumor with a stalk. When this is seen, it mostly indicates it's a T1 tumor. It won't, when we see the ingium sign on diffusion, we can assume that it is mostly a T1 tumor, then there is no muscle infiltration. And this is VRADS 3, where there is suspicion of bladder wall infiltration, but not sure, though this is an equivocal equivocal score, because in pathology it may have 2/3 bladder wall infiltration. Again the same thing. VRADS 4 onwards there is definite muscle infiltration, and VRADS 5 will have perivesical infiltration. So basically the drawbacks is one, experience is a big factor in assigning VRAD scores. I think this has come up in 2018 only, the VRAD scoring, and depending on the number of cases you see, the accuracy of the reports also will increase. I currently not much of bladder cancers are sent for multiparametric MRI now. As we see more and more cases, the accuracy will go up. And contrast in renal failure, that is another issue, but contrast is also not needed. We can do biparametric MRI also with T2 and diffusion alone. Contrast is not a must. And lesion in bladder diverticulum, mostly cystectomy may be needed. For follow-up also, multiparametric MRI may be useful. Actually, contrast may not be needed, but contrast due to the changes due to treatment, there will be early enhancement. It may resemble tumor recurrence. So biparametric MRI, that is T2 and diffusion alone, may suffice to evaluate post-treatment follow-up.
Yeah.
Thank you.
Thank you, Dr. Gavishankar. Can you come here? Any questions on this?
We can have 2 minutes for discussion. Any questions from the podium? Dr.
Gnil?
Gnil, you want to say something?
I just want to make a comment about VRAD. We are not routinely.
Can we have mic to Dr. Gnil?
Regarding VRAD, we are not using something like the PIRAD or BIRAD. We are not that much using VRAD score because one is the cost, and second we are not certain how it is going to improve our management. So particular area where it will be important is where we may go for a re-TURBT. Like if muscle is present, high grade tumor, the MRI doesn't show any definite tumor, probably we will be able to avoid a re-TURBT and proceed with the management early. So that is the area specifically where it is going to help us. So the clinical impact of VRAD score may not be that much as a PIRAD score of prostate, but definitely when we are focusing more on the non-muscle invasive entity of high-grade tumor, probably the MRI of bladder has got a great role.
Yeah, great. Because CT will give most of the information what your MRI is also giving. Here we need a histological confirmation whether T2 is involved or not. That is the main crux in treating the bladder cancer. How MRI is superior to CT in T2 staging?
Yeah, that's what the basic purpose of this thing VRADs is for assessing muscle invasion. We can only see the muscle in MRI. CT, it is not possible to definitely comment on muscle infiltration, but MRI we can. That is the most important point is we can differentiate between muscle invasive and non-muscle invasive. Only in certain cases, if we assign VRAD 3 score, that is equivocal, we don't know whether it is infiltrated. That will also have high chances of muscle infiltration. If we see the first two slides, that is the injuvum sign or narrow tumor without stalk, that's definitely non-muscle invasive. That we can definitely come. But everything depends on the experience of the reader also.
I think, but sir, last question because it's already time.
Yeah. If there is a mass at the bladder neck, based on the MRI, can we say whether it is median lobe or prostate cancer or bladder cancer?
That is another difficulty with VRAD scoring. Other tumors infiltrating into the bladder. So if it is a prostatic tumor infiltrating the bladder, basically we go by where the bulk of the tumor is, center of the tumor is. If it is more in the prostate, it will be prostatic tumor. And prostatic tumor, if it is such a big one, Mostly metastasis may also be there. In bones also we will be seeing sclerotic mets. Even otherwise, there is one drawback is in ureteric orifices and the bladder trigone, bladder neck, Virad score may not be accurate, but current studies are showing it with experience that is also we can also give good scoring. Thank you, sir.
Sir, I would like to add one more thing. You said about CT in this thing bladder tumor. As compared to CT, MR has advantage also, like we can identify the functional aspect, as sir has told about diffusion and this thing dynamic contrast. Suppose if you want to differentiate between a leiomyoma and an this thing bladder cancer. So now people are even doing MR perfusion also, MR perfusion, MR spectroscopy also in bladder lesions to identify whether they are this thing malignant. So that's one advantage of MR over CT. Obviously, if the lesion is very big, we can make out on CT. Tiny details, the functional details, the neurovascular imaging, all those things are better picked up on MR.
Thank you, Dr. Gauri, and for that
Thank
excellent
you.
talk. And we have exceeded 2 minutes. Sorry. Thank you.
Thank you.
Now I invite Dr. Janil Kumar to hand over the certificates to Dr. Gauri Shankar and to our chairpersons. Your dedication to advancing our understanding of this topic is truly commendable.
As we transition to the next segment, I invite Dr. Nivedita Suresh, Assistant Professor in Pathology, AIMS Kochi, to share insights on the topic significance of histological classification and molecular subtyping. We welcome you, ma'am. And to chair the session, we have Dr. Lili Kuti Pothan, Professor, Department of Pathology, Pushpagiri Medical College, Tiruvalla. Dr. Georgie Matthew, Professor, Department of Urology, AIMS Kochi. Dr. Chengal Varayan, Professor, Department of Urology, Madras Medical College, Chennai.
Thank you very much, Dr. Suresh Bhatt, Dr. Frederick Paul, Dr. Oni, and the entire organizing team, because the crunch of a conference is starting the conference on time. This conference is well started on time. I think we'll be finishing comfortably as a very good conference once it starts on time. I think we need a very small speaker introduction. The pathologist will be the better person to give the speaker introduction.
Good morning, everybody. The pathologist speaker is Dr. Nivedita. She is Assistant Professor in Pathology of Amrita Institute of Medical Sciences, Kochi. And she is well versed in the diagnosis of bladder tumors. And I think it will be a very interesting and enlightening talk. Over to you, Nivedita. Thank you very much.
Thank you, ma'am, and thank you to the organizers for inviting me to this talk. So the topic given to me was histology classification and molecular subtypes of bladder cancer. So bladder cancer is the 10th most common cancer worldwide and the 13th most common cause of cancer-related death. One of the major issues with bladder cancer is that it is one of the costliest cancers to treat because of its increased propensity to recur and progress. And as of now, we have limited data available to see which are the cancers that are likely to progress and which are the ones likely to recur. So the management guidelines, as everybody here sitting here knows, that it differs markedly between the different subtypes and different subgroups of cancer. So just like all the other organs, which is seeing a rapid shift towards molecular medicine and personalized medicine and individualized catering to patient needs, bladder is no different. So molecular classification has gained popularity in bladder cancers as well. So first, we'll start with the basics. The most common cancer is the urothelial carcinoma, which accounts for more than 90% of the tumors, and followed by squamous and adenocarcinomas, which together constitute less than 10%. It has always been known that the low-grade and the high-grade tumors follow different molecular pathways, and morphologically they look very different. So unlike you have an adenoma carcinoma sequence where you have a benign lesion which gains mutations over time and it progresses to a full-blown carcinoma, here it does not follow a sequential pattern, it follows two distinct pathways. So on one hand, we have the hyperplasia papillary pathway, and on the other hand, we have the dysplasia, carcinoma in situ, and the muscle invasive or the high-grade urothelial carcinoma. So the driver mutations in each are different. The passenger mutations that each acquire are also different. And morphologically too, they look different and they act different, and the response to treatment are also different. So that is one thing that makes bladder cancer different from the other tumors, that it's still the bladder, it's still the same organ, but you have two distinct pathways for pathogenesis. So on one side, you have the hyperplasia, which transforms into the low-grade papillary, high-grade papillary, the hyperplasia papillary pathway. And on the other hand, you have the carcinoma in situ and the high-grade muscle-invasive carcinoma pathway. This is how the bladder that you operate looks like on our table. So that is a gross image. You can see the papillary fronds that is invading into the lumen of the bladder. And this is a cross. This is the cross section there. And here you have that whitish area, which is the cancer that is invading into the perivesical fat. And the staging on this side, you have the infamous muscle invasive bladder cancer. And on this side is the non-muscle invasive bladder cancer. 2A, 2B is muscle invasive. 3A, 3B is microscopic and macroscopic perivesical tissue. And 4 is contiguous organs. So coming to the histology classification, I understand there is a lot of confusion regarding the terminology among many of the people sitting here. So according to the latest WHO 5th edition updates, this is the things on the entities on the right side, they are called subtypes. So whether they're called variants, divergent differentiation. So now it has been proposed by WHO that they are called subtypes. And the other one, the conventional urothelial carcinoma, they can have divergent differentiation in the form of squamous, glandular, and trophoblastic differentiation. So they are urothelial carcinoma still, but they show divergent differentiation in the form of the entities that are mentioned there. And then you have the subtypes. Most of the subtypes portend a worse prognosis than the conventional urothelial carcinoma. So they are the micropapillary, plasmacytoid, sarcomatoid, poorly differentiated, nested, giant cell rich, lipid rich, clear cell, tubular and microcystic, and lymphoepithelioma like urothelial carcinoma. So the most conclusive way to distinguish between them is the presence of a coexisting CIS or a papillary urothelial carcinoma with no morphologically similar tumor in another organ. So we constantly get requests whether IHCs can help. IHCs can be tried, and the primary organ can be suggested, but nothing conclusive can be said on IHC alone. So it's still one area where molecular classification can help. So this is where the molecular classification starts. So it was decided that the same treatment given to patients across different subgroups does not really help. That is, one size does not fit it all. So it all started in the Lund University in Sweden. They were the first who proposed molecular classification for bladder tumors, and it was kept short and simple initially. It was just divided as luminal subtype and basal subtype. And we had luminal markers like GATA3 and uroplakin on one side, and basal phenotype markers like P53, CD44, and high molecular weight cytokeratins like CK5/6 on the other side. But that has evolved into something that you can see on the other side. So now we have 5 different distinct subtypes in the muscle invasive bladder cancer group, and 3 distinct subtypes in the non-muscle invasive group. So the purpose of this was to prospectively identify the progressors, to tailor the treatment in such a way that it prevents recurrence, it prevents progression, and to assess the response to neoadjuvant chemotherapy and the immune checkpoint inhibitors. So generally speaking, all the cancers, including the bladder cancers, usually you have a driver mutation where there is gain of function mutations in the proto-oncogenes, or loss of function mutations in the tumor suppressor genes, or mutations in the DNA mismatch repair genes. So this is the classification of non-muscle invasive bladder cancers. You have 1, 2, and 3. So you have the luminal type, and 3 which has the basal type. So the mutations or the genes involved in terminal urothelial differentiation are 3 important ones. They are the FGFR3, PPAR gamma, and GATA3. So if these genes are not altered, or in other words, low-grade tumors or the luminal papillary tumors have alterations in any of these 3 genes, along with FOXA1. So as you can see in the picture, FGFR3 mutations and the newly identified TERT promoter mutations are involved in the hyperplasia papillary pathway that I mentioned first. And mutations in FGFR3 again with basal phenotype are involved in class 3 mutations. So this is the molecular classification of muscle invasive bladder cancers. You have the luminal subtype broadly, and basal subtype, and neuronal differentiation subtype. So generally speaking, luminal subtype has a favorable prognosis, and they're further classified as luminal papillary, luminal non-specified, luminal unstable. So unstable just refers to genomic instability. And you can have APOBEC signature mutations. It's genomically unstable. And the other ones consistently show FGFR3 and TERT promoter mutations. And then you have the basal squamous phenotype, and finally the neuroendocrine. So why do we need to subtype them? Because the assessment, it is basically to see who are all going to be the responders to neoadjuvant chemotherapy. It was found that basal or squamous subtype has the best response to neoadjuvant chemotherapy, and there are certain subtypes which are associated with increased response to immune checkpoint inhibitors. So there are a few morphologic correlates. The basal and squamous subtype usually have, on morphology, we see them as urothelial carcinoma with squamous differentiation and lymphoepithelioma-like carcinoma. The luminal non-specified has, or ERBB mutations are seen in micropapillary. The luminal non-specified unstable and basal phenotype have increased expression of PD-L1 receptors, and as well as in the lymphoepithelioma-like carcinoma. TERT promoter mutations can be used to distinguish between conventional and especially if you're trying to differentiate whether it's actually a neoplastic process or not. In nested variant, tubular and microcystic, sarcomatoid versus postoperative spindle cell nodule, inflammatory myofibroblastic tumor, etc. And somatic mutations in CDH1 are seen in plasmacytoid variant. So the new drug that has been developed in bladder cancer treatment is the PD-L1 inhibitor. So ideally, a T cell should be able to invade a cancer-affected cell, but there is something like a co-stimulatory molecule like PD-1 which is blocking it. So the purpose of immune check inhibitors is that to prevent that blockade. So anything more than 1% is taken as positive, and you give a combined positive score, which is a combination of tumor cells expressing membranous positivity and host immune cells that have a cytoplasmic and a membranous positivity, and you divide it by the total number of viable tumor cells. So this is another slide to show the morphologic correlate. This picture there is the micropapillary variant, which usually expresses a luminal subtype. Then you have the plasmacytoid, microcystic, as well as nested, which predominantly show a luminal subtype of molecular classification. And then you have the lymphoepithelioma-like and sarcomatoid, which express the basal phenotype. So we recently had the latest WHO 5th edition update coming. So there have been a few changes in it. So the earlier termed papillary urothelial hyperplasia and urothelial proliferation with undetermined malignant potential, together they have been clubbed and they have been put under the category of early non-invasive low-grade papillary carcinoma. A tumor with more than 5% high-grade component is diagnosed as a high-grade carcinoma, and one with less than 5% high-grade component is diagnosed as low-grade with less than 5% high-grade component. Urothelial dysplasia continues to be used as a diagnostic term for lesions that fall short of carcinoma in situ. Presence of TERT promoter mutations can help to distinguish carcinoma from non-neoplastic proliferations and establish urothelial origin. Advanced urothelial carcinoma with FGFR3 alterations may be eligible for treatment with anti-FGFR agents. Mutations in ERCC2, which is a DNA mismatch repair gene, and other DNA repair genes may determine those likely to benefit from cisplatin-based chemotherapy. Anti-HER2 therapy may be tried in non-muscle invasive bladder carcinoma to prevent recurrence, along with anti-EGFR therapy. Predictors of response to immune checkpoint inhibitors are PD-L1 expression in tumor and host immune cells, tumor mutation burden, microsatellite instability, and mismatch repair defect status. So the limitations and perspectives of molecular classification, the major caveat here is the affordability and availability of NGS platforms for molecular classification. Bladder cancers are highly heterogeneous. There is a lot of intertumor and intratumoral heterogeneity with multiple subtypes occurring within the same tumor. There are multiple subclones as well, which have limited data as to their prognostic or therapeutic significance. There are a lack of clinical trials as well. So currently, there is not enough data to suggest the use of novel therapeutic markers, but it is a highly evolving field, and we can expect many more changes to come in the coming years. So just like all the other organs, there has been a marriage between the molecular classification as well as histological classification in bladder tumors. In future, we can expect an integrated morphologic as well as a molecular subtyping report in pathology.
Thank you very much for that wonderful presentation. We were actually worried how such a huge topic is going to be covered within 12 minutes, at the same time giving information about what particular type of treatment is necessary whenever you find this. This was excellent. Only one question from a urologist perspective which I'd like to ask. Previously, there was one low grade, high grade, and intermediate grade. Now, what happened to that intermediate grade now? As it slipped into low grade or high grade, because we're seeing a lot of patients with low grade tumors who have a spread.
So, from what I've read, it's the constant complaint from clinicians that intermediate category they cannot really say how to treat it or how it's going to progress. So it was just clubbed, and they've made it into just a biennial classification with just a low grade and high grade. So it makes it easier. So we have criteria of how to diagnose high grade. So we always try to classify, and that intermediate category has been taken off. So even the malignant potential, undetermined malignant potential, all that now in the latest WHO, they have clubbed it into early non-invasive papillary carcinoma, because it was found that they eventually recur or progress and they behave just like the invasive carcinoma, and they have the same driver mutations. The molecular profiling is the same as well. So so now it is more crisp.
Exactly, that is where the molecular
grade.
profiling has given a little more information rather than the low grade, high grade, and intermediate grade.
Yes.
Yeah, a few more comments from Madam, and then Sir will take it up for a final word from the crowd as well as a few questions.
Thank you, Nivedita, for that lucid talk. It is very difficult to learn all these molecular markers and all. And urology carcinoma, before we need to diagnose only whether it was muscle invasive or non-muscle invasive. But there are so many sub-classifications coming, and latest is the molecular classification, just like that of other tumor types also. So this molecular classification is more for therapeutic response, whether the patient will respond to chemotherapy or whether they need immunotherapy and all. But I think the molecular classification is now emerging. And in the future, we'll get more insight into the molecular classification, and the pathologists will be able to help the clinicians more and more in the future. Thank you very much, Nivedita, for that.
Madam, just one question. How meticulous would your search be when we give you a sample? We see all these histologic variants like micropapillary, microcystic. How meticulous will your search be to pick up these small bit of tumor in an otherwise normal looking pure urothelial malignancy?
For someone with a lot of experience, they can, I've always noticed that they always pick up if there is a divergent differentiation or a different looking subtype, any other subtype with a worse prognosis. And we do have a few IHC markers that can help, but molecular markers are considered to be more conclusive for identification of divergent differentiation. So it is quite meticulously done.
Thank you. Now to the audience.
The question is again extension to what has been discussed. See, when you have the variant histology like micropapillary, small cell, all those things. See, what we are interested in is, see, almost all those things are worst prognosis. The percentage of urothelial malignancy, if it is more than 80%, say, it behaves like a urothelial. If it is less than that, then it behaves like the variant histology. So is it, how do you actually calculate this percentage? Or is it regularly done when you see a variant histology?
When you see a different histology, it is always done, and we always give a percentage. We look at the slide, and if you remember the slides earlier, they look different. So on our light microscopy itself, most of the time we are able to identify a different morphology, and we always quantitate it. We give the percentage of different histologic subtypes when we see them. Okay. So if it has not been given, that usually means that we did not see it.
Okay, and again, depends on how much tissue you have taken, and there are so many fallacies, I think, in this.
Tissue taken as well as how badly it is cauterized. So that is one of the things
true. That is again,
we
cauterization artifacts are also there, but even then the sampling errors and so many things are there, but still.
If it comes to us under our microscope, we look at it and we always quantify a different histology whenever it is there.
Okay.
See, madam, there is a concurrence of
opinion in among the TCGA about the muscle invasive bladder cancer on luminal basal neuronal, all those. Where do we stand in molecular subtyping in NMIBC? Non-muscle invasive.
Yeah.
And second thing, one more question is there. What is the difference between the differentiation and variant histology? Is it one and the same, or what is the newer terminology for that?
Yes. So it is no longer called variant. Variant is now used in the context of genomic alterations. So when you say FGFR3, they give you a variant, what a variant or what allele is variant. So we don't no longer use variant in histology. So what we have now is a conventional urothelial carcinoma or a urothelial carcinoma that shows divergent differentiation in the form of squamous, glandular or trophoblastic. So there you have your variants. The others like plasmacytoid, nested, they are all called subtypes now. So they are not divergent, they are just subtype. They are not conventional urothelial carcinoma, they are urothelial carcinoma subtypes. So you have divergent and subtypes and variants in molecular classification. So that is the terminology that is used now. And in NMIBC, most of them show the driver mutations as FGFR3 and TERT promoter mutations. So I have read a few articles where anti-FGFR therapy seems to have worked for them. So the main goal there is to prevent recurrence. So, and depending again, if there is a luminal papillary tumor that is showing a basal differentiation, they are likely to respond well to your conventional cisplatin-based chemotherapy. So in non-muscle invasive bladder, it is FGFR3 that has shown increased response rather than neoadjuvant chemotherapy, cisplatin-based.
Pathological discussions are always that important. We just keep going because we have the restriction of time issues also. Thank you, Dr. Dineshan and Dr. Mujib. Dr. Mujib, in fact, has put up a book on bladder cancer. One last question we'll take from Professor Satish Kurup. With that, we'll end up this session.
Only this one. When there's a field change going on, the genetic changes can be identified properly in all the areas?
No. So that is one of the main caveats of molecular classification as well, because even within the tumor that you take as one tumor, it can have subclones, it can have genetic heterogeneity. One area may show FGFR, another area may show P53. So that is one of the major caveats, a stumbling block towards directing.
So then how did you say the therapy?
They give you the percentage. If you send it to an NGS platform, they give you the percentage of the variance, or if it is predominantly showing FGFR3, how much 80% is showing FGFR3. So based on that, you can direct your treatment. Based on the
That's the reason why the resistance comes in, and after something there's no response.
There is a specific variant called luminal unstable. There is a thing called apobic signature mutations that is cited in the acetylase or something like that. So that is known to cause drug resistance. So if you identify that mutation in your molecular profiling, you can know that those patients are less likely to respond to your conventional chemo.
Thank you very much, ma'am, for that excellent thing. So with that, we can wind up the session. We can wind up the session with this. Thank you. Thank you very much. And thank you, the organizing team. And if time is running out, the mementos can be given to the presenter, and we can take our mementos from the floor also. It's not an issue.
Thank you, doctors. Our journey continues. Next topic is carcinoma in situ bladder. Now to chair this topic, I invite Dr. Renu Thomas, Senior Consultant Urologist, KIMS Hospital, Trivandrum, Dr. P. Roy John, Consultant Urologist, Apollo Athletics Hospital, Angamali. Please join me in welcoming them to the stage.
Good morning, y'all. Our next topic today is carcinoma in situ bladder. Our speaker today is Dr. Mujib Rahman. He is the head of department at Yennapoya Medical College, Karnataka. Over to Dr. Mujib Rahman.
Yeah. Good morning, everyone. Today's topic is carcinoma in situ. Carcinoma in situ. I'll be stressing more on carcinoma in situ, the what is important for the clinicians, because we have the pathologist, and it is very highly controversial topic, carcinoma in situ. When you compare to the dysplasia, in the same department, the same sample, you give it to different pathologists, there will be inter-observer variability in that. And still, as the previous discussion was the grading, there are lots of controversies in the grading. Different, like what is the percentage to be, more than 5% in the sample, we can high grade it, intermediate grade, because why they have in WHO, still they have maintained, and most of the trials, the G1, G2, G3 is still coming, is they have an explanation for that. Even the experts of the experts still are not in concurrence as far as the grading is concerned. So coming back to the CIS, sorry for the poor quality of the slides. This normal urothelium, for the PGs it will be useful. Normally from the time immemorial, we know that it's 5 to 7 layers arranged in a precise manner. We have a basal, we have a peribasal, intermediate and umbrella cells. Because this is the area where the NMIBC, where we are focusing today. So on the right side, there is uroplakin, CK20 GATA3, and GATA3 in the intermediate cells, and the basal cells where we have the CD44 and CK5 and 7. Because this will be useful in the classification as well as in the therapeutics. So coming back to the last discussion, probably Ginil and all was there in the Tata Memorial. The famous pathologist was asking why the CIS is called still a carcinoma, because we have the lots of definitions for a thing to be carcinoma. So this is carcinoma in situ. It is put in the high-grade lesion. There is a flat neoplastic proliferation, then high-grade malignant urothelial cells of variable thickness without papillary formation, and morphometrically it is similar to MIBC, and urothelial dysplasia, that is a mimicker of this, it cytologically falls short of CIS. And this can occur throughout the urinary tract, from the upper tract down into the prostatic urethra. It can be a unifocal, it can be a diffuse, multifocal, in any form it can. And you cannot sometimes see also. Then as per the current existing data, it is classified into primary, concomitant as well as the secondary. Primary de novo 1 to 3%, but most common it is concomitant with an invasive carcinoma. Then as far as the staging, in all the staging systems, it comes in CIS, PTIS, it is in the early stage. And in all the AUA and EN is considered as high risk NMIBC. Now ICDs, different ICD codings as given for the renal pelvis, the ureter, bladder, urothelium, prostatic urethra. And coming to the pathogenesis, why it is being considered as a high grade, as Madam described in the previous one, whatever is the high grade pathway for the muscle invasive or high grade bladder cancer, these mutations are seen in CIS as well as this. And you can see again the this pathway for NMIBC, luminal basal. We have the basal which is more aggressive, and P53 loss, the P retinoblastoma, this most of the CIS pathway in the MIBC track. And it's considered as a dangerous entity because risk of invasion in untreated patients is 80%, and progression rate after BCG is 50% at 5 years, and disease-specific mortality may reach up to 60%, and recurrence even hours after radical cystectomy is there, and mean interval diagnosis of CIS and progression is 5 years. And normally as coming back to the diagnosis, the clinical features, we all know that the clinical features, and urine cytology is very important. It's a valuable tool in CIS detection, and especially you all know that in the postgraduate days also we know that what all the significance of the urine cytology in, and FISH is one of the urine biomarker study that is approved by FDA. And coming to the diagnosis, cystoscopy, we have the white light cystoscopy, and most of the time we can see that erythematous mucosal patches, raised, granular or velvety, at times difficult to identify, and histopathological report gives a conclusive evidence. And EAU 2023 is the enhanced cystoscopy. All of them are saying that enhanced cystoscopy has got a definite edge over the white light cystoscopy. Even AUA is also recommending that if available, increase the detection, decrease the recurrence, and may consider NBA to increase the detection, decrease the recurrence if it is available. So this is the white light cystoscopy pic, and you might not see the CIS, And if you use the NBI, narrowband imaging, where the red light spectrum is removed, you can see the lesions better. And coming to the PDD, ultraviolet rays after intravesical installation of HAL, and it has got a better diagnostic accuracy, and during the resection you can have a complete tumor resection. And long-term clinical effectiveness as well as the progression is concerned, still there are data are controversial. And blue light versus white light transurethral resection and non-muscle invasive bladder cancer, they definitely say that all these studies show that recurrence as well as recurrence with the white light cystoscopy, so you can see the 45.4%, and in the blue light cystoscopy is 34.5%. And these have got, there's International Journal of Technology Assessment in Healthcare, PDD has got a higher sensitivity, 93% versus 65%. It has got a lower specificity, and false positivity you can see in inflammation, recent UR, and first month after intravesical BCG. Coming to the confocal laser endomoscopy for the diagnosis and high resolution imaging probe designed to provide endoscopic histological grading in real time. And you can see that fluorescein is injected in advance 1 hour before. Then later on, this is a probe histological diagnosis. And later on, you can put the probe through the scopy. And you can see the white light cystoscopy, confocal laser endoscopy, histopathological correlation. In normal, you can see that. See, this is the confocal laser endoscopy, low grade, high grade CIS. So still the conclusion is confocal laser microscopy correlates to histopathology, may enable real-time tumor grading. Flat lesions still difficult to classify like an CIS. Real-time cancer differentiation during system prognosis and disease management. As a patient can ask, why not a better available options? If it is available, why I'm not using it? As a doctor, higher cost, no improvement in 3-year recurrence rates even after enhanced cystoscopy technique. Higher cost of a new technology, better patient outcome is questionable. Now, coming to the once you take the histological sample, you give it to the pathologist, there are sub-classification of the CIS like large cell, small cell, plasmacytoid, diffuse, denuding cystitis, clinging CIS, but these doesn't have, as of now, no clinical or prognostic implications. And urothelial CIS with in situ glandular differentiation, that adenocarcinoma in situ also has been described. And you can see the pegyatoid spread, malignant isolated cell interspersed within the benign looking urothelium. So this is the low power magnification, and higher power magnification, the whole of the urothelium is involved by the malignant cells. And this, as I mentioned, the epithelial CK20 and GATA3 diffuse involving all the layers. Then immunohistochemistry, abnormal full thickness labeling of for CK20, abnormal expression of P53, all the high grade markers, immune staining is positive in CIS. But none of these markers entirely, they are not that specific or sensitive. Now, coming to the treatment of CIS, we have the standard of it has not changed over the period of years. It is still the BCG, the immune. What the TH immune enhancement that happens, it is not. It has not changed, and this is still the gold standard. And everyone knows the induction and maintenance therapy up to 2 years. The dose schedule and is almost the same, and there are different studies have come where there is a dose reduction, but still what we have studied some few years ago, it's 10 raised to that 10 million organisms should be delivered, and it depends on the quality of the company it produces, the whichever the brand you are using, and the immune genicity of the patient. The novel treatment after, because this was come when the BCG, but the Ferring company alone was producing the BCG in US, and they were not getting adequate sample. Then the people started thinking about the alternatives for the BCG, dose reduction, and for high grade only high grade you give the intravesical BCG. The other cases you give the gem dosi or other intravesical therapies. And this is a rescue treatment following BCG failure. And this is the study on sequential intravesical gemcitabine and docetaxel for the salvage treatment of NMIBC. And in this study, that 45 patients with a median follow-up of 15 months, 66% had a successful treatment at 3 months, 54% at 1 year, and 33% at 2 years. Recurrence-free survival was rate at 3 and 6 months was 89% and 82% respectively. Another one is intravesical cabazitaxel, gemcitabine, and cisplatin, and this trial that's showing that the combo therapy as well as the cabazitaxel individualized treatment, and they have compared the response rate. Then systemic pembrolizumab, as Madam said, this PDL1 and PD1. There is more in the MIBC and in the CIC group, and this PD1 and PDL1 blockade maintains the function of the effector T cells, high PD1 expression with progression and recurrence after BCG therapy, and FDA approval based on the keynote 057 in 2020 for BCG unresponsive NMIBC with this is intravesical pembrolizumab. The pembrolizumab monotherapy for the treatment of high-risk NMIBC cancer, keynote 057, 101 patients, median duration complete response in 1.5 years, and 20% sustained response lasting 1 year, and progression-free survival of 83% at 1 year. Then intravesical pembrolizumab. This again, this doesn't have the, as of I know, it doesn't have the approval. Then first line in human intravesical delivery pembrolizumab identify immune activation in bladder cancer unresponsive to BCG. And in this trial, there is one patient expired, myasthenia gravis, potentially related to the treatment. Then the other one is gene therapy, nadofaragene firadenovec. This is like intravesical BCG. You are giving the bacteria. This is the virus. This is the first gene therapy approved for bladder cancer. The recombinant adenovirus vector-based gene therapy, delivering what they are trying to do is this interleukin alpha 2b of these viral vectors infect the malignant cells and they start producing the interleukin alpha 2b and killing the cancer cells. FDA approval for BCG unresponsive NMIBC with CIS in December 16th, 2022. So this is the pamphlet from the company. And the other one is the TAR-200 intravesical drug delivery system releases gemcitabine in a controlled continuous manner. Normally you know that whenever we put the intravesical therapy, it is for a 1 year, 1 hour is the dwell time. In this, the 2/3 of the drug is maintained for at least 2 weeks. So the dosing also 3 weeks. So 0 you start, then the 3rd week you start, till the two weeks you give that the dwell time in this. And the device is introduced through the 18 French catheter, and after that it is removed through cystoscopy. And this is the size of the silicon tube that is going, and the drug is inside that. It's like an osmotic pump and has got fine orifices. This drug will be delivered in a continuous manner and not much of an irritative voiding symptom for the patient during the trial. Then Sunrise study, TAR-200 with sertolizumab, the systemic PD-1 inhibitor in BCG unresponsive NMIBC, complete response with either TAR-200. They have again combined and individual they have gauged in the study. Then other electromotive therapy and hypothermic intravesical therapy, these are all in the textbook, and how far it's in the clinical utility of this. Increase the permeability of the drugs into the urothelium, toxicity against the malignant, increase the toxicity against the malignant cells, and hyperactivate the immune system. Mitomycin is heated to 42 degrees prior to being instilled, then recirculated for 60 minutes. And this is again the studies showing in BCG unresponsive, recurrence free rate 53% and 35% at 1 and 2 years. This is how it is being done.
Once this is done, you will see that the default heat setting is 43 degrees centigrade and the treatment time is 60 minutes. Once the machine
Dr.
is
Mujib,
switched
we
on
have
and
to
these
rush
default
through it,
settings have been
otherwise
noted,
we'll
you
exceed
can
the time
invite
limit.
the patient into the room, tip pointing upwards, slowly
Will be the
and
last
gently
slide.
into the urethra. The white line that runs the full length of the catheter should be face down, and inflate the catheter balloon with 5 to 10 milliliters of water and then gently pull the catheter out until it is stopped by the balloon. Once the urine has been drained from the bladder, connect the catheter to the disposable set. To do this, remove the red and clear caps from the drainage and installation ports on the disposable set. Connect the large aspiration port of the catheter to the blue installation port of the disposable set, and connect the small irrigation port of the catheter to the red drainage port of the disposable set. This will close the circuit.
Then what you do is, this is the heated up to 42 degrees centigrade and given it and dwell time of 1 hour is given.
Clicks the begin button to switch up.
In conclusion, there is a growing literature on the comprehensive molecular classification of the bladder cancer, including the NMIBC, and mutation landscape, transcriptomic and proteomic signatures have a translational relevance to better classification, prognosis and selection of efficacious therapeutic target, unlike a blanket treatment of a chemotherapy or immunotherapy. Then now what we are coming is, there's a immediately after the diagnosis, you have which the target has to be aimed at which histological subtype, and urine cytology is important, and accurate staging of the bladder cancer is critical, and TURBT and VIRADS in conjunction improves the bladder cancer staging, and optical technologies improve sensitivity, and dynamic contrast enhancement MRI with photodynamic therapy TUR has got a potential benefit as a diagnostic approach, and intravesical BCG installation with maintenance remain the first line in CIS, and intravesical device assisted therapies effective in BCG naive or BCG unresponsive CIS, and Keynote 057 phase 2 trial pembrolizumab in high risk BCG unresponsive patients, and mostly with the CIS open door to a new treatment option. Thank you very much.
Thank you, Dr. Mujib. You have covered it extensively. Almost all treatment modalities, including the most recent advances of CIS, has been in that to say that you have covered the treatment of the NMIBC itself, all the treatment modalities available. So, what is the scenario in our country? What is practically feasible in our country, and which of these modern modalities are available in our country?
Earlier, historically, we have the white lights, and now Olympus has come and Spice Stores has come. Narrowband imaging. These two will be at present practical in our country. And most of the patients we are giving a blanket, it's a BCG, intravesical BCG.
That is regarding diagnostic aspect, the NBI and the fluorescent cystoscopy itself. But regarding the therapy, everybody can deliver BCG intravesical therapy. But the question is, when it becomes unresponsive to BCG, what is practically possible? We can offer cystectomy, but
now most of them, I think, gemdosi they are giving 1 gram gem, 37.5 docetaxel. That is alkalinized if it's required on the previous night. Then you give it. Installation is almost monthly. It is induction and maintenance. The trial is going on.
Thank you, Dr. Mujib, for the vivid presentation. Good to see that new drugs are giving good results so that we can spare the bladder as well. Since we are running short of time, we can have 1 or 2 questions from the audience.
Thank you, Dr. Mujib. With that, we conclude this session. Thank you. Thank you, South Zone, for this opportunity.
As we proceed to the next phase of our CME, to unravel the intricacies of recent advances in TURBT, I request Dr. Mujib Rahman, Department of Urology, Yenapoya Medical College, Dr. Vijay Radhakrishnan, Senior Consultant, Urology, Masleva MedCity, Pala, Dr. Abhilash Anthony, Senior Consultant, Department of Urology, Chaitanya Hospital, Kannur, to chair the session.
Good morning all. Dr. Sandeep is at present working with Aster Medicity. He is a known expert of lacing the tissue. prostate is his specialty, and we'll see what he has to offer to the bladder today.
To my seniors and my dear friends, the TURBT is a TURBT, transurethral resection of bladder tumor, is considered a gold standard procedure since 1950s. This procedure was first described by Stern and McCarthy in 1931. But this procedure uses a method of incise and scattering technique. So as a surgeons, what we have learned is whenever there is a tumor or cancer, what we need to remove it completely. So this is a complete contradiction to the usual oncological principle. This procedure has got that inherent demerit. Now, we thought about something better than a conventional TURBT, because of the primary reason for that is that this malignancy for bladder cancer was notorious for its high recurrence rates, primarily propelled by the reasons other. One is during the primary resection there will be undetected tumors and there might be incomplete resection, and tumor seeding due to the transurethral resection of bladder. We are scattering the tumor so that there will be tumor seeding to the multiple parts of the bladder, and also proposed mechanism is field effect. So the high frequency of recurrence often necessitates retreatment, resulting in a huge financial burden that is among the highest of all cancers. So pointing on this part actually already covered beautifully by Dr. Mujib. Basically, the point on the first thing, we are missing a lot of cancers during our primary resection. So for this, the urologists world over developed initially the enhanced cystoscopy. Whatever we studied most about this fluorescent cystoscopy. Dr. Mujib has beautifully shown a video about the fluorescent cystoscopy. Fluorescent cystoscopy is, as a commonly termed as blue light cystoscopy. This is a very validated technique for enhanced visualization. It involves intravesical installation of a photosensitizing agent called hexaaminolevulinate 1 hour prior to the planned resection. This molecule is absorbed preferentially by malignant cells, and the tumor cells will show fluorescence red with its distinct demarcation when illuminated by blue-violet light. This has consistently demonstrated a superior tumor detection rate and lower recurrence rate. The flip side is that this thing is not available in India. This molecule is not marketed in India, first thing. Second thing, it is very difficult. We have to instill the bladder 1 hour prior to the procedure with this. So practically it becomes a very difficult procedure to do in our systems. So now we have another not better in terms of the detection rate, but it is a very easily doable enhanced cystoscopy. It's available with the Olympus and Calso systems, which is most of the hospitals has got these systems now. So this narrowband imaging gives an improved tumor visualization that avoids preoperative bladder installation of a photosensitizing agent. This procedure relies on hypervascular nature of bladder cancer to aid in differentiation of normal urothelium. This uses an optical filters to reduce light to blue and green components, which are preferentially absorbed by the hemoglobin in neoplastic cells. enhanced contrast between vascularized cancer tissue and normal urothelium. So this is a no NBA picture. There is not much suspicion about this picture. So when you put the NBA mode, it becomes a very really suspicious area. So this NBA can actually increase the detection rates of the CAS lesions, small lesions, which could be undetected by normal white light cystoscopy. So when there are a lot of outcome comparison to the white light cystoscopy. So there was a recent meta-analysis which shown NBA had an increased sensitivity over white light cystoscopy to the tune of 94% versus 85% with similar specificity. So that false negative rates are also very less. For CAS detection, the sensitivity and specificity of NBA were 93% and 77% respectively. These rates are almost equivalent to the fluorescence cystoscopy. So it becomes very easy to integrate into our practice to put NBA during our cystoscopy procedures. So now, the first part was about how to detect more do not miss any tumors. Next is to how to remove the tumors completely. So this was a technique of en-bloc TURBT. I think most of us are doing now en-bloc TURBT. This was first described by Quada et al. In Journal of Urology 1997. They have published an article, a case report. The en-bloc TURBT allows for a high quality transurethral resection and a precise pathological analysis by a more accurate and controlled resection, which can reduce the incidence of complications first of all. Next is providing a better sample orientation for precise histopathological analysis. Third is obtaining the reducer in the resection if necessary. Also very easy with this technique. So technique is very simple. It involves a circumferential incision is made on the mucosa around the tumor, around 5 to 10 millimeter from the tumor edge. The dissection is carried out. This can be done using either laser fiber or normal TUR loop. I will come to the laser en-bloc TURBT later. The dissection is carried out in the macroscopically normal mucosa and extended through the submucosal and muscular layer. The muscular fibers are divided cautiously from the periphery to the center of the tumor, and we can also use hydrodissection technique to improve that dissection. Basically, hydrodissection technique is commonly employed by the gastroenterologist for the polypectomy and all. That is, you instill some element of normal saline into the base of the tumor so that it gets elevated, so that you get planes. You can easily make out the planes between the tumor and muscle and all. So this is a small video on en-bloc laser TURBT. This I have done using thulium fiber laser. Nowadays, thulium fiber laser is available in most of the centers. So it has got it's a beautiful laser, basically thulium fiber laser, because it has got not much vibratory action like Holmium laser, and good planes you can develop with that. First step is to demarcate the lesion around 5 mm to 10 mm away from the primary tumor margin, making a incision line. You could easily make that detrusor muscle, you can make out very easily when we use the thulium fiber laser in a low power mode. You do it around it. So this is tumor is getting enucleated, and you could clearly see the detrusor fibers. tumor is completely enucleated, you could like very clearly see the detrusor fibers. So, and as we are using a low power mode, the thermal damage artifact to the tissue is very less. So this was the lesion with the muscle intact, detrusor muscle beneath it. Patient was discharged on post-op day 2 because we don't need irrigation for this patient and all. Another case is a 74-year-old male with hematuria and obstructive LEDs. CT IVU showed 1.9 into 1.1 into 1 centimeter, enhancing polypoidal lesion. So this was a cystoscopy. Cystoscopy. It was a somewhat large lesion which was very close to the ureteric orifice. So we thought we will put a stent first of all. Then we start laser en bloc TURBT. First step is to making a resection line. So en bloc laser TURBT, the Nd:YAG laser, KTP laser were used initially, but the limitation of these lasers were basically the less tissue was available for pathological examination because it has got a lot of thermal artifact. Once the holmium has come, the people started doing en bloc TURBT using holmium laser because it will get a sufficient laser for sufficient tissue for histopathological examination. The lasers most suitable for this procedure will be holmium laser, normal thulium laser or thulium fiber laser, because all these has got a penetration depth of holmium has got a penetration depth of 0.4 mm and rest thulium fiber laser, thulium laser 0.2 mm. EBRT, the biggest limitation or limitation will be in general 30% of patients may not be suitable for en bloc TURBT due to the tumor size or location. Because tumors on anterior wall or dome will be very difficult to like remove using en bloc methods, and if the size of the tumor is more than 4 cm also, it will be very difficult to retrieve the specimen after removing the taking it en bloc, but it is very difficult to remove it to wash it out if the size of the tumor is more. Regarding the oncological results, EBRT versus conventional outcomes, all the outcomes are in favor of EBRT over the conventional TURBT. On the perioperative parameters were significantly superior to the in the EBRT group. Like bladder perfusion will be very less because it's a very controlled method. This unlike TURBT, it is a very controlled surgery. And the obturator nerve reflex risk is very low, and hospitalization and catheterization time is also low. Recurrence rate at 2 years was significantly lower. And all these meta-analyses have proven that. Now, you'll ask me whether which energy is better, laser, monopolar or bipolar. Oncological results all are same, but in laser en bloc resections, there is no incidence of obturator nerve reflex. This is the biggest advantage of laser removal of laser en bloc. But biggest actually seal in this procedure is the specimen retrieval after EBRT. So it is inherently unable to extract large en bloc specimen. So less than 3 cm evacuation can be done through the resectoscope sheath or by using a standard Ehrlich evacuator, grasper, baskets and all. Retrieval of larger specimen like 3 to 4 cm specimens is challenging. What we can do is a careful division of the tumor, allowing for a sub en bloc removal. You can also retrieve somewhat bigger tumors. You can retrieve using a nephroscope and grasper, and you can also use a smaller endocatch bags to retrieve specimen. Next is advanced is now coming up is a pneumocystoscopy. Pneumocystoscopy has been available. It was used in earlier years, but it was not of use in. Now some group have started using pneumocystoscopy, that means carbon dioxide cystoscopy, to remove tumors in the dome, and that will be also muscle invasive, not muscle invasive tumors, just like a partial cystectomy is done. In this, they had developed a larger resectoscope with a large working channel through which laparoscopic instruments could be placed, and using ultrasound, scalpel and all, you can do a transurethral partial cystectomy. They are termed this as a super transurethral resection of bladder tumor, or super TURBT. Super TURBT advantages will be as utilization of carbon dioxide is used to fill the bladder. It allows for the removal of the full thickness of the bladder wall and even tissues outside the bladder wall without the risk of fluid extravasation. And as ultrasonic scalpel is used, it gives a reasonable mechanical energy for the resection of bladder tumor, providing a more precise and controlled approach, and there will be minimal bleeding during resection, and there is no requirement of lavage fluid. This eliminates the risk of tumor spread and planting. So this is the scope they have developed. This is a Chinese group. They had presented their data in the American Urology meeting in 2021, and it has been published in the AUA in supplements. So to conclude with, TURBT remains the gold standard because it could be used in all the situations in the bladder tumor. And the conventional TURBT still has got limitations, which include suboptimal pathological assessment, perioperative morbidities, and in particular operative nerve reflex and bladder perforation and high recurrence rates. Modifications in resection technique like en-bloc TURBT and enhanced cystoscopy in the form of PDD and NBA have demonstrated a promising results to address some of these inherent limitations of conventional TURBT for diagnosis and treatment of bladder cancer. The pneumocystoscopic technique like super TURBT appears to be very promising for localized muscle invasive bladder cancer. With this, I am concluding my talk. Thank you.
Excellent presentation, and especially the super TURBT. But the problem with the en-bloc dissection, no, small tumors, it's definitely good. Otherwise, large tumors, it's like any other TURBT. The advantage with the en-bloc dissection, what I have seen is that for the pathologist, when they get a specimen, no, you would have done the TURBT and see the piecemeal what you give. You don't know what is the apex, what is the base. And second thing is the hydro distension. It all depends on where you inject the water. Like in the gastro, you said, no, it has to be in the muscle. If it extravasate in the subcutaneous plane, the resection again becomes like superficial. It can't go down. These are all the two things. And then the retrieval of the large en-bloc tumors.
Retrieval is a big problem in en-bloc resections, basically. Bigger tumors, I think we could go for a division, a careful division of the tumor, and a sub-en-bloc resection will be also better than a normal TURBT, I think.
Is it possible to do in broad-based lesions or only in papillary lesions?
Broad-based lesions also we can, actually broad-based lesions we have to demarcate the lesion properly, otherwise the en-bloc will be difficult. So in broad-based lesion, mostly I have found that tumors will be a bit hard also. So in a normal case, even 4 or 5 cm also, the bladder tumor appears to be a very soft tumor. When we wash or take with the grasper, it comes out easily. But in broad-based tumors, mostly the tumors are a bit hard. It won't come out easily. There are some instances where we done a big broad-based lesion around 5 cm, and I have to moslate it and take out.
And the second thing is bed biopsy taking in this, and second re-resection TURBTs. So these are all what is any other study on en-bloc with a re-resection? What is the positivity rate of the
En-bloc resections are EBRT is characterized by a low recurrence rates in all the studies. All the meta-analyses have shown that there is a low recurrence in EBRT.
I have one question now. Are there any guidelines on immediate intravesical therapy post en-bloc TURBT? Because the possibility of seeding is not zero exactly, right? Especially when you just said you did a suboptimal 2-stage or something like that.
I think you can do the intravesical therapy just like in a conventional TURBT.
Okay, any guidelines on that? Any published guidelines on that?
I'm not sure about that, but I think the perforation risk will be very less. So I think it could be used more than a conventional TURBT. because you are seeing the muscles, muscle walls and all, layers and all. So the risk of having a subclinical perforation and all are very less with the en-bloc TURBT. In all the series, the perforation rates have been considerably less compared to the conventional TURBT. All the meta-analyses have proven that. So I think the giving a like intravesical therapy post procedure is will be very like logical, and it will be very safe as well.
If there are no more questions, thank you, Dr. Sandeep, for that wonderful presentation. Thank you, the organizing team, for this chance.
Thank you, sir. Esteemed guests, delegates, and representatives, we are thrilled to provide you with a glimpse into the heart of our healthcare services. Join us as we explore the dedicated professionals, cutting-edge technology, compassionate care that defines our commitment towards well-being.
The year 1962 witnessed the landmark in the healthcare sector of Central Travancore when Bishop Mar Thomas Tharayil laid foundation to the establishment of Caritas Hospital at Tellagam, Kottayam. Staying true to its founding ideals of charity and pursuit of excellence, Caritas soon outgrew its name in the treatment of snakebite victims and branched out into providing care in multiple other specialties.
Welcome to Caritas Center of Excellence in Urology, where cutting-edge care meets compassionate expertise. At Caritas Center of Excellence in Urology, with a legacy spanning decades, our accomplished team of urologists, supported by skilled staff, stands ready to address all facets of urological care. From precise diagnostics to a range of treatments, your well-being is our priority. We navigate the vast landscape of urological care with precision. From diagnostics to a palette of treatments, we delicately address the conditions. We are on par with international standards of treatment for the entire spectrum of urological procedures for stone diseases, prostate diseases, congenital disorders, andrological diseases, and urological malignancies. Our services include endoscopic procedures with thulium laser, advanced laparoscopic reconstructive and uro-oncological procedures, and renal transplant. Our support goes beyond borders. People from different corners of the globe choose Caritas for urology and urologic oncology treatment. We take pride in being known as the best urology department in Kerala, welcoming patients from far and wide.
Now, it's time for the formal inauguration of our CME, Bladder Cancer Update 2024. I welcome Dr. Janal Kumar, President, Association of Southern Urologists; Reverend Dr. Binu Kunit, Director, Caritas Hospital and Institute of Health Sciences; Dr. Surya Prakash, Secretary, Association of Southern Urologists; Professor Dr. Suresh Bhatt, Organizing Chairman, Bladder Cancer Update 2024; Dr. Sujendra Prasad Unni, Organizing Secretary, Bladder Cancer Update 2024; Dr. Frederick Paul, ASU Council Member from Kerala, to the dais. As we commence this auspicious occasion with divine blessings and the lamp lighting ceremony, we will begin with prayer. May I please request the entire gathering to rise for the prayer.
കാരുണ്യവാനായ
Thank you, ladies and gentlemen. Now, you may please take your seats.
I welcome Professor Dr. Suresh Bhatt, Organizing Chairman, Bladder Cancer Update 2024, Senior Consultant, Department of Urology at Caritas, and he was also the former Professor and HOD, Department of Urology, Government Medical College, Kottayam. Thank you, sir.
Now I invite Dr. Jinal Kumar, President, Association of Southern Urologists, for the presidential address.
Good morning, everyone. A happy new year to all of you. I welcome you all to this updates on bladder cancer. The law demands that we update ourselves regularly so that we can give the correct and most appropriate treatment to our patients. CMEs are done to learn, to relearn, and to unlearn what have we learned. Bladder cancer is not a common disease. Today we are here to update ourselves on bladder cancer. Dr. Ginil Kumar, President of ASU, is a well-known robotic surgeon and internationally acclaimed uro-oncologist. He is a passionate researcher as well. Some of his papers in international journals are stellar and stand out in cancer field. A hearty welcome to you, sir. Reverend Father Dr. Binu Kunnath, the Director of Caritas Institute of Medical Science, is a big man with a very big heart, eager to serve the needy and the poor. His motto has been perform, reform, and transform, and this has taken Caritas to a very great height. The string of awards which Caritas got in the past few years under his guidance, like the old Onida ad, owner's pride and neighbor's envy. The changes that are happening in this direction are palpable and visible. A very cordial welcome to you, Father. Dr. Surya Prakash, Secretary of the ASU, is also a very prominent robotic surgeon based in Hyderabad, a profound teacher and a guide. He is known for his innovations. A fraternal welcome to you, sir. Dr. Frederick Paul is a very skilled surgeon. He was my right hand while I was working in Medical College, Kottayam. He is an ASC member now and representing Kerala. He has all the four qualities of a very good surgeon. A disciplinarian to the core. A hearty welcome to you, sir. Dr. Suchindra Unni is the organizing secretary and the backbone of the CME. There are no words to describe him. A blissful welcome to you, Unni. I welcome my guru, my mentor, and the repository of urological knowledge, Professor Appu Thomas, who is sitting there. I also welcome ASU President-elect Dr. Changalvarayan, Professor MMC, Chennai, Dr. Jagdishwaran, Council Member from Hyderabad, and all the other faculty members who have come from all the other states of South India. I also welcome other urology faculty, non-urology faculty, including Dr. Gauri Shankar, Dr. Lilikutti, Dr. Nivedita, and radiation oncologist Dr. Flowerlit, Dr. Jenny Joseph from Caritas, and medical oncologist Dr. Unni S. Pillai. And a very red carpet welcome to all the students who have come from various parts of South India. I extend a joyful welcome to all the staff of Caritas. Thank you.
Now I invite Dr. Jinal Kumar, President, Association of Southern Urologists, for the presidential address.
Thank you. Respected Reverend Father Dr. Binu Kunnath, Dr. Suresh Bhatt, the organizing secretary, then my teachers, Dr. Appu Thomas, Dr. Sanjeevan, Dr. Dinesh, other members of ASU, my secretary, Surya Prakash, Vice President Changalvarayanji, and Jagdish, organizing team. It's a great privilege for me to stand in front of my home crowd and talk to you in front of my teachers who has curated me to reach this height, and my friends who supported me to hold this position. On behalf of ASU, let me convey our sincere gratitude to Caritas Hospital and its director and the entire team for accepting our council member program of Kerala and organizing in such an enviable form and beyond our expectations. The organization aspect, I have to congratulate Dr. Suresh Bhatt, who was associating with me initially in curating the program. But how it has turned out to be today is, as you see, is perfect. Bladder cancer, the subject he selected is very important. As you know, the urology doctors, we face a set of cancers which are quite different from other cancers. We have got a renal cancer doesn't respond to chemotherapy. Then we have got a prostate cancer is a confusion for the pathologist and the treating doctor, how to report and how to treat. And we have a bladder cancer which responds to immunological treatment rather than rest of the treatment. It is sensitive to chemotherapy, radiotherapy, immunotherapy and surgery, everything, and we don't know how to treat it. And stage wise, we treat bladder cancer in the initial stage without removing the organ, and we try to preserve the bladder. So this is quite different from how we treat other malignancies in the body. And there are a lot of advance that has happened in this decade. Last decade, I will say, was for the prostate and the bladder cancer and kidney for the kidney and prostate. But this decade seems to be of bladder cancer because a lot of evolution is happening in the management of bladder cancer. It's the right time to select this topic and update. And the way in which the program is curated is perfect for that. So I congratulate Suresh Bhatt sir and team for the excellent program. Now, I want to just get your attention to few of the programs that ASU is very particular with, and you have to associate and you have to support it and you have to be a part of it. One is the JASU, or our journal, that is Journal of ASU, that is coming up, and first issue we are planning to get out in this month, and I hope that it will be a great success, because the problem what we face is we cannot publish without giving a huge money when it is coming from the West. We have our own journal where we can publish without giving publication charges, and this has to be utilized by our community and our others who will be eagerly looking for publishing in it. So that is one thing I want to highlight. We are planning to have a group for supporting, and it is evolving into a group supporting the postgraduates to improve the research in our community. The few other things are elections are coming. It is our responsibility to select the best people for taking up the programs for tomorrow. And the next conference that is coming up in Madurai in the third week of July, we have to be a part of it and actively promote it, and we have to support the program in whatever way we can. With these few words, and expressing once again my gratitude to Caritas Hospital and the urology team there, let me stop my words. Thank you very much.
Thank you, sir. Now I request Reverend Father Dr. Binu Kunnat, who has been a constant source of inspiration and support for us, right from the concept of the idea of the CME. He has continued to support us in spite of his busy schedule. I invite Father for the lamp lighting and the inaugural address.
Very good morning. Respected Dr. Jinil Kumar, President of ASU, respected dignitaries even on the dais. First of all, wish you a wonderful new year 2024. And Caritas is so excited to collaborate with ASU for its wonderful CME in the year of 2024. Of course, doctors running behind the patients, looking after, caring them, loving them. As we study in the MBBS or PG, there will be a therapeutic touch that really heals the patient. Of course, the Bladder Cancer Update 2024, one of the initiative by the ASU and Caritas Urology Department. And so we are so glad to say that Caritas Urology Department is happy to collaborate with ASU. Normally we do conduct CME in every Sundays in this particular hall, in different perspectives, different departments. From the organizers, I heard that this is the one of the best CMEs is happening in Caritas with the ASU because of the representatives from the different part of the country, the teachers, the gurus, all the urologists dealing with the patients, talking the same subjects in different perspectives, different angles. How do we relate? How do we give the best quality care with affordable cost? This is what we mean in this 2024, the new era, new centuries. Of course, people are moving around the hospitals, different part of the countries with a lot of problems. But as a healthcare providers, we are giving the best care, the quality care with affordable cost. Of course, in Caritas, we have the best team by Dr. Albert, Dr. Suresh Bhatt, Dr. Bijoy, Dr. S.P. Unni, Dr. Arun, Dr. Naveen. And as we have seen the video, Caritas Hospital is almost completing 62 years. One of the oldest hospitals in Kerala. Started in 62 for the snakes bite and the pregnant woman. But right now, we have 250 doctors are working in Caritas hospitals with all the departments, including the nuclear medicine and therapy. Of course, we need the updates, we need the corrective measures and actions, new studies. At the same time, I do communicate with everyone, every conclave, every healthcare workers. New G or 5G. We are looking for everything in the mobile, maybe in the Google. If you have any doubts, we always search in the Google. And everybody is right now thinking of the new technologies. While the patients entering the doctor's OP, the doctor should know what's the real status, the vitals, fever, height, weight, without touching the patients. This is what the doctors, the new healthcare leaders want to know everything. Everything should be technologically improvised. More than that, when the patient enters the hospital, when the patient enters the ICU, the door itself scanning the patient, the vitals, the fever, the height, the weight, everything. It's possible right now. Even everybody is looking for the robotic surgeries, new technologies, new interventions. But I would say, of course, we need. These are the need of the hours. We should run between technologies. But my dear healthcare, my dear friends, don't forget that we should not lose the humane touch. Once we lose the humane touch, we will be out of place. This is what I experienced from my few years in the Caritas hospital. I live in Ernakulam district. There's a small PHC is nearby our home, where my 85 years of my father used to go there, government sector. When he feels a pain or fever, he used to run to the PHC to meet the doctor there. When he enters in the OPD, the doctor smiles. In Malayalam, Thomas Yata Karibaru. He listens the patients, looking at his face, looking at his eyes, empathizingly, emotionally, he is attaching to the patients. After listening whatever the patients needs to tell, the last word the doctor used to say, Thomas Yata, ella okay. It will be okay by touching the shoulder. That's called therapeutic touch. Dear friends, where are we right now? Are we away from the humane touch or therapeutic touch? Of course, we need everything. Of course, these are the updates, bladder cancer updates. So, wish you all the best. These are just matter of a thought for the Sunday. And really, I congratulate the entire team of the Caritas Hospital for the wonderful CMEs under the leadership of the entire urology department. And thank you so much, ASU team, for wonderful selection of these hospitals and the teamwork. And in future also, we would like to collaborate with the ASU. We work together for the better care, and we should make sure that spreading the radiance of good health and happiness. With this, I officially inaugurate this wonderful CMEs and wish you all the best. We're looking forward in future. Thank you very much. God bless you.
Thank you, Father. I request Dr. Surya Prakash, Secretary, Association of Southern Urologists, for the felicitation speech.
A very good morning to all of you. Respected Dr. Ginil Kumar, President, Association of Southern Urologists, Dr. Binu Kamath, Director of Caritas Hospitals, Dr. Suresh Bhatt, sir, Organizing Chairman for this program, Dr. Suchindra, and my council member from Kerala, Dr. Frederick Paul. First of all, let me congratulate the organizing committee. You have designed a very well program. It is really like not just like council member activities, almost like a program of a regional level. And the topics are excellent, and the faculty has been very well selected, and it's going to be, the program has gone so far very well. Congratulations for that. A few words about Association of Southern Urologists. So ASU has always been in the forefront in promoting academics. This activity, which is called council member activity, we have got 4 council members from 4 state associations: Tapasu, UAK, KUA, and SOGAS, AP and Telangana. So each council member is supposed to do one academic activity during his tenure of 2 years. This is how this program is devised or planned. Dr. Frederick Paul from UAK is asked to do this program with the help of the Caritas Hospital and Dr. Suresh Bhatt, sir. I think this is the only zone among all the 4 zones of USI where a council member is asked to do an academic activity, and we are very successful in doing these academic activities. We have already done 3 in the last 1.5 years, one by Dr. Nishchas D'Souza and Dr. Jagdish from Hyderabad. And this is the 3rd activity. One more activity is pending from Tapasu by Dr. Dorai Rajan. Dr. Ginil has already pointed out about the journal. We had a lot of pains and a lot of discussions in bringing out this journal. Why a journal for ASU when we already have a journal for USI? So as you all know, there are a lot of material we have, a lot of clinical data we have. It is not seeing the print. So we present in the conferences and just take the best prizes, best poster, best video, and just forget it. So we want all these things to be in print so that it will be archived for the generations to come to see, read, and learn. So this is how the concept of JASU, the Journal of Association of Southern Urologists, has taken birth in the last AGM at Trivandrum. Dr. Mallikarjun Reddy is editor, and he has his editorial board. The first issue is almost ready. It's going to be it's an online journal. The issue is going to be released before our USICON partner, maybe end of this month. So I request all of you to send your valuable material. Let it be case reports, point of technique, original articles to JASU and get it published in the journal. Very soon it's going to be indexed. And a word about our website. So as you all know, I've been telling every meeting that website is revamped, updated, but without your support, we can't have good information in our website. All the directory, the members of our ASU are there in the website. I request all of you to update your addresses. We need your emails, latest phone numbers, so that I can communicate with all of you, send all the latest information, what is happening in ASU. That is lacking. Nearly half of the members have not updated their addresses. So when I send a mail, almost 1/3 of the mails, they come back to me saying that mails are bounced because of the wrong email ID. So I request all of you to update your addresses in the website. And as you know, this program is live telecast through the YouTube, and many members across our South India are watching this program live. So I'll not take much time. And once again, I thank the organizing committee headed by Dr. Suresh Bhatt sir for devising a wonderful program, and the Caritas Hospital for providing such a nice venue. It's really pleasant to stay here and watch this program. Thank you, sir, for giving this wonderful venue. And again, congratulate Dr. Frederick Paul for taking up this academic activity. And most important is the faculty and the audience. Without your support, without your presence, sharing knowledge, any program will not be successful. Thank you very much for coming and taking part in this program. Thank you very much.
Thank you, sir. Now I invite Dr. Frederick Paul, ASU Council Member, for Council Member Address.
Honorable President of the ASU, Dr. Ginil Kumar, Chief Patron and Director of Caritas Hospital, Reverend Dr. Binu Kunnath, Honorable Secretary of the ASU, Dr. Surya Prakash, Organizing Chairman and my teacher, Professor Suresh Bhatt, Dr. Apu Thomas, and dignitaries on and off the dais. As the Honorable Secretary has outlined, this is a council member program, and when I thought about it, I discussed the idea with my teacher, Professor Suresh Bhatt and Suchintra Prasad Unni. They immediately agreed to take up the CME, and we have got all support from the Caritas team, and now you can see we are having a wonderful program. This is due to the wonderful meticulous planning and execution by the Caritas team. My sincere gratitude to them, especially Dr. Suresh Bhatt, Dr. Suchintra Prasad Unni, and Dr. Arun Ayappan. They have been behind this, organizing this wonderful program. My sincere gratitude to them. The ASU Council, most of the members are here. They have extended their unflinching support and guidance to organize this program, and my sincere gratitude to them. The UAK and most of the executive members are here, and the delegates, most of them are the UAK members, and they have extended their support for this program, and I am extremely grateful to them. And I am extremely thankful to the delegates and the faculty for bringing out such a nice academic activity, and I wish this program all success. Thank you. Jai Hind and Jai ASU.
Thank you, sir. I would like to invite Dr. Sujendra Prasad Unni, Organizing Secretary, Bladder Cancer Update 2024, for delivering the vote of thanks, whose tireless efforts have substantially contributed to the success of the CME.
Good morning, everyone. We are running a little bit behind the schedule. I'd like to keep it short. First, I would like to thank the ASU President, Dr. Ginil Kumar, for giving us this opportunity to host and conduct this conference. Thank you, sir. On behalf of our urology fraternity, I would like to thank Reverend Father Dr. Binu Kunath for inaugurating this program and for his wholehearted support and blessings for conducting such an event at Caritas Hospital. Thank you, Father. I would like to thank the ASU Secretary, Dr. Surya Prakash Vaddi, sir, for his continued support and interaction with the organizers. Special thanks to Dr. Frederick Paul, sir, for ASU Council member for entrusting us with the program. And special thanks to the ASU Council for their support in conducting this program. Thank you, sir. I would like to extend my heartfelt gratitude to all the fraternity of faculty who have come across from the various parts of South India for their active interaction and deliberation. Thank you. I would like to thank all the PGs and delegates for their participation. A special thanks to the tireless efforts of the organizing team, our management, Reverend Father Jinsmon, Dr. Bobby Abraham, Dr. Alcy for the guidance, Dr. Navneet and Dr. Rapana for their comparing, and our audiovisual team and the IT team and PROs who have worked diligently behind the scenes for the smooth running of this program. Thank you very much.
Thank you, sir. Now it's time to hit a pause. Enjoy the break, and we will reconvene shortly for more enlightening discussions. Please note that food items are not allowed to be brought inside the hall. Washrooms are located on the left side of the hall.
15 minutes. 10 minutes. So the break will be for 10 minutes. We'll gather as soon as possible. Yeah, sure. Yeah, sure. One letter.
Please remember to collect your certificates from the registration counter. Next, we request everyone to be back in the halls. We request everyone to be back in the halls. We are restarting the sessions.
Please remember to collect your certificates from the registration counter.
No, but he hasn't come in. ഞാൻ പോയി വിളിക്കട്ടെ സാറിന് പിന്നെ ഈ ബാലഗോപാൽ നായർ സാർ ഒന്നുണ്ടോ നോക്കൂ ഇവിടെ ഉണ്ടോ നെബു ഐസക് മാമൻ അല്ല ഇങ്ങോട്ട് വരണ്ടേ ഇവരെ വിളിക്കണ്ടേ ചെയർപേഴ്സൺ സാറിനല്ല
തുടങ്ങുമ്പോഴേ ഈ ഫ്രണ്ടിലത്തെ ഒരു 3 റോ ഫ്രീ ആയിട്ട് പീജീസിനെ മാത്രം പറയാം അപ്പോൾ രണ്ടാമത്തേത് കഴിയുമ്പോൾ അങ്ങ് പറഞ്ഞു ബാക്കിലോട്ട് പോകാനായിട്ട് പറ്റുമെങ്കിൽ പീജീസിനെ ഓൾട്ടർനേറ്റ് കിട്ടുന്നതായിരിക്കും കോപ്പി ആയിരിക്കും പർച്ച് ചെയ്തോളാം അല്ല അത്
അവർ വന്നിട്ടില്ലെങ്കിൽ നമ്മൾ വേറെ ലിസ്റ്റ് ഇത്രയും നടക്കുന്നുണ്ടല്ലോ ഞാൻ സ്റ്റാർട്ട് ചെയ്യണം ഇല്ല ആൾക്കാർ വിളിച്ചിട്ട് വന്നിട്ടില്ല that's what I feel. Everybody can hear. Only during the coffee break at least. Only during the coffee break at least if it's there. എല്ലാവരും അറിയിക്കാമല്ലോ ബാലഗോപാൽ നായർ സാറാണ് ഇല്ല അവർ ചെയർപേഴ്സൺ പറയും അങ്ങനെയാക്കി എല്ലാം അങ്ങനെയാക്കി അത് വേണമെങ്കിൽ ഇവർ പറയാൻ പറ്റും ഇതില്ലല്ലോ അല്ലേ ആഫ്റ്റർ പ്രസൻറ്റേഷൻ ഇതില്ല
ആഫ്റ്റർ പ്രസൻറ്റേഷൻ സാധനമില്ല പക്ഷേ ഇതുണ്ട് ഇതില്ല ഇതുമില്ല നമ്മൾ നേരെ ഇത് ആസ് വി മൂവ് ഫോർവേഡ്.
And so our exploration of cutting-edge medical research and practice continues to present insights on intravesical adjuvant therapy. To chair the session, I would like to welcome Dr. Unni S. Pillai, Consultant Medical Oncology, Caritas Institute of Medical Sciences. Dr. Balagopal Nair, Senior Consultant Urologist, Rajgiri Hospital. Dr. Nebu Isaac Maman, HOD and Professor, Department of Urology, Pushpagiri Hospital, to the dais.
Good morning, everybody. We will start with this presentation, and I welcome Mithun Gopalakrishnan, who is a young consultant urologist at Amla Hospital, Amla Institute of Medical Sciences. And he has done his fellowship from Tata Medical Center in Calcutta in uro-oncology. He's got a urogynecology fellowship also. So Mithun, so let's put some light on intravesical adjuvant therapy.
Thank you, sir. Good morning, everybody. Today my topic is regarding intravesical adjuvant therapy in carcinoma urinary bladder. So a little bit regarding the history of intravesical therapy. So Bloomberg et al. In 1975, that was the, he was the first person to identify the local BCG causes inflammatory reaction in the healthy bladder. It was actually in dogs. And in Morales in Canada was the first to use BCG in 1976 in non-muscle invasive bladder cancer. And the first RCT was done by Lam and colleagues in 1980, and the BCG was approved by FDA for use in carcinoma in situ in 1990. So as you all know, this is the AUA risk stratification of non-muscle invasive bladder carcinoma. It is divided into low risk, intermediate risk, and high risk, and all our intravesical adjuvant therapies are going according to this risk stratification. So basically, the intravesical therapy nowadays we employ intravesical chemotherapy and intravesical BCG therapy. So regarding intravesical chemotherapy, the drugs used are mitomycin C, then epirubicin, valrubicin, and the newer thing in our armamentarium is sequential gemcitabine docetaxel therapy. So as we all know, mitomycin C is an alkylating agent which inhibits DNA synthesis. Now it acts by destroying the circulating tumor cells after TURBT. It has got an ablative effect on residual tumor cells as well at the resection site. So single instillation, it is found that it reduced the 5-year recurrence rate by 14%. That is from 59 to 45% in low risk category patient. And best results are obtained when we are giving it in the first 6 hours and no use of single instillation if given after 24 hours. So the dose is 40 milligram intravesically, holding time is 1 hour, and no benefit has been found in high risk disease. So now in intermediate risk group, single instillation followed by repeat monthly instillation has got a improved recurrence free survival in this group. So there also the usually maintenance injection dose is weekly once for 6 weeks at a dose of 50 milligram, and the length and frequency of repeat chemotherapy instillation is still controversial, but it should not exceed 1 year, usually given monthly for 1 year. So the method of instillation, it is administered through a catheter outflow port under gravity, and the holding time is 1 hour, and after 1 hour it is allowed to drain under gravity itself. So the optimal schedule of intravesical chemotherapy mitomycin C instillation for low risk is single instillation. For intermediate risk group, we can give single instillation plus maintenance instillation, that is monthly instillation for 1 year. And the complications, most commonly storage symptoms, then chemical cystitis, cutaneous desquamation when it comes in contact with the skin, then decreased bladder capacity and calcified eschers in the bladder. Now a word regarding device assisted intravesical chemotherapy. One is HIVEC, then the other one is microwave induced hyperthermia effect, then EMDA, electromotive drug administration. So this is a HIVEC machine. As Mujib sir already shown us regarding through a catheter, we instill the solution, the medicine with the diluent, and the speed is around 2.5 ml per minute, and it is heated up to 42 degrees centigrade, and the circulating time is 1 hour. So in a pilot phase 2 RCT on 50 high risk NMIBC, HIVEC has showed early outcomes which is comparable to BCG. But this data needs to be corroborated by further studies. This treatment actually seemed to appropriate for NMIBC intermediate or high risk category patients who cannot tolerate BCG and who have contraindication for standard BCG therapy in cases or where there are supply shortages of BCG, as we have encountered in the COVID time. And a word regarding the neoadjuvant chemo ablation, not a routine practice, not in any guideline, still under trials. That is neoadjuvant HIVEC treatment, 8 weekly instillation followed by TURBT, then followed by adjuvant weekly instillation for 4 times, and then monthly for 6. The incidence and severity of side effects were slightly lower in the adjuvant group than in neoadjuvant group. And the microwave induced hyperthermia effect, Actually, all these device-assisted chemotherapy, only the difference is the energy source differs. In HIVEC, it is heat. In microwave therapy, it is microwave they are using, and it is EMDA, they use electric current. So, the efficacy of mitomycin C using electromotive drug administration sequentially combined with BCG in patients with high-risk tumors has been demonstrated in one small RCTs, but all these things needs data from further trials to make it into a routine practice. Regarding the other intravesical chemotherapeutic agents, doxorubicin, epirubicin, and valrubicin, as we all know, doxorubicin is an anthracycline antibiotic, whereas epirubicin is an epimer of doxorubicin, and valrubicin is a semi-synthetic analog of doxorubicin. Actually, all these acts by binding to the DNA base pairs, inhibiting topoisomerase 2 and inhibiting protein synthesis. Now, the new thing, which is now getting into a routine practice, is sequential gemcitabine docetaxel chemotherapy. It's an alternative to BCG with less intensity of complications, mostly used in BCG failure situations, and we started to think more about it during our COVID times when we had an acute shortage of BCG and all those things. So, regarding the sequential gemcitabine docetaxel, how is it's been done? Prior to all instillation, patients were treated with 1,300 milligram of oral sodium bicarbonate in the evening prior and the morning of treatment to alkalinize the urine. Actually, alkalinization of urine is thought to prevent some side effects of acidic gemcitabine. After complete bladder drainage, 1 gram of gemcitabine in 50 ml NS is instilled into urinary bladder for approximately 90 minutes. The holding time is 90 minutes. After that, completely drain the bladder, then followed by next instillation, that is 37.5 milligram of docetaxel in 50 ml of NS, and the holding time is 120 minutes. The induction, it also has got induction and maintenance. Induction is weekly once for 6 weeks as with our BCG. Then the surveillance, first surveillance is initiated between 4 to 8 weeks after beginning this chemotherapy. It is by cystoscopy and urine cytology. If the patient is disease free at first surveillance, we will give monthly instillation up to 24 months. And if there is, during surveillance cystoscopy, if there is low grade recurrence, we will fulgurate it and we will continue with the usual maintenance dose. But if the recurrence is high grade, then we should assume it as failure and we will go for next therapies. So, regarding the comparison, regarding the treatment success, gemcitabine docetaxel was the recurrence free rate was 66% at first surveillance, 54% at 1 year, and 34% at 2 years after initiating induction. Whereas BCG, its 1 year recurrence free rate was 70%. It was 54% in sequential therapy and decreasing approximately to 60% at 2 years, which was when compared to docetaxel, it was 34% at 2 years. So, drawback of this gemcitabine docetaxel, still at an evolving stage only, not much RCTs, still not accepted as a routine practice, mostly used now in BCG failure scenarios. Another sequential intravesical chemotherapy pair is valrubicin docetaxel. Now, regarding the intravesical BCG. So, when BCG is compared to mitomycin C or other chemotherapeutic agents, BCG has got a clear-cut advantage in recurrence free in intermediate and high-risk groups, but with a slight increased chance of toxicity with BCG. So, in trials with BCG induction plus maintenance, there was a 32% reduction in the risk of recurrence for BCG when compared to mitomycin C, and a Cochrane analysis also proved this as true. Then, regarding the progression, based on median follow-up of 2.5 years, tumors progressed in 9.8% of the patient treated with BCG compared to 13.8% in control groups. So, regarding the mechanism of action, as we all know regarding that, intravesical immunotherapy, it results in massive local immune response. Then, initial step appears to be direct binding of fibronectin within the bladder wall, subsequently leading to direct stimulation of cell-mediated immunological response, and it includes both Th1 as well as cell-mediated immunity. And regarding the strains, Danish strain, we know 10⁹ is a colony forming units. And BCG powdered vaccine 80 milligram is reconstituted with 100 ml of NS and should be administered through a urethral catheter. And it begins 2 to 4 weeks after resection in order to allow for re-epithelialization. And after instillation, the patient should retain the solution for at least 2 hours. The earlier teaching was the patient has to roll in all sides, but now they say it's not required. And fluid diuretic and caffeine restrictions are before the instillation are should be limited, and patients are usually instructed to clean the toilet with bleach, although there is no demonstrable risk of close contact infection. And regarding the dosage schedule, we all know that regarding the SWG regime, for intermediate risk, it is induction weekly 6 weeks, followed by weekly 3 installations at 3 and 6 months, and repeated every 6 months thereafter for 1 year in intermediate risk group, whereas for 3 years in a case of high risk group. And the dose is 80 milligram in 100 ml saline installation. Then complication, storage symptoms, bladder contracture, fever, joint pain, granulomatous prostatitis, and disseminated tuberculosis. Absolute contraindications are in immunosuppressed and immunocompromised patients like HIV. Then personal history of BCG sepsis, gross hematuria, traumatic catheterization, total incontinence, those patients who can't hold BCG. Then these are the relative contraindications: UTI, liver disease, because if the patient goes for BCG sepsis, we can't give all the isoniazid, being it a hepatotoxic drug. Then poor overall performance and advanced age. And this is our standard Cleveland Clinic approach to management of BCG toxicity. Grade 1, where there is moderate symptoms only less than 48 hours. Only thing is we need to send a urine culture, prove that there is no UTI other than UTA. Then only needs symptomatic management. Whereas in moderate symptoms, that is symptoms which is lasting more than 48 hours, we need to send urine culture, chest X-ray and liver function test, and we need to start anti-tuberculosis drugs like isoniazid and rifampicin until the symptoms resolves. And grade 3, again divided into allergic reactions only, where we give isoniazid, rifampicin for 3 to 6 months, depending on the response. If there is solid organ involvement, we need to give this isoniazid, rifampicin, and ethambutol for 3 to 6 months. Here, pyrazinamide is not given because BCG is uniformly resistant to that. And if the patient, we need to consider prednisolone if the patient comes with BCG sepsis and septic shock, given under the coverage of an antibiotic. So agents with historical importance only now are interferons, thiotepa, keyhole limpet antigen, and liposomal 2. Thank you.
Thank you, Mithun, for covering this topic so quickly and covering all aspects of it.
Thanks,
okay, well, the BCG failure, probably Dr. Ginil will be covering that. Whatever the adjuvant therapy for that is there. And with mitomycin, probably which is the most commonly used thing, the complications with that, it's there.
Yes, sir.
And as you mentioned, systemic complications can also happen.
Very rarely.
Yeah, but when it happens, they do have all the features of, I have seen one patient who had all the features in which he had, where the cannula was put, the eschar formed there also. And he had leukopenia, and which lasted long, then only required conservative management.
How do you compare the side effect profile of BCG versus mitomycin?
Definitely, BCG has more toxicity. Local toxicity is more. Symptoms are more. Patients tolerate mitomycin C better than BCG. But we have already seen the recurrence-free survival rate, recurrence-free rate is better with BCG.
Any questions from the audience? Yes, sir.
I just wanted to add one more thing. See, post-operative mitomycin, immediate post-operative 24 hours. The effect of reducing the recurrence lasts for only 2 years. After 2 years, there is no advantage. The recurrence rate is the same. So the effect lasts for only 2 years. That is one thing which you have to be very careful. But there is a definite advantage.
Dr. Appatham, sir.
BCG fails, what is the consensus that you are giving us?
Sir, it's a next topic.
Are you? Oh,
that's another topic. That's why I didn't touch upon that.
Okay.
I think Ginil is getting up already.
So Ginil will.
So one more question, sir. It's regarding a patient. She had a very small tumor. We did a TOPT and we gave mitomycin. Initial post-operatively, first 2 weeks she was fine. Then she came back with hematuria and severe LUTs. So we did ultrasound which showed a irregular growth in the bladder. So I did a cystoscopy which showed a multiple nodular ulcerative lesion involving the whole of the anterior wall. I advised a biopsy, but she never came back. So my question is, what could it be? This is after mitomycin actually.
Mostly mitomycin related injuries. It can
How happen.
do
You treat that actually? When
symptoms.
That is unlikely because
what we are giving is only 20 milligram mitomycin.
But it was very small, hardly a 1 centimeter. tumor it was.
So it's unlike we actually need a biopsy to prove that. And the toxicity of 20 mg mitomycin is practically very small.
Sir, it all depends on the the response of the body to the medicine. Some
but
patients
20 mg, you know, most of the 20 mg or 40 mg, what we use is 20 mg.
But actually you did a complete resection, right? Immediately after you are developing this.
After maybe 2 weeks, exactly.
So unlikely, we need to do a biopsy to see what it is.
No, so there's a eosinophilic cystitis in mitomycin. I was just read in the net about it.
That will be very rare. So we never came across such problems. So I think Ginil sir will be talking about pembrolizumab in mitomycin, in BCG refractory, so I'm not adding that. Are we the same panelists? I mean,
No.
Okay.
You have to get out.
Thank you, doctors.
Thank you.
As we move forward, we delve into the nuance of the topic BCG failure. Now, I would like to welcome Dr. Kannan R. Nair, Professor, Department of Urology and Renal Transplantation, AIMS Kochi, Dr. Ramesh Babu, Senior Consultant, Urologist, GH Talasheri, and Dr. Kiran S., In Charge and Senior Consultant, Department of Urology, Metria Hospital, to chair the session.
Respected chairperson, dear audience. BCG failure is a hot topic currently because of a few factors. One, BCG is difficult to get now. Second, so because of the side effects when it's failing, then what are the classification for failure? Then what are the current modalities which is possible for BCG failure to avoid a cystectomy? So what we know is when we are putting BCG inside, a cascade of immunological reaction happens, cascade happens. It can be tolerability issues. It can be failure of specific issues related to cancer or immunological factors or even genetic factors. How we will say adequate BCG is given? This paper again from MD Anderson group. If we are given 5 out of 6 induction dosages and at least 2 doses of maintenance course within 6 months, we assume that adequate BCG is given, and then we can define it as a BCG failure. If this is not given, then probably we cannot say that the BCG is failed. The types of BCG failure is refractory, relapsing, unresponse, and of course intolerance. When we will say BCG is failed, when there is a muscle invasive bladder cancer, we always say is there is a progression and BCG has failed. Other important factors is one is intolerance, either inadequate BCG therapy or because of the symptoms, patient hasn't completed the BCG therapy. This may be different in different strains. What we get now is Moscow strain, which has got more side effects. Probably that can be a factor in some of our patients. BCG refractory, what we have to think of is a time frame within 6 months. If there is a persistence at 3 months of any high-grade tumor T1, or even if there is an initial response within 6 months it is coming back, or any progression on BCG, or any high-grade persistence on BCG or maintenance, or carcinoma in situ persisting beyond 6 months even after initial response, this is considered to be BCG refractory. BCG relapsing is high-grade disease after a period of 6 months. It can be early or late depending on the duration. BCG unresponsive is a better term or easier term we can have in our studies, because is very easy to understand. Within 6 months, if either a refractory stage or lapse stage, or any carcinoma in situ persisting up to 12 months is considered to be unresponsive. So what are the management options? We have got some old or new methods. So compiling everything together, the modalities are either to remove the cancer cells by cystectomy or by radiation or photodynamic therapy or installation of chemotherapy or thermochemotherapy, as Midun has explained, or using toxins, which are new molecules, or stimulate the immune mechanism to kill the tumor by repeating the BCG or adding interferon alpha to BCG, or immunotherapy as a systemic treatment, or immunotherapy as an intravesical treatment, or new modalities with adenovirus. These are the options we have. If I am compiling everything, these are the options in BCG, which are good and which are bad. Among the good options, the gold standard is even now radical cystectomy. If there is a failure, radical cystectomy is the gold standard. When the patient is not willing for radical cystectomy, then only an option comes. So all the trials was for patients who are not willing for a radical cystectomy. So chemoradiation, actually this particular treatment is not explored much in this BCG failure scenario, but the small data shows good response. But since the data is not adequate, we will not go into that. The new treatment that has come to kill the cancer cells is published in ASCO, is present in ASCO 2023, is interesting. This photodynamic with a specific agent, ruthenium based complex, then illuminate with the green laser 530 nanogram, and they found that the response is excellent with 90-day response of 53 and 1 year persistence 29. All these tumor, our important thing is how long the CR status, complete response status, persists. That is the most important criteria we have to look into. Intravesical chemotherapy, already explained in that MMC has got mitomycin doesn't have any role in post BCG failure. Gemcitabine, there are studies. Docetaxel is another molecule that is studied, but best evidence for us will be in a sequential gemcitabine and docetaxel, as Midun has told. So it has got the best response among the chemotherapeutic agents what we have. So how it is given is 1 to 1.5 years. Initially you put the gemcitabine 1 gram, then instill as a sequence after draining the next dose of docetaxel. Even though it's 37.5, we get usually 40 gram docetaxel here. There are other modalities. Thermochemotherapy is in the form of fried by radiofrequency induced increase of temperature of bladder wall, or installation of preheated mitomycin. Another almost similar is electromotive drug administration, already discussed with Midun. All these things has got limited data, small study papers, so none of them have approved by FDA, but probably tomorrow they may come up. Valrubicin, it was FDA approved, but only one paper which showed a fast approval by FDA. After that, none of the paper came, and nobody is probably using it now. Repeat BCG is one thing that we regularly do in our practice. That is actually when there is no obvious tumor, but carcinoma in situ is present or cytology is positive. And if you are eradicating entire tumor, probably this is possible, but there is no role for a second induction. Beyond second induction, there is no role. If BCG is not acting within 2 inductions, just stop. It is not going to work. BCG per interferon alpha, there was a lot of enthusiasm initially, but later we found that the additional benefit of interferon is not there, so that has dropped out. Apasicon is actually a molecule that is steroid, good response, but the evidence is not adequate. Vicinium is an interesting thing. A toxin, Pseudomonas toxin, is coupled with epithelial cell adhesion molecule or EpCAM, and this is joined together and it stops the protein synthesis. This is Vicinium, shown to have good result. Even the persistence of result in papillary CA was excellent, but the evidence, more evidence has to come. This is probably one molecule. Mycobacterium flea cell nucleic acid complex, BCG, same team. Initially paper, they actually again studied about the role in BCG failure, but FDA did not. So response was initially good for papillary, but it is not a dedicated study for BCG failure. What we have now FDA approved is pembrolizumab, that is showed excellent response. More important is that the initial response is seen even after 12 months. The response is persisting. Pembrolizumab, but thing is, it's a systemic treatment. Problem for us is the cost. If there is a failure after spending this much, a lot of patients, when we counsel the patient, they go for a cystectomy rather than pembrolizumab. So easiest way to convince for a cystectomy is to talk about pembrolizumab. That is what I found now. So another thing that is coming up is a viral gene. That is actually has come as one landmark method. Two FDA approval has come. One is nadofaragene firadenovic, is almost like a Russian name. The response is actually in more than 60%, and it is persisting. The complete response is persisting. So this may be a future thing. And what are the things that is coming up? Lot of immunological treatments are tried intravesically: atezolizumab, durvalumab, nivolumab, then erdafitinib, that is the FGFR3 inhibitor. Then intravesically, again immunotherapy, pembrolizumab significantly. And BCG may be a history in the coming days because of the new molecule that is coming up. If it is cheaper and affordable, probably that will be the thing. What we can do in our practice is, one is the sequence of gemcitabine and docetaxel is one thing, and radical cystectomy is the two practical things what we can think of, and pembrolizumab, whoever can afford, is the things that is available for us. All other adeno vectors may come up to our country later. Thank you very much.
Thank you, Professor Ginil, for this excellent talk. As we all know, that the BCG failure is quite an heterogeneous group of entity. And from his talk, my understanding is that still the gold standard is radical cystectomy, and the other options we can have in the context of a clinical trial. So now this thing is open for discussion from the floor.
About the last sentence you made, BCG may be as part of history. Just, I think I don't know why you have omitted the last. There was I think one of those series came last was pembrolizumab with intravesical BCG.
Yeah.
I think you omitted that article, but that is also that shows a little better. Probably, if at all, equally good or better. So that can reduce the side effect profile and maybe cost in the setting. If much more studies are coming in that series.
A lot of intravesical treatment is
intravesical BCG with pembro, systemic pembro.
Yep.
Now one question which I couldn't find an answer for. PPD positivity is not considered to be a contraindication. So in our place, tuberculosis is not uncommon. And I wonder whether hyperactivity of the PPD positivity, that is, you say that it is positive when it is between 1 and 2. If it is 2 centimeter patch or reaction or more than 3 centimeter, for example, it is very hyperactive. Is it likely that a person who has had tuberculosis have a very high reaction to the BCG with S2 forming and is likely to be
beneficial
problem generating?
Actually, we had our own paper in therapeutic urology on our BCG failure, BCG response patients. What we found is actually, even if it is less than 1 year and more than 1 year, it is only around 100 patients we have in that data. There was no difference in the shorter duration. This is the finding we had. Even in less than 1 year BCG, there was not much difference, even if we are giving more than 1 year. But we cannot put it as a practice guideline because it's only a retrospective analysis. Yeah, Kishore.
Ginil, I was wondering whether we can change the whole paradigm.
because BCG is a relatively toxic medications. So instead of giving BCG as a first line, whether to switch to gemcitabine and docetaxel, which is well tolerated.
Good question, because in our practice, what we are doing is in old age, where they may not be able to withstand, like more than 70 and all, we go as gemcitabine, docetaxel as the primary treatment. And young patients who may have a longer life, we are opting BCG because always we can go for a better treatment which can go for a longer duration.
Are there any trials where gemcitabine has been given upfront and then BCG has been put as
No,
a...
Mithun has showed one paper. In this, actually a comparison is between BCGs, and yeah, in that actually it was comparable, docetaxel BCG in the primary setting.
Only thing which is worrying in this is whether BCG in the next, if it fails, is it going to be effective? There is no reason why it should not be, but it is only a speculation.
Yeah, both sides we can say BCG failed, the other one, this one fails the BCG.
This one failed, then you can opt for
it is
BCG.
acting through mechanisms, so probably it may.
There is no reason why it should not, because BCG has to be effective.
Dr. Ginil, it's not about the failure, the BCG tolerance. Now, we initially used to give 120 milligram the dose. Now we are reduced to 80 milligram. I just want to know what is the standard of dose?
Standard of care is actually you have to have 10 million bacteria inside, and nobody is going to check that bacterial count in our this one. And what we do is, according to side effect, we gauge that this is tolerable or not. So 120 was not tolerating with the Moscow thing, so we reduced to 80. And we have got SGPGA paper and one study from European, that is the randomized trial, URTC trial, where they have reduced sequentially like less than 1 year, low dose and high dose. In that, actually what we know is in the high grade, it is not advisable to reduce the duration of dose, but in the recurrence or intermediate category is very high risk. It is better to go for full-fledged, and the other one we can reduce was this thing from the URTC. But other studies in our country like SGPGA, that study and all, probably use the exposure to tuberculosis and another factor where we can advise for a lower dose, we don't know. But more studies are required. Till that time, what I can say is 80 milligram is a better. Recently, TMC has come out with a study and they found that 120 and 80 better tolerable, and equal effect is there for 80. So 80 is actually, one study is from TMC is there. Tata, Gagan and team has published recently one paper.
So I think we are running short of time.
Tata,
We'll take the last question.
Tata, they have the 22 paper. It was very clearly mentioned that 120 and 80, they have reviewed the 120 and 80 series, but the 40, I think there is an ongoing study with 40, and the results are awaited actually. They have not come out with the 40 response. So, and especially it will be useful for our, maybe effective in our country, because to have the tuberculosis is very endemic here. So the response may alter for the favorable.
We actually, as a custom, we put 120 here, but thing is different.
Thing is that Borel started with 120 because that was the only thing.
Taste and other thing is not 120.
That was because at that time it was available.
We blindly follow
only thing
what is taught
which was available, because Morales was first started with 120.
Yeah.
So everybody is following it, and the chemokine response with 40, with 120, 80 is almost equal. That also has been studied. Actually, interleukin 8 response has been studied, and it is found that it is almost equal.
Thank you.
So we can wind up. We are already running short of time. Thank you, Jinal sir, for the wonderful presentation. Thank you, delegates, for the discussion.
Our journey through the realms of medical innovation continues, and we welcome Dr. Arun RM, Assistant Professor, Urological Oncology, AIIMS Kochi, to moderate a case discussion on non-muscle invasive CA bladder. I would also like to call the expert panelists, Dr. Satish Kumar, HOD, Trivandrum Medical College, Dr. Nasser M, HOD, Professor, Department of Urology, Government, TD Medical College, Alleppey, Dr. Venugopal, HOD, Professor, Department of Urology, Calicut Medical College, Dr. Dinesh KM, Senior Consultant, Department of Urology, Malabar Medical College and Research Center. Dr. Renu Thomas, Senior Consultant Urologist, KIMS Hospital.
Thank you, sir, for the opportunity. I've actually kept this a little basic. It's for primary benefit of the postgraduates. Again, Dinesh sir was my teacher at MCH, so this is truly an honor. So, the first case, 45-year-old male with gross painless hematuria since 1 week, former smoker, stopped since 5 years. Examination, per abdomen examination, NAD, DRE, grade 1 prostate firm. What investigations would you advise? Renu Thomas, sir. Excuse me, can you let me know when it's 15 minutes are up? First 2 cases, 15 minutes, rest all 5 minutes.
Obviously, we'll go for all the standard investigation that we do for hematuria, starting with imaging and the cytology also.
Okay.
So we will start with the ultrasound abdomen, urine cytology, urine routine, urine culture as well.
Okay. So urine routine showed numerous RBCs. Urine cytology was negative. You say KUB showed can you describe this piece?
Okay, there is a hyperechoic lesion which apparently appears to be a broad-based tumor into the bladder lumen.
Okay.
Just a difference of opinion. See, how many of you agree with this is an oncology discussion, but how many of you agree with me if I don't say urine cytology in the setting of hematuria? Primary, just see a patient coming to you with hematuria. I don't think anybody will agree if you do a cytology, not at this setting.
We should ask for cytology only when the urine is quiet, that is when there is no hematuria. The hematuria usually is intermittent, that's why.
Even then, hematuria evaluation in primary, see, question of cytology comes not even in the diagnostic setting of malignancy. So it comes mainly in the follow-up and in problem situations in the diagnosis.
Even the initial setting, I think cytology can be advised because the standard advice for cytology is to do it for 3 days, 3 consecutive days. So it is unlikely that all the 3 days the bladder will be equally hemorrhagic and grossly hematuria will
one
be
thing
there.
is here, this is only hematuria. So they had hematuria clinics and then they found that 63 to 80% patients don't have any pathology at all. That's one thing. And secondly, it's wrong to assume that it may be only 12% patients will have bladder cancer.
Okay. So basically the AUA guidelines say for gross painless hematuria, evaluation includes a CT urogram, urine cytology, cystoscopy and a PSA. So do you want a cross-sectional imaging for this patient? Dinesh sir?
This patient, I will not ask for a cross-sectional imaging at this stage.
Okay.
Because it is not going to give any added advantage regarding the whole treatment at this stage.
So any difference of opinion?
I'll go for a CT because the lesion appears to be a broad-based tumor. It is unlikely to be a superficial, at least on my views, in the images given.
So the protocol is that we go for a flexiscopy after this.
Okay. So is a CT urogram necessary? So even for low risk bladder cancer, the NCCN actually recommends a baseline imaging. You don't need to do it at follow-up, but a baseline CT is required. 1, you see the lesion better. 2, you can visualize the upper tract. You don't know if that is the only cause of hematuria. So baseline imaging is recommended per NCCN guidelines. So that's a small lesion there. So what's the next step? Renu Thomas, sir?
The next step will be, I will be advising cystoscopy, and there is no point in doing a outpatient diagnosis cystoscopy followed by therapy. We will advise a cystoscopy under anesthesia so that we can have the therapy itself coupled with that.
Absolutely. Nazir sir, this is the lesion. It's actually just around 1 into 1 centimeter papillary lesion. It's situated right over the left ureteral orifice region. Any advice on how you would go about a TURBT for this?
No, I look for the base of the lesion. If possible, I'll plan for a en bloc resection. I don't consider the salvageability of the ureteric office. Irrespective of that, I'll proceed with the resection, complete resection. That's what is my plan.
Renu Thomas, sir, would you stent this patient after resection? If the ureteral orifice, you could visualize the ureteral orifice?
No, first thing before resection, I would do a CT imaging just to see the upper tract, whether it is normal or not.
Yeah,
that you have seen. Okay. Yeah. So I will do a resection, and while resection, I will be able to appreciate the ureteric orifice more. And if I am actually cutting the ureteric orifice, I will put a stent. Sometimes the ureteric orifice may have to be resected. It may get resected if it is sitting right at the ureteric orifice.
Dinesh, sir, any comments?
Yeah, when you are resecting in that area, you have to be very careful because you have to use really a thin loop and think about point fulguration. No, too much coagulation in that area. And if you think that there is a compromise, you may have to put a stent. So that is the thing when you have to take very careful about. Not too much of coagulation. You may be asking for stricture.
Any difference in opinion on using a stent for after a TURBT?
It's actually controversial. There's a risk for reflux into the upper tracts.
Yeah.
So not many people use stent. We have never used stent, but some people do use stent.
Okay. So
I wouldn't hesitate using a stent, because whether you put a stent or not, I will, for all such cases, I will put immediate intravesical chemotherapeutic agent. So any kind of spillage, even if it is spilling into the upper tract, hopefully would be taken care of by that thing.
It's not mandatory. Actually, stenting is not mandatory. It depends on the what you see and what you. If you think that the orifice is compromised, that there is any issue and damage in the chance of stricture is there, then you can. But your stent is not going to prevent the stricture. Maybe it will help in the immediate post-operative.
Not only that, afterwards, if there's any possibility of stricture, you can always dilate that area, dilate the balloon, and that's it.
If possible, if bipolar is available, I prefer a bipolar resection for this patient.
Okay. Would you advise intravesical therapy for this patient? Immediate post-op, Renu Thomas, sir?
Yes, I would advise.
You would. What agent would you advise?
I would advise mitomycin C, but in that setting, I would say that cytology will be providing more information. If the cytology is positive, that means that it is a high-grade tumor. Your immediate intravesical mitomycin is not going to help. In that case, I might think of vomiting it.
Okay. So again, this patient would ideally fall into one of these categories, and intravesical, the immediate post-op intravesical therapy is definitely recommended. So the bladder biopsy shows this, low-grade papillourethral carcinoma, no deeper tissues included, to comment on invasion. So what's the next step, Dinesh, sir?
Low grade. It is low grade.
They've said low grade.
Ideally, you have to have muscle. Then only you comment about. But thing is that it looked like a low-grade lesion on resection, and on resection, what you saw, whether it was a clean cut, there was no deeper tissue. If you are happy about that, there is no point, especially if it is low grade. You can put the patient on follow-up.
Fine. Nazir, sir, any comments?
I also suggest the same. I don't directly go in for a really core muscle biopsy again. I'll observe the patient. I'll probably do a scopy after 3 months and will follow up after that.
Okay. Any difference in opinion?
That's what we should be on.
Yeah. Okay. So, but like we did advise a re-TURBT. He refused it. He presented after 3 months for follow-up, and this was his finding. He had multiple lesions, around 13 lesions actually, all over the bladder, all less than 5 millimeter. So what would be the next step? Renu Thomas, sir.
So obviously the tumor is now multiple. That puts him into high risk tumor, irrespective of the grade. So I'll re-resect all the tumors meticulously, and after this second resection also, I will plan a second re-look cystoscopy. I will try to convince the patient to have a re-look cystoscopy a couple of weeks after the first resection, and based on the histopathology report, I will plan my next treatment.
Fine. So he underwent repeat TRBT. All visible lesions were resected. And after your resection, would you recommend intravesical therapy if he's already received it the first round?
Already received.
Yeah, during his first TRBT, he got it.
It was not done.
It was given. It was given.
It was given.
Yeah, given.
Okay.
Now he's developed multiple recurrences. So.
Okay, then then depends on the grade. See, re-resection, what was the grade and what was the level of invasion?
Again, low grade.
Low grade.
All low grade lesions. Deep muscle this time is free of tumor.
Okay. Second, you are asking whether second BCG.
Second, immediately after
Immediate
resecting.
mitomycin was given.
Yeah, for the first TRBT.
Okay, I'll definitely give BCG. Definitely, there is no other confusion.
Yeah.
Giving mitomycin doesn't alter the management because at this stage it is a multiple tumor, even if low grade, recurrence within 3 months. So
yeah,
3 months. Multiple tumor recurrence, definitely you give BCG.
My question was, he's received mitomycin C during the first resection. Immediately after the second resection, do you want to give him mitomycin again?
No, no. I won't give it.
One
because
thing that
because
is observed-
mitomycin is given in a low risk group, only in low risk. As obviously this is not a low risk group. Mitomycin.
One reason why mitomycin fails is because the patients not been prepared properly in the previous night. You have to properly alkalize urine before giving mitomycin. If the patient has not been properly prepared, then definitely it's going to fail. But this appears to be a high risk case. So definitely after the resection, you should put BCG.
Yeah. So he actually would fall into the intermediate risk for NCCN. He's low grade, multiple lesions, more than multiple lesions, and recurrence within 1 year. So further plan, so we're saying BCG induction.
BCG.
Any difference in opinion?
To be continued for 1 year.
To be continued for 1 year. Renu Thomas sir, any difference in opinion?
Yes, I will go with the same. Continue for 1 year.
1 year, is it? Okay. So how would you follow up this patient after his BCG?
After giving maintenance phase for 1 year, I would do the cystoscopy every 3 months initially for the first year and 6 monthly thereafter.
And scopies?
The scope is what I said.
Sorry. So scope is 3, 6 and 12 months, and from the second year onwards, every 6 months and annually thereafter. So case 2, he's a 62-year-old male with the gross painless hematuria since a week, current smoker, more than 40 pack year history. Abdominal examination, nothing detected. Genitalia and prostate were normal. So this is the lesion. Any comments on the CT? Nazir sir.
This appears to be a big broad-based tumor. There is no obvious perivesical stranding I could find, but appears to be a invasive tumor by the image wise.
Okay. Fine. Any difference in opinion? Dinesh sir?
It's difficult to make up as actually a broad-based tumor from CT. CT is not very sensitive or specific as defining the base of tumor in these cases.
But it looks like a sessile lesion.
It looks like a sessile, but it has been confirmed by other means.
And nothing because only with these 2 films, I don't think we'll be able to make a.
So this was his TRBT cystoscopy finding. So actually, I'm sorry, the light is a little poor on this. So it's a large sessile tumor, solid-looking lesion. It was completely resected, and pathology came high-grade invasive urothelial carcinoma, no CIS or lymphovascular invasion, muscle included, shows no evidence of invasion. It's T1 high-grade. So, what would you advise intravesical therapy for of a lesion that looks like this?
Definitely not, because it is a broad-based lesion, large lesion. It is a only low-risk group is indicated, mitomycin. But in this case, you want to know what exactly is going to be the next.
Yeah, what is the next step? You have this pathology. You finished 1 resection. You have a diagnosis.
High-grade lesion.
High-grade
lesion, muscle not involved.
Yeah.
Definitely go for a re-resection at 1 month, 4 to 6 weeks.
Absolutely. And any difference in opinion? If you have muscle in the first specimen and it's
definitely F staging is 30 to I think 75% nearly. So it depends on if muscle is present, even then 30%, up to 30%.
Yeah.
If muscle is not present, upstaging maybe even up to,
Higher,
there are
yeah.
studies going up to 50%, 50 or even more. Definitely re-resection, whether muscle is present or not. Prognostically, maybe it is different. Muscle is present. Even muscle is present, then it is bad prognosis.
Yeah, and repeat resection does actually, on studies, when you have a repeat resection done, the chance of him actually having a recurrence and responding better to BCG is higher. So definitely a RTRBT is advised. And when
also do a biopsy from the bladder also.
You want to do a random biopsy? Oh, any comments on that?
If you have a narrowband imaging, or if those other additional scopy procedures like say blue light, if it's well and good, but I don't think any recommendation regarding biopsies.
There's no recommendation regarding this biopsy because you are supposed to do all this with an NB.
Yeah.
Or fluorescence scopy.
But it can be taken because you can take 4 specimens, one from dome, one from trigone, and both lateral sides.
And what are you actually looking for in the random biopsy?
Any evidence of CA in situ you have to rule out because there is a high chance of coexisting CA in situ for this patient.
Maybe that will, if that is going to be followed, I don't agree with that, but if that is going to be because there is no recommendation, that is why. It doesn't alter the management.
Absolutely.
Further management.
I agree with you. So actually, in a case like this, doing random biopsies is not going to be fruitful. If you're planning a bladder preservation or something like that, definitely random biopsies. But just like that, I don't think it's of value. But so he had a re-TURBT, chronic inflammatory cells, no evidence of malignancy. So what is the next step, Renu Thomas sir?
So my next step will be to plan a bladder preservation protocol in the form of...
he's T1 high grade, muscle not involved.
Yeah. T1 high grade, okay. Maybe the gold standard of therapy will be advising a radical cystectomy because it is invading the lamina propria.
Okay.
And
he hasn't had BCG. He hasn't had
that is what I told initially. I would advise adjuvant BCG therapy.
Yeah, he hasn't had BCG yet. So he's just had the re-TURBT. So you want to give him BCG.
BCG, yes.
BCG. Any...
That's what BCG
one
should be started
thing.
for this.
Another thing is, see, if you have, about what, did you tell anything about the lamina propria? What, AB?
No, it wasn't recorded.
It was
the pathologist could not...
any lymphovascular?
No. No CIS
no
or
lymphovascular. And in situ. These are the three things which lymphovascular, carcinoma in situ, and deeper lamina propria, deeper B, that is 1B.
Yeah.
These are the things, poor prognostic signs. Those may tilt the balance towards cystectomy. But still, I don't think, I will not disagree if you say BCGS first.
BCG. Anybody for intravesical gemdosi for them? Upfront rather than
upfront
BCG?
you should give BCG for all patients in the proper dose, that's all.
Okay.
And later on, if there's BCG failure is noted, then you can go for all these things as a salvage therapy.
Okay.
Upfront, our experience that patients do not tolerate. Though Ginil said that in his institute he is giving this dose, this combination therapy. We have noticed that some patients do not actually are safe, not safe. They don't tolerate this drug, this combination therapy, especially elderly people.
So actually, I know this has been the standard of care, intravesical BCG, but of late, in the last 2 years, because of gemdosi, there have been a lot of randomized control trials. And
that is true. That's because BCG is, for one thing, BCG is not available. That's the main reason why people shall start shifting the therapy.
Correct.
And second is that I feel that BCG is being overdosed. The BCG that we are giving is actually has got 3 times more of BCG. M-bovis inside it than the initial dose that were given by Morales. So actually we are using 3 times more of the organism. If you reduce the dose, not even a 40 may be one trial that is, some people have tried with 40 milligram and found equal efficacy, 40 milligram. So actually we are giving 3 times the dose every time. That may be the reason why the so much side effects are there.
Okay. So just 2 points. One, the 40 milligram trial that Dinesh was referring to was actually terminated early because of increased recurrence. They met their criteria for termination. So 40 milligram is not given.
Okay.
That's
80 is the standard that we also use.
80. And the second point is actually in the last 2 years there have been a lot of randomized trials, and there are 2 articles that are published in JU that looked at about 100 patients each of BCG versus induction gemdosi, and the treatment response rates were better with actually gemdosi. The chance of stopping induction therapy was actually better with gemdosi.
I don't know. Right now, I think we will have to stick to the guidelines. If you stick to the guidelines, you will have to go for the BCG.
Yeah.
Then, depending on the recent studies, then you may think about giving gemdosi or even gem as a primary.
Okay.
And regarding the first dose reduction, see, long back in 1990, even 80s, in Calicut, we did a study with 120 and 60 comparative dose, and I think the first at that time we didn't publish it. 1991, I think third ASU conference at Mysore, I presented the results, and it was equal. The response was equal, 60 and 120, and the side effect profile was much less.
This is the Danish 1331.
Danish 1331.
Sir, quickly one comment. Sir, when you compare BCG versus intravesical chemotherapy, so the initial
not all intravesical
chemotherapy, gemdosi, yes, I'm talking about that. The initial responses were equal, but when you look at 1 year outcome, 2 year outcome, BCG has persistently done well. At 2 years, it's 30 versus 60. BCG 60 and 30% or so with gemdosi. So the BCG exposed patients are doing well compared to gemdosi regimen.
That is the reason why I told
BCG should be.
That is the reason. We have told that there is no guideline so far received.
Fine. So he actually has advised 6 cycles of intravesical BCG and maintenance for 3 years. So he completed 2 doses, and we were giving him 120 milligram. After the second dose, he had severe dysuria, no fever or systemic symptoms, and his symptoms resolved. Next step, Renu sir?
Obviously, this is related to the BCG therapy, but I will do a urine culture also. He might be having a urinary infection. If there is a urinary infection, that will be treated.
Fine.
But once his symptoms resolve, I will resume BCG. 120 milligram, there is always a discussion whether 120 is required or 80 milligram is required. I will restart the therapy with 80 milligram.
80 milligram, absolutely. Dose reduction. So he completed 80 milligrams for 4 more cycles. So at 3 months cystoscopy, this is the finding. He's got a lot of these red velvety areas. Nazir sir, how would you proceed?
So now I have to do biopsy from the, of course, if this NBA is available, that will help us. Otherwise, even it is obviously visible, so we can plan for biopsy again. And now we'll think of curative treatment, because even otherwise there is a chance of 30 to 50% chance of for this patient who had a primary tumor, T1 tumor, to progress for to the state of even metastatic disease. So now you plan for a biopsy and plan accordingly for a curative treatment.
Okay.
Yeah, why cytology was not done in this case?
No, cytology was negative. Cytology is negative. Renu sir, any difference in opinion? Multiple red velvet areas. Would you proceed with the biopsy?
I will proceed with the biopsy, but my routine follow-up investigations include urine cytology as well. So the cytology is positive, that gives another indicator that there might be CA in situ.
Okay. And absolutely, if you have enhanced cystoscopy, you can absolutely use it. And we will proceed with the biopsy. A biopsy was performed. There was no carcinoma and C2 changes. So what would be the next steps? If the biopsy was positive, he's just finished BCG, it's just been 3 months. So when would you consider it to be a BCG failure? Would you wait till 6 months, or would you directly at 3 months declare it a BCG failure? Dinesh sir?
I think it has been described as within 6 months.
6 months.
So within 6 months. So it comes under BCG.
If there's a T1 high grade disease at 3 months also, it's a BCG failure.
And it is, I think, all this previous that intolerance, resistance, all those things are, see, they have, in 2018 there is a consensus that is BCG unresponsiveness, and that clearly states that in situ within 6 months. Yeah. So it falls under this unresponsiveness, BCG unresponsive.
Okay. He actually received maintenance BCG and into 3 more doses, and he developed a 2 centimeter papillary lesion on the anterior wall. TRBT shows T1 high grade urothelial carcinoma, no invasion of muscularis propria. So he's failed BCG. BCG
I think naturally we'll have to see. I think we had a whole lot of discussion on BCG failure. We have to offer him cystectomy first, and if he refuses, then we'll have to think about other options.
Absolutely. Anybody would recommend a second induction course of BCG, Nazir sir?
Because he has two issues. He has a BCG toxicity probably, and also he is not responding also. So in that case, there is no meaning in going back again with the BCG.
For this only T1 high grade, this is the case where we should be giving a second course of BCG and see what happens. If it's still not responding after 3 months, I think any of these conditions, any of this process can be accepted.
But if this was a low grade, then there was a point in giving re-BCG.
No, yeah, this was T1 high grade. From the start, it was T1 high grade.
I think it is. I think
there's no grade progression. If there's a grade, if the grade regression, then definitely it's BCG resistant, and then you can give a second dose. But in this case, it's worth trying because it's just a small issue.
Progression means it is already beginning from the beginning. It was a high grade.
Yeah, absolutely. So first option would be early cystectomy. If he's not willing, a second course of induction intravesical BCG. And again, he would fall to the very high risk group because he's BCG unresponsive now. So, yeah. So what are the other options? We've had a discussion, but
rather than the second induction course, I think we should go for a BCG. What we follow for a BCG unresponsive disease, like a sequential gemdosi. That may be the only thing available to us. I think pembrolizumab is available in India, right?
It is.
Yeah. But do you have to do a genetic study before giving pembrolizumab? The PD1, PDL1, any genetic study has to be done?
Patients will respond to pembrolizumab irrespective of PDL1 status, but the responses will be better if you have PDL1 positive disease. So irrespective of PDL1, it will respond, but as you correctly said, it will be better in a PD1 positive patient.
Okay. So his other options would be pembrolizumab or nadofaragine. So he refuses cystectomy. I'm sorry, that's
the gene therapy is promising if it is available in India, because anyway that is an intravesical therapy itself.
Yeah.
So, but with time, I think it might be available in future.
So 55-year-old female, third case, 50-year-old female, gross hematuria clot since 5 days. She had a myocardial infarction 2 weeks back, and an angiogram and stent placement was done. She's on antiplatelets, ticagrelor. So this is her CT. So Nazir sir, any comments on the CT?
CT again shows a large tumor, and I'm not sure whether it is multiple, but it is looks like a large infiltrating tumor.
Satish sir, any additional comments?
It's a very hypervascular tumor.
Yeah, it's a very hypervascular tumor. It's, picking up contrast very well.
Very high, very hypervascular. That is the only thing I can make out from this.
Fine.
I think the bottom image shows there is a suspicion of extravesical spread as well.
Absolutely. It looks like it has extravesical spread also. So antiplatelets were stopped after cardiology consultation. She was high cardiac risk, recent stent placement. Hematuria resolved. Now, what would be the next step? Her cytology was negative.
Cystoscopy should be the next step.
Okay. And would you do it under local anesthesia or?
No, it should be a planned cystoscopy.
And you would try to take a biopsy
yes,
also?
Take a biopsy or if possible resect the tumor.
Yeah, okay, exactly. Yeah. And you can even try to fulgurate the tumor because it's a large tumor. She's in the immediate high risk cardiac
yes,
setting.
that's why it should be done in one step.
Yeah. Okay. So it was a very large, I don't have the images for this, I'm sorry, but it was a large hypovascular tumor. It was not completely resectable. It was fulgurated to the extent possible, and she had blood pressure fluctuations during the course of resection. So this was the impression. Morphological features suggest possibility of bladder paraganglioma. So that's why it was a very hypovascular lesion.
That's the same as pheochromocytoma.
Exactly.
So being extra adrenal.
Usually it looks like a CT-wise, it looks like a papillary tumor on CT-wise. Usually encapsulated, it looks, yes, you can have an endovascular, means endocytic tumor, but usually encapsulated thing, paragangliomas.
It is a very lobulated mass.
Lobulated.
Yeah, actually, these tumors will have mucosa over them and some yellowish appearance beneath that. That will be suggestive of a tumor that's outside the mucosa.
So, what would be the next investigation, Dr. Renu Thomas?
So, if it is a paraganglioma, I would like to know whether there is any disease in other parts of the body. I think a DOTA scan would help for that.
Okay. Any other investigations, Dinesh sir?
You have to primarily go for the catecholamines, all those things.
Yeah, her catecholamines were very elevated, and again, all this time she's high cardiac risk because recent stent placed. So per cardiology consultation, she was started on alpha. I'm sorry, for endocrine, she was started on alpha blockers, and she was discharged on ecosprin 75, and she was asked to review after a month so that her cardiac risk would be a little less. We suspected it's an extracycle disease, so she would need a cystectomy. So she presented 2 days later with gross hematuria and clots. Hemoglobin was 5.6. So what will be the next step, Dinesh sir?
You have to stabilize the patient on transfusions and things, and then you have to take up the patient and fulgurate whatever is, or you have to angioembolize whatever is, because the first your primary concern is to go for the stabilize the patient.
So
and then next thing is you have to plan for the excision once the patient is stable.
Yeah.
Cystectomy, partial cystectomy has to be, or if
whether
you can bladder neck, basically whether you can preserve the bladder neck because it is
extending onto the bladder neck.
Onto the bladder neck. If it is not there, then you will have to do a total cystectomy.
So exactly, say we've stabilized her. And we had to proceed with an emergency cystectomy because it was not amenable for a partial.
Yeah.
And so this is the pathology report, T2A.
Any lymph nodes you have taken?
No, it was a quick cystectomy, so we didn't sample the lymph nodes. So Renu sir just asked this, answered this question. How would you follow up this patient?
We should follow the medical condition has to be stabilized. She has had a recent MI. That part has to be taken care of in consultation with the cardiologist. But regarding this, regarding the bladder part,
okay.
As I told earlier, we have to see for any spread in other parts of the body with a DOTA scan.
Absolutely, a DOTA scan, and we have to repeat her metanephrines in a month's time.
Yes, right.
And we suspect the cardiac event also happened because of the metanephrines.
Yeah, that is quite possible.
So,
regarding the initial catecholamine assay, I think we already had a histology of paraganglioma. So, addition of a catecholamine assay may not help in managing the patient.
Absolutely, but it would help in follow-up.
Recurrence. Regarding the recurrence, we don't know right now because paraganglioma's decision regarding malignancy is not very clear on the histological findings are not very clear cut on malignancy. So, the thing is that whether he develops a secondary or a local recurrence is the local recurrence is suggestive of. So you will have to do a DOTA scan or DOTA is better because the uptake is better with DOTA rather than MIBG.
Absolutely.
So you have to go for DOTA. And if there is DOTA, then DOTA positive, then you can tag lutetium.
Yeah. And
with the DOTA.
Theranostics, you can give theranostics. Yeah. So the next patient, 32-year-old male with irritative voiding symptoms and dysuria. He's had these symptoms for 2 to 3 months. No hematuria. So that's a CT finding. and that's a cystoscopy. So, Satish Kumar sir, any comments on the cystoscopy?
It's an extensive tumor involved in the bladder base, and it looks a high grade.
Okay.
And so.
Any comments of its cystitis cystica?
Cystitis cystica cannot appear like this. Usually it's in the triangle area, but this involves the whole of the base of the bladder.
Looks like an
and
infiltrating
creeping onto the
tumor.
lateral wall also. So likelihood of that is true.
Fine. So we went ahead with the TURBT. It showed adenocarcinoma invading muscularis propria. So Renu sir, how would you evaluate this patient?
So I think already the CT scan has been done, and we will be knowing the local extent as well as the lymph node status. So adenocarcinoma invading muscularis propria, the treatment is radical cystectomy. So we have to counsel the patient. He is a young man, so we have to give psychological support as well, because he has to cope up with this is something which is we are doing permanent to him. So, but adenocarcinoma invading muscular propria, I don't think there is a chance of bladder preservation. So we have to prepare him for radical cystectomy.
Yeah, absolutely. And
adenocarcinoma basically could be either de novo primary adenocarcinoma or urachal, or it could be secondary from GIT, either direct GIT prostate or it is a male.
Male.
Or
so young male, that's a
or
big
secondaries from GI or direct infiltration. So you exclude all those things, then see that it is primary bladder.
Absolutely.
Then whether it is infiltrating or not, the treatment is cystectomy. Whether infiltrating or not, it is cystectomy. Because and
was a biopsy taken before you proceed with that?
Yeah, we directly went ahead with the TURBT resection biopsy. So that showed adenocarcinoma. So like
you plan for colonoscopy also?
Yeah, absolutely.
That is why you exclude all those things by GI consultation, and then go ahead with if it is a primary de novo bladder cancer adeno, then irrespective of whether it is infiltrating or not, it is radical cystectomy.
Absolutely. So the key point is that in case of adenocarcinoma, we have to rule out we have to do upper GI and a low GI scopy to rule out a metastasis. And we are offering him a cystectomy. Any role for neoadjuvant therapy for him?
No role
for neoadjuvant therapy.
Even recurrence C5 or other, those are all anecdotal response, not very good.
So pathology after cystectomy was adenocarcinoma T2 and 0. Any role for adjuvant therapy?
So one question I want to ask you: did you spare the prostate in this case?
No, it was a cystoprostatectomy. It was actually
young male,
almost reaching up to the bladder neck.
Absolutely.
No, you could have look for positive margins and then spare the prostate.
No.
Because young male, you want to have some sexual pressure for him, something like that.
No.
No, in this case.
No.
Because we had a female like this, and then we preserved the vagina, 28-year-old female, preserved vagina, service, everything, and she is now doing okay.
Yeah. Female absolutely agreed. Gender preserving is fine.
Male's prostate sparing is still mentioned.
Not really, sir. I mean, the prostate is a dangerous organ. So if you leave the prostate behind, his chance of having a prostate cancer in the future, detecting it, treating it, becomes much more difficult. So in a cystectomy, the prostate is ideally removed. So this is a 67-year-old male, hematuria dysuria since a month. He had a history of TA low-grade urothelial carcinoma treated 3 years back. He's a former smoker. So his bladder is normal on cystoscopy. This is the image in the urethra.
He had a TA before.
He had a TA in the bladder 3 years back, treated 3 years back. He was not on follow-up, and he's presented with these lesions in the urethra.
Now the bladder is absolutely free also.
Bladder looks free. On cystoscopy, it's free.
And
cytology is negative.
What is the biopsy of anyway? Naturally, you have to take a biopsy from this. What was the biopsy now?
We took a cold cup biopsy, TA low grade.
TA. It was a cold cup, so the TA doesn't matter.
Yeah.
It's not indicative of what exactly it is. Whatever you have taken, it is A. That's all.
Yeah.
But it is not indicative of what it is, what he is having there. So now you have to stage it because it is a urethral malignancy, whatever it is.
Yeah.
It's an independent urethral malignancy. Stage it accordingly. You do a MR.
MRI done. It's limited to the lining epithelium.
Lining epithelium. But it shows where the area is, I think, multiple circumferential, whether the proximal urethra and the distal urethra is normal.
Yeah, everything else is normal. This is the bulbar urethra.
You can think about, depends on the, it's a circumferential lesion. So no question of, if it is a solitary single lesion, then you think about fulgurating. Otherwise, I think you will have to do a segmental urethrectomy. Segmental urethrectomy. You will have to do a segmental urethrectomy.
Any option of lasering it?
Laser therapy would be ideal in this case, I think, because you can, if you go for TR resection, you will surely go deep and then destroy the urethra just like that. So laser maybe laser you will be able to take off the
only concern is it's a circumferential. That is why I said if it is a single lesion in one of the quadrants, then well you can lace it. But circumferential stents of stricture and the whole.
But it looks extensive, so segmental resection may be a little difficult in this case.
Yeah. We actually went ahead and lasered this the whole lesion. Sorry. My question is, now it's low grade. Any role of adjuvant therapy for him?
Low grade, I think urethral malignancies, TCCs, BCG has been described, but not in low grade.
Yeah, there is no evidence for
not in low grade. BCG with retaining with a Foley catheter, it has been described, but not in low grade.
So, case 6. This is the second last case. So just let me know when we time runs out. 44-year-old female, gross painless hematuria with clots since 1 month, underwent TRBT at another center, 2 into 2 centimeter lesion in the right lateral wall. It was a complete resection. The outside CT was not available, but our slides were reviewed. They showed T1 high-grade urothelial carcinoma, plasmacytoid variant. So this is her CT, and the cystoscopy is perfectly normal. Urine cytology, no evidence of malignancy. So, what would you offer her? Renu Thomas sir.
Plasmacytoid variant, again, it's the prognosis is worse than a high-risk cancer, high-risk disease. So, if you go by the guidelines, we should offer her a cystectomy. But I think that's what I would advise her.
Absolutely. Any difference of means?
Some people have advised neoadjuvant chemotherapy in this kind of case, but before cystectomy, but the results are not very. In any case, there will be recurrence, and so the progress is not that good.
What was the T stage then?
It was T1.
T1 or TA, whatever it is, I think segmental resection or whatever resection is not going, because if you resect it completely, even then it recurs with that. It is fast recurring, and even the superficial will immediately recur with infiltration mets, and so whatever you are going to give is going to be. Most often it is palliative.
Some of these tumors are chemosensitive, so that's one thing.
Chemosensitive, taxanes and I think taxanes and monoclonal antibodies are also tried. And furosemide is also being tried.
Okay, sir. Medical oncologist, any comments? Are these tumors? Are these tumors responsive to chemo or?
Plasmacytoid variant of carcinomas generally do very badly. But T1 tumor, I would not give a neoadjuvant chemotherapy. T1 there is no evidence to give neoadjuvant or adjuvant, unless it's a muscle.
But going through the literature, you are sure that this is going to be going to recur and going to spread.
This is a bad tumor.
It's a bad tumor.
It's a bad tumor. What to give? There is no evidence.
Whatever you give, it is going to recur and spread.
Absolutely.
Yeah,
most of the time.
This is a bad tumor. It will have a lot of perineural invasion, lymphovascular invasion, all those bad things will be there. So, I mean, if you ask me how I'll proceed, I don't know. Probably that's.
Nazir sir, any comments? No,
I will also favor early cystectomy for this
absolutely.
patient.
So, an early cystectomy is the standard of care. Very high risk features, NCC and very high risk. She's got variant histologies, and early cystectomy is definitely advised. It's not chemo sensitive. So the last patient, 82-year-old male, obstructive LUTS since many years, severe bother on tamsulosin and dutasteride. His gross hematuria with clots, intermittent episodes since 1 month. And that's the cystoscopy finding, and that's the CT. Nazir sir, any comments on the cystoscopy?
See, this growth is coming out through the urethra, it seems. It's urethral. CT. Diverticulitis. It's a diverticulum. A tumor in the diverticulum.
So how would you proceed with this patient? He has severe obstructive lower tract symptoms. He has multiple diverticulae there, and one of the diverticulae has a tumor now.
Multiple diverticulae are there.
Multiple diverticulae. The other lesions are also diverticulae.
Oh. So, I think we'll have to try resecting the tumor. That's one thing, because there is only one lesion in there. But the problem with resection is, this is, even if it is a superficial tumor, chance of progression will be much. And
you can perforate also. It's probably thin wall.
So in that case, you can go for a better treatment, like curative treatment.
I think this is one thing which where you have to think about doing a cystectomy, because this you cannot resect it.
Can you do a partial cystectomy?
Partial. That is what I was
Partial
coming to.
cystectomy is
I was asking for a
82-year-old man.
rest of the bladder.
Yeah.
If the rest of the bladder is normal, you can always think about a partial. That was what I was coming to. Actually, partial cystectomy is one of the reasons. Think about bladder preserving surgery.
Yeah.
Cystectomy, either if it's a young and healthy patient, then think about cystectomy.
82-year-old man.
82-year-old.
Rest of the bladder has to be clearly looked into.
Yeah. And during a partial cystectomy, would you attempt to address the prostate also? He has severe obstructive lower tract symptoms causing these diverticulae.
You can always take the prostate out open. Anyway, you are going to do a lap or open, whatever. Depends on the merit of that. So you can tackle the prostate also at that time. See, if you are doing an open, then naturally you can enucleate the whole thing and then go ahead with that. That also in the same setting.
Renu sir, any comments on attempting at just taking a cold cup biopsy and doing laser for this and for the prostate?
And the first thing that I would do is to do a TURP along with the biopsy from the tumor, and depending upon the grade of the tumor, I will decide how to proceed. If it comes out to be a high grade tumor, I would advise 82 years. 82. If the patient hasn't got other risks and all, if I feel that he will stand a surgery, I'll advise a cystectomy. And if it is coming as a low grade tumor, I will advise a partial cystectomy if he is keen on bladder preservation.
Right, perfect. That's it.
Thank you, doctors, for your enlightening discussion. As we move on to the next phase, the topic for discussion is early cystectomy. Please join me in welcoming Dr. Harish C.H., Professor, Department of Urology, Government Medical College, Trivandrum; Dr. Arun B., HOD, Consultant Urologist, Sri Gokulam Medical College, Trivandrum; Dr. Nandagopal V., Senior Consultant Urologist, SUT Pattam, to chair the session.
Good morning. I invite Dr. Ashwin. Yeah, Dr. Ashwin. I forgot the name. I'm old now. Dr. Ashwin to deliver a lecture on the early cystectomy. And it's actually a confusing area. When to go for a early cystectomy? Now, already we heard a lot of lectures here and discussions. And going for a early cystectomy, still it's a confusing area. We are as surgeons, we usually hesitate for a early cystectomy. We move on according to the guidelines and other trials rather than going ahead with the early cystectomy. I don't know why we are so hesitant, but as surgeons, I think we have to increase the population of early cystectomy cases, because if you get rid of the malignancy by cystectomy, so most of the patients will do better in the early stages rather than going for an late stage and doing a cystectomy. Early cystectomy will definitely give a definite positive response. I think Dr. Ashwin will be detailing that. Okay.
Thank you, Hari sir, and the respected chairpersons and the organization committee. Thanks for the invitation. So I'll be talking on the early cystectomy. This picture is we are operating on a bladder. It's early cystectomy done few months back on a robotic system, Medtronic's Hugo. So what is early in this early cystectomy? Yeah. So the concept of early is, or perhaps better described as timely cystectomy, is early in the course of the disease. So what we operate is a classical radical cystectomy, which is a cystoprostosephanovasculectomy with bilateral extended pelvic lymph node dissection. There's no change in any kind of surgery, but it's only done early. So when it is done for non-muscle invasive, that is what we call it as early cystectomy. It could be a part of a primary treatment, that is in case of a high-risk disease, which I'm going to explain you, or it could be a second treatment when the primary treatment fails. So I think we all came through these layers of bladder. So what we are concentrating on the PT1, which is involving the lamina propria, and further divided into T1A, T1B, T1C, depending on the muscular mucosa involvement. And that is, it's a stage 1 bladder cancer what we are looking into actually. So T1 tumors are they really non-invasive tumors? T1 tumors invade the lamina propria by definition, so they cannot be accurately characterized as non-invasive. That is why the recent nomenclature has removed the superficial disease. What we now address is non-muscle invasive or muscle invasive bladder cancers. Unlike the urothelium, which is devoid of vessels or lymphatics, the lamina propria is rich in both, providing an opportunity for metastasis. And high-grade T1 lesions recur in more than 80% of cases and progress in 50% of patients within 3 years if you don't give any adjuvant treatment. So this is what it progresses in 30 to 50% of cases, and 33 of the mortality rate is up to 33%. So T1 high-grade treatment is always a clinical dilemma. We had a lot of discussions even in the case discussions, even when the BC treatment was going on. Yeah. Why? Because it has an inherently aggressive disease, it is heterogeneous outcomes, and significant risk of recurrence and progressions to muscle invasive bladder cancer. So how do you treat non-muscle invasive bladder cancer is based on risk stratification, depending upon what we use, maybe a ERTC risk model or maybe a Q2 model, and we manage based on the risk of recurrence and the progression after initial treatment is used. So low risk disease, yes, TURBT plus a single dose of perioperative intravesical chemotherapy. Intermediate and high risk, that is what we are looking into, where the options is conservative management, that is preservation of the functional bladder, that is TURBT potentially combined with the adjuvant intravesical therapy versus early cystectomy. What we have to balance is the risk of recurrence or progression in the conservative or TURBT management versus the quality of life, risk of surgical complications in the early cystectomy. So just risk stratification, I think we all know that it is 2021 scoring model what we use for the tumor progression, and for tumor recurrence any other things can be used because ERTC doesn't give a tumor recurrence. For that we use a Q2 protocol probably. And these apps are available on the web, both for the iOS and the Android platforms, where you can stratify the patients. Why it is important? Because all patients with the probability of progression at 5 years varies less than 1% to more than 40% between the risk group. So that's why the risk stratification is very much important. And we already come through this. We classify the patients into low risk, intermediate risk, high risk, and very high risk based on the site of the tumor, size of the tumor, number of the tumors, maybe a primary or secondary, what grade they are, and yeah, what the age of the patient also. So the treatment of high risk disease, we know that TURBT with some adjuvant intravesical therapy, but still the progression is up to 14.2% in 10 years. Generally, we give a long-term 2 to 3 years of maintenance BCG therapy, and immediate RC may also be discussed with these patients, Though radical cystectomy is the safest approach for an oncological point of view, however, with associated risk of complications and quality of life impairment, it represents an over-treatment in some patients. With treatment of a very high-risk disease, extremely high risk for tumor progression up to 53.1 to 58.6%, and immediate RC could be discussed with these patients. And in case radical cystectomy is not feasible or refused by the patient, then full dose intravesical therapy of BCG 1 to 3 years should be offered. 3 years should be offered. And carcinoma in situ, that is TURBT plus intravesical BCG installation or radical cystectomy. Yes, BCG decreases it causes complete response, it decreases the disease-free survival, it reduces the tumor progression. But when you compare to cystectomy, definitely they have the excellent specific survival rates compared to the just BCG treatment alone. So a lot of issues why we think about early cystectomy is there are a lot of issues regarding maintenance therapy and the treatment of this T1 high grade. Already we had a lot of discussions on BCG. How do you give? What is the dose we give? And what is the toxicities? It vary from cystitis to sepsis. Then what dose? 40, 80, 120 mg. What is the 1 year or 3 year? And definitely with all these, patient has a very bad compliance for this BCG therapy, which is most important. And yeah, we come to BCG failure like refractory, resistant, relapsing or intolerant to the BCGs. And moreover this, there is confusion regarding when we declare it as a failure, whether 3 months, 6 months, waiting for this, we would lose a golden period opportunity to treat the patient. So when we take a early versus deferred cystectomy head on, definitely the clear winner is early cystectomy. That is, the 10-year cancer specific survival rate is 78% in early cystectomy versus 51% in deferred cystectomy. So what is important is the optimal timing for early cystectomy, and the goal is to prevent the eventual progression and improve the cancer specific survival. So we look into these factors of the patient to decide whether we're going for early cystectomy, like the correct stage, the patient age, the size of the tumor, prostatic urethral infiltration, carcinoma in situ, presence of lymphovascular invasion, BCG failure, or any varied patterns, histology patterns. Yeah, for correct staging, definitely TURBT is important, very important. Re-TURBT is must. And based on T categories, tumor grade, tumor size, presence of CIS, the decisions taken. Again, the presence of a solid appearance of tumor, multifocal tumor, or a tumor location in the trigonal area, which are the high risk for recurrences. In all these cases, we can encourage the patient for a cystectomy. Like I said, the role of re-TURBT is must. However, the skilled surgeon is, however the experienced is, the re-TURBT must be done. And in case when we see a residual lesion in the re-TURBT, it is understood that these are less likely to complete respond to our intravesical therapy. And again, for these patients, we can encourage for early cystectomy. Depth of tumor invasion, looking into a depth T1 more further, like T1A, T1B, T1C, depending upon whether it involves the musculus mucosa, whether it is surpassing it or whether it is completely crossing it. It gives like T1A, probably we are comfortable in managing them conservatively, but T1B, T1C, like sir told, deep T1 lesions, yeah, you can always encourage them for early cystectomy. And yeah, patient's age, the studies, evidence say that as the age goes on, the chance of progression, probably because they're not compliant to the treatment, increases. So 65, 70 years, more than that, we can always encourage them for a cystectomy. Tumor size, yeah, more than 3 centimeter is likely to progress with hazard ratio of approximately 1.89. So you always encourage them for a cystectomy. And then prostatic urethral infiltration, it increases, it's a poor prognostic marker, increases the, decreases the specific mortality, increases the mortality. Presence of CIS, again, presence of CIS is a one more poor prognostic factors, and presence of lymphovascular invasion, which is a specific, which is again a marker, poor prognostic marker, where survival has come down to 33.6% compared to 62.6%. And then upon crossing these characters, we're moving into a BCG failure. Yes, when the BCG failure is there, the next treatment is like early cystectomy is the better advised. It could be a refractory disease, resistant, relapsing, or intolerant. And radical cystectomy is the recommended treatment in these patients. And varied histology, yeah, micropapillary carcinomas, anything of these varied histologies, we always suggest that cystectomy has to be done because the survival is better in these patients. So what is the benefit or the advantages of early cystectomy? Yes. So among 13 to 45% of patients with the high-risk groups, even with the re-TURBT, which is not showing any muscle invasive, if you do a surgery, still they show the muscle invasion. So we are missing 13 to 45% of patients with the muscle invasion by not doing the cystectomy. Second, we do a pelvic lymph node dissection while doing a early cystectomy also, and it is said that T1 tumors, 7 to 15% of them has a positive nodes. So the adjuvant, this will give an exact staging of the patient. You can put a patient on adjuvant therapy. Definitely it will increase the overall survival. Anytime early cystectomy done at the earliest is the best, 85.4% at 10 years. When compared to the PT tumors with 62.4, and when compared to the cystectomy done for the progressive disease, the survival is 52.9. So what are the quality of life which are more worried about this? There are studies, evidences say that when you really look a survey in the patient, they're not bothered much about this. Well done surgery, well done cystectomy. Maybe we have various type of diversions. We can give a neobladders where patients are more comfortable with that. But still, the study says that there is no difference of quality of life in before cystectomy and after cystectomy. On the other side, there are papers saying that even TURBT, BCG medications can affect the patients. They cause fatigue, they cause physical and role functioning affection, they cause mental health affection. So the EUA says that there is no randomized prospective health related trial comparing this. So you are well justified in suggesting radical cystectomy for these patients. So these are the highest risk group where you can straight away suggest them as early cystectomy, like T1 G3 associated with concurrent bladder carcinoma in situ, multiple tumors, large TIG3 tumors, recurrent TIG3 tumors with CIS, with posterior urethral infiltration, with lymphovascular infiltration, with the varied histology and BCG failure patients. So to conclude, T1 high grade is a heterogeneous and aggressive disease. The poor prognostic factors in the cancer bladder has to be remembered while you're taking a decision for the surgery. Watch closely for the BCG failures and plan cystectomy early, and perform early cystectomy earlier for eligible patients after well-informed discussion with the patient and attenders. So, thank you. So we take a ticket after the train has gone. There's no point. So do it early when you're planning to do it early. Thank you.
So thank you, Dr. Ashwin. It was a wonderful presentation. So I think the point he highlighted was that probably we are only delaying the inevitable by delaying the cystectomy, because as one of the statements made in the floor of the house was that TURBT is a procedure which is going against all the principles of cancer treatment. And with respect to the quality of life also, on these high-grade tumors, probably they have to more stringent BCG regimen for years together, stringent follow-up regimen, and ultimately more than 50% will end up in cystectomy as we see the disease progression. So ultimately we are only more or less delaying the inevitable, and regarding the quality of life also there is a question mark.
Yeah.
So I think the point to be highlighted, I think, is at least we should place this early cystectomy in the platter when we are offering treatment for high risk patients, early T1 G3 patients, right?
Exactly.
I think that is the conclusion we can make. Yes.
So open for discussion.
Yeah, I think the only when you have a scientific indication, you have talked about all the indications as an option, cystectomy as an option. I think it has to be insisted, because there are all other treatment modalities, the patient is not going to be compliant.
Yes.
At one stage, we will lose the patient, and that will be at the expense of his life. Okay. So definitely, I think we will have to insist on early cystectomy. That too, when the patient is at his prime of health.
Yes.
I think that is the take-home message. That is going to be the take-home message. You have got all the scientific reasons for going for alternate treatments, but practically this has to be the
study should be
message.
Offered.
Thank you, Dinesh sir. A few things I want to highlight. Then we are all going for with the guidelines, but the reality is little different. In our scenario, Indian scenario, as the sir said, many patients drop out. During how many of our patients are coming for this properly 3-monthly follow-up? Very few patients only come. I don't know why, because maybe they are afraid of the cystoscopy pain and the cost factor. That all these are there. So in this, when we consider this middle and poor socioeconomic people, many patients drop out. So they we are regularly seeing, once we do a TRBT, after 3-4 years, the patient will come with a huge mass in the bladder with the metastasis. This is very, very common. So where we are failing at? We are seeing renal tumors, we are seeing penile tumors, we are seeing testicular tumors. How many of them die because of the malignancy? Very, very few. Most of them will stop the treatment with a radical procedure. But whereas in CA bladder, lot of patients die. In front of our in the ward. When we on the treatment, patient coming with a recurrence and patient with bleeding and the patient going for the metastasis and patient will die. So we are going a little away from the actual reality. Some mistakes we are making. So this is one. Early cystectomy, actually, we have to go a little radical in this CA bladder, because radical CA bladder is a very aggressive malignancy most of the time. And cost factor also. The patient coming for every 3-monthly follow-up, especially in private hospital, how much they had to spend for scopies, and that too under anesthesia they had to pay for it. And the medicines, most of even the BCG is costly. So one installation usually costs 2,000 rupees.
3,000 to 4,000 rupees.
I am in a government hospital. I know people they are struggling. Many they don't get insurance for this, and they have to buy it.
Yes, sir.
So getting this BCG and spending for it, and the repeated scopies, and that. So we have to be a little more vigilant. And as he told, we have to think in terms of early cystectomy, because that is a one-time treatment.
Correct. And best done in the earlier. So just one point that what we can do to improve the follow-up is, probably we can spend some more time with the patient. We can make a patient education, probably what missing with our patients. Probably that can help, because this is only what we can offer from our side. To realize them ki this is important, so you need to come for the follow-up. This is a matter of life. But then poverty, financial crisis, all those things will hamper them. But still we should, I think that's only we can do from our side. Thank you so much.
Thank you, sirs. We'll be having a quiz during the lunch break. I request the PGs to stay back during the lunch break. They will be having the lunch after the quiz. The next topic is role of neoadjuvant and adjuvant chemotherapy. I would like to invite Dr. Yatish Srinivasa, Consultant Urologist, Mangala Hospital, Hassan. Dr. Flavalit Thomas, Assistant Professor, Department of Medical Oncology, Government Medical College, Kottayam. Dr. Manchunada, Senior Consultant Urologist, St. Philomena's Hospital, Bangalore, to chair the session.
Good afternoon, everybody. And at the outset, I'd like to thank the organizers of the Bladder Cancer Update for inviting me. And it is very good to meet many of the uro-oncology colleagues from my previous institute, Amrita, and also Rajagiri. And special thanks to Dr. Unni and Dr. Suresh Bhatt for the invite. And I think we are slightly behind on the schedule, probably. So without wasting much time, I'll go over to the topic. So we finished a lot of sessions on the non-muscle invasive sector. I think we'll go on to the muscle invasive bladder cancer, which is something that we are involved in as medical oncologists. So I'll be dealing with the neoadjuvant and adjuvant strategies that we follow in bladder cancer. So just a brief introduction. We know that bladder cancer is predominantly a disease of the elderly, usually described beyond the age of 65, and smoking a very important risk factor. We oncologists particularly stress on this point because it leads not just to bladder cancer, it is probably more commonly an etiological factor described in lung and oral cavity malignancies. So the thing with smoking is there is increased incidence of muscle invasive bladder cancer among smokers compared to non-smokers, and also the age of onset of bladder cancer is supposedly younger in the smoking population compared to the non-smokers. And at presentation, there's differing data on the percentage of the incidence of muscle invasion at presentation. It in many series it is hovering around 10%, but it may be as high as 30%. The incidence of muscle invasion at diagnosis. The survival of muscle invasive bladder cancer roughly would be around the 50% mark. T2N0 patients, there are patients who survive beyond 60 to close to 60 to 80%. 5-year survival has been reported, but by and large for the whole group it would be hovering around 5%. Now the treatment of muscle invasive bladder cancer is potentially life altering. The 5-year survival that we usually used to see with cystectomy alone used to be around 40 to 43%. So 57% of patients would have died and at 5 years, and the remaining 43% alive. But with the neoadjuvant treatment strategies, the survival has improved, and it is around about 50 to 60% with the advent of neoadjuvant chemotherapy followed by cystectomy. But the thing is, it is still underutilized. That we know a lot of factors which prevent the regular use of neoadjuvant chemotherapy. There are institutes where case series where the utilization of neoadjuvant strategies are less than 20%. By and large, it is about 20 to 50% is the utilization of neoadjuvant strategies in bladder cancer. Now, what are the potential attributes of neoadjuvant therapy? So following a TURBT, you go for systemic therapy and surgery. We get a pre and post therapy tissue. So we can, there are a lot of data that we can gather from the pre and post operative biopsy specimens. The response to the tumor in the primary, again, is indicative of the biology of the tumor. So these can be gathered from a neoadjuvant approach. So as far as muscle invasive bladder cancer is concerned, if you look at a medical oncologist perspective, we know that it's inherently a systemic disease because close to 50% of them or more are going to develop metastasis at some point. And the purpose of local therapy is actually, to control the tumor before it can start disseminating. And preoperative therapy or neoadjuvant strategies primarily addresses the potential micrometastasis. Micrometastasis are those mets which we cannot pick up on clinical or imaging studies. And the success of this neoadjuvant therapy can be measured in vivo. That this patient will be going for cystectomy at some point, and we can see the chemo responsiveness and thereby the success of neoadjuvant therapy. And if you talk about the local therapy, an ideal local therapy should definitively address the local disease and also preserve the quality of life. So this becomes important because we have, cystectomy is still considered standard of care, but you all know that trimodality treatment with bladder preservation protocols are coming up in a big way in muscle invasive bladder cancer as well. I think we'll have a session on that later today. So as I said, neoadjuvant chemotherapy followed by radical cystectomy has become the standard of care, and this has been the standard of care for the past 15 to 20 years or so. So these are the two very important trials which looked at the use of neoadjuvant therapy before cystectomy. This was a SWOG study and the BA06 study. This was more than 15 to 20 years back, and patients received 3 cycles of cisplatin-based chemotherapy versus no neoadjuvant therapy followed by radical cystectomy. So if you look at the survival, the median overall survival was 77 months with the use of neoadjuvant chemotherapy vis-a-vis 46 months in patients who underwent cystectomy alone. For the purpose of for the benefit of postgraduates, when you say a median overall survival of 77 months, it means that 50% of the patients are alive at 77 months and the remaining 50% of patients have died. So that's what median overall survival actually means. So this is a term that is regularly used in mainly in oncology, and most of the survival is either expressed in terms of 5-year survivals or median overall survivals. So these two trials conclusively proved that neoadjuvant strategy is probably better compared to patients who undergo cystectomy alone. And this was the landmark meta-analysis which is often quoted in all conferences where you have sessions on neoadjuvant therapy, where this was the ABC meta-analysis, and it showed a 5% improvement in the survival at 5 years. So this was a meta-analysis which included about 11 randomized controlled trials involving more than 3,000 patients. The neoadjuvant strategy used was combination of cisplatin containing chemotherapy regimes. So the combinations were multiple and heterogeneous. Many trials included cisplatin alone as their neoadjuvant strategy. Many had MVAC. Few had the combination of gemcitabine and cisplatin. So primarily, cisplatin was the backbone of therapy used in this neoadjuvant approach, and the disease-free survival also improved by about 9%. So then this continued to be a standard of care for long. Cisplatin-based combination chemotherapy, MVAC, is the common regime that was most commonly used in most of these trials, and the other chemotherapy regime that we commonly use is gemcitabine, and a combination of gemcitabine and cisplatin. So this VESPER study was, it was recently reported. This was a study which compared the two chemotherapies, that is the dose-dense MVAC and gemcitabine cisplatin. Now MVAC was kind of replaced by dose-dense MVAC because the results with dose-dense MVAC was found to be much better compared to the standard MVAC. So now the recent guidelines, the NCCN guidelines, do not mention the standard MVAC. All the guidelines usually mention only the dose-dense MVAC, and that is what is preferred as a neoadjuvant strategy in these trials. So this particular trial, the VESPER trial, looked at patients who were cisplatin eligible, muscle-invasive bladder cancer with a T stage more than 2, of course, and node-negative patients. And also the adjuvant arm had patients who were node positive and more than T2. And of course, as all trials dictate, the performance status should be good. So neoadjuvant dose-dense MVAC is a 14-day cycle. Patients receive chemotherapy every 14 days. It's a combination of methotrexate, vinblastine, erythromycin, and cisplatin. Whereas gemcitabine cisplatin was a 3-weekly regime, and 4 cycles of gemcitabine cisplatin were given. And I think I'm being very slow, is it? Okay, so the VESPER study basically concluded that the primary endpoint, when we looked at the primary endpoint, the progression-free survival was significantly better in the dose-dense MVAC arm compared to gemcitabine cisplatin arm. There was toxicities was slightly more with the dose-dense MVAC in comparison to cisplatin, the gemcitabine cisplatin, but of course the survival was, the progression-free survival was better, and the overall survival data is pending. So the investigators concluded that dose-dense MVAC should become the standard of care as the new neoadjuvant strategy for muscle-invasive bladder cancer. So we know that meta-analysis showed the absolute 5-year overall survival benefit of 5%, and dose-dense MVAC and GC are both standard options. We prefer doing gemcitabine cisplatin because it is considerably less toxic compared to dose-dense MVAC. But we still know that there is high rate of recurrence despite neoadjuvant chemotherapy and the surgical strategy. So neoadjuvant chemotherapy, it still seems to be an area of unmet need because survival still continue to be not very great even after neoadjuvant chemotherapy. So now the newer strategies are, exploring the use of immunotherapy along with chemotherapy. Immunotherapy, as you know, is being explored in every cancer known to man. And this is like, it's a new kid on the block. It has been there for the past, 5 to 10 years. And these these trials, the BLAST trial, HCRN trials, explored the use of nivolumab and pembrolizumab, which are all these immunotherapy drugs are now available. Nivolumab and pembro are the ones which are commonly used. They saw that the PCR rate was about 49% and 44% with the use of immunotherapy plus chemotherapy. The chemotherapy arm used gemcitabine cisplatin. So if you see, most of these trials used gemcitabine cisplatin as the chemotherapy regime, be it nivo, pembro, atezolizumab or durvalumab. All these used gemcis as a combination chemotherapy partner. The PCR rates about 49%, 44% and 40% and 34% with durvalumab. I think if you look at the PCR rates with gemcitabine cisplatin or dosed in Zemvac, it is about 20 to 30%. So slightly better PCR rates with the addition of immunotherapy. There have also been studies, looking at single agent immunotherapy as a neoadjuvant strategy. So these trials, most of these trials included patients who are cisplatin ineligible. But if you see the PURE trial and the ABACUS trial using pembrolizumab and atezolizumab, that's the first two ones you have. They were conducted in patients who were cisplatin eligible as well. So trying to see if you can have good results with the use of single agent pembrolizumab or atezolizumab. Primarily, it may be targeting patients who are cisplatin ineligible. PCR rates slightly lesser compared to the combination therapy, 37-31% were the pathological complete response rates with the use of single agent IO. So if you see, about 10% lesser compared to combination IO plus chemotherapy. So checkpoint inhibitors or immunotherapy agents are being incorporated into every aspect of bladder cancer treatment. We know that there is role in the non-muscle invasive segment of bladder cancers. Muscle invasive bladder cancer trials are going on. Metastatic bladder cancer, it is already approved in many scenarios. So there are also ongoing phase 3 trials using neoadjuvant IO. A lot of trials going on in this segment. These are a few of them. Probably I'll skip them because the results of many of these are pending, and I'm sure many of them will come into the guidelines at some point of time. So neoadjuvant strategy, this I've already described. We've already gone through this. There's a median overall survival benefit of about 2.6 years with the use of the neoadjuvant chemotherapy strategy, and the neoadjuvant checkpoint inhibitor in bladder therapy strategies. Again, as I mentioned, the pathological complete rates of 40 and 29, slightly better, about 10 to 15% better compared to doing cisplatin-based chemotherapy alone. So quickly going over to the adjuvant therapy in bladder cancer, we know that the data on adjuvant therapy is not as robust as that is seen with neoadjuvant strategies. The ultimate goal, as in any therapeutic protocol, would be to improve the survival of the patient, preserving quality of life. Now, the EORTC 30994 was the trial that looked at adjuvant chemotherapy in the bladder muscle invasive bladder cancer segment, and it showed survival, median overall survival benefit 6.74 years versus 4.6 months. So that was this was a trial which included about 280 patients, and it showed survival benefit in patients who are PT3, T4 or node positive. And also there has been this ABC meta-analysis which again showed improvement in the absolute overall survival. There's a 6% absolute improvement in overall survival with the use of adjuvant chemotherapy. But the meta-analysis was, it had a lot of flaws. Just like the neoadjuvant meta-analysis, the adjuvant ABC meta-analysis also had a lot of trials which were very heterogeneous in the chemotherapy used, very heterogeneous in the population that was employed. So no real conclusion could be drawn from the adjuvant meta-analysis, and this has been looked at, with a lot of skepticism among practitioners. So adjuvant hasn't been really, that therapy hasn't been really that in high regard as the neoadjuvant strategy. Again, immunotherapy is coming into the adjuvant segment of muscle invasive bladder cancer. So the IMVIGOT trial using atezolizumab was one that was that was started, one involving around 800 patients, but it failed to show any disease-free survival or overall survival improvement. So atezolizumab is basically a PD-L1 inhibitor that was looked into, tried in this scenario, but it failed to show any survival benefit. And it was a checkmate 274 study using nivolumab. So nivolumab in the adjuvant setting, this was the trial which showed disease-free survival improvement. The overall survival results are yet to come because the overall survival data is immature, and this has been FDA approved in the use in the adjuvant setting in bladder cancer. So the checkmate 274 study, it included patients who were YPT and T4 or node positive if they have received neoadjuvant combination therapy, and if they did not receive any neoadjuvant therapy, T3, T4 and node positive patients were included. So these patients either were cisplatin ineligible or refused an adjuvant cisplatin sort of therapy. And the randomization was to receive nivolumab 240 mg IV every 2 weeks, that is a standard dosing, and they were the control arm received placebo, and treatment was for a period of 1 year. The endpoint of the study was disease-free survival, and also they looked at patients who were PD-L1 positive, that is PD-L1 more than 1%, and the PD-L1 less than 1% as well. Secondary endpoints of course included the overall survival and recurrence-free survival. So when you look at the data from the checkmate 274, the Kaplan-Meier curves show that is, the curves are wide apart, and if you see there was significant improvement in the disease-free survival in the nivolumab arm compared to the placebo. At 1 year it was 63% versus 46%. That was the disease-free survival, and it was statistically significant, hazard ratio of 0.7. So the median disease-free survival was doubled in the nivolumab arm, 22 months versus 11 months in the placebo arm. So it doubled the disease-free survival, the addition of nivolumab. Also, in patients with a PD-L1 score more than 1%, the difference was more marked. But even in the overall population, there was a disease-free survival benefit. OS data, that is the overall survival data, as I said, is yet to come. And the toxicity, well, safety was fairly standard. We expect a lot of toxicity. Lot of low-grade toxicities with immunotherapeutic drugs, much safer compared to chemotherapy. So rash, diarrhea, fatigue, and some thyroid dysfunction. These are the usual side effects we employ, most of which are kind of manageable easily. The main toxicity with immunotherapy is the financial toxicity. These drugs come at a price. Most of these drugs are very expensive now, so the companies are coming out to support programs to ensure that a wider population gets access to this drug, but it still continues to be a very, very costly affair for a good majority of our patients. Ambassador trial that looked at the other agent, that is pembrolizumab. So pembrolizumab again is a PD-1 inhibitor that has been tried in a similar setting. Pembrolizumab 200 mg every 3 weeks, given for a period of 1 year. The trial looked at the primary disease-free survival and overall survival, and it significantly improved progression-free survival as in the adjuvant setting for patients with localized bladder cancer. So pembrolizumab also has showed significant overall disease-free survival. Again, overall survival data is still pending. So this is another very recent article. This is not on immunotherapy. This basically compared neoadjuvant and adjuvant chemotherapy strategies. And this was a retrospective study, but involved a large number of patients. This is from this is Chinese data, and basically it looked at which would be a better strategy to go about, neoadjuvant chemotherapy or the adjuvant chemotherapy strategy. And it found out that this may be an interchangeable strategy. That means patients who receive neoadjuvant chemotherapy or adjuvant chemotherapy probably does not make much difference in their survival. So especially in patients with, this is again in patients with stage 3 and stage 4. So if they haven't received a neoadjuvant chemotherapy, I think definitely you should be considering them for an adjuvant strategy. So what do we do at the end of the day in our practice? So if you have a muscle invasive bladder cancer patient who is eligible for cisplatin based therapy, I think we should go for cisplatin based chemotherapy in the neoadjuvant setting, either GemCis or dose-dense MVAC. Our preference has always been gemcitabine cisplatin because it is much more patient friendly. The toxicity profile is much better. So gemcitabine cisplatin followed by cystectomy would be the plan for a patient who is cisplatin eligible. If the patient is not eligible for a cisplatin based therapy, until and unless until we have data from the neoadjuvant immuno trials, I think the patient should go for cystectomy, because if the patient is not eligible for cisplatin, other chemotherapeutic drugs like replacing cisplatin like carboplatin may not be as effective. Because there is some data, retrospective data mostly, to show that carboplatin may be inferior to cisplatin as far as a neoadjuvant strategy is concerned. So if the patient is ineligible for cisplatin based chemotherapy, maybe we should go for cystectomy, because post cystectomy now we have an option to offer adjuvant nivolumab if the patient has a high risk characteristic like a more than T3p T3 lesion or a node positive lesion. And if they have not received neoadjuvant chemo due to an alternative reason, and they are still cisplatin eligible, are not affordable for immunotherapy, definitely adjuvant chemotherapy should be considered as what I think from whatever data we have. If they have received neoadjuvant chemotherapy, again there is a role for adjuvant nivolumab if more than PT2 or node positive, because the Checkmate 274 we saw there is significant disease-free survival benefit. It is almost double with the use of nivolumab. So even if most of these patients in the Checkmate trial had received neoadjuvant chemotherapy, so patients received neoadjuvant chemotherapy, PT2 or node positive in the histopathology, we should be offering them adjuvant nivolumab. And if they are not affordable, probably that is the case. Maybe on a case-to-case basis, maybe we can have a radiation oncology referral for adjuvant radiotherapy as well. So that is something that can be discussed in the tumor boards as well. I think we'll have sessions coming up on radiotherapy and the trimodality treatment later, so I'm not going to those later. So the take-home message is neoadjuvant chemotherapy remains underutilized. Adjuvant immunotherapy also remains underutilized now because of primarily because of financial reasons, and immunotherapy is expected to come into these treatment guidelines soon, so in the neoadjuvant strategy as well. Thank you for your patient listening.
Thank you, Arun sir, for extensively covering adjuvant therapies of chemotherapy after bladder cancer. So I have one question. While the patient is on neoadjuvant chemotherapy, what is the surveillance? What is the imaging you use for tumor progression?
Yeah. So what we usually do is after the second cycle, the patient is subjected to a CT. So if there is no progression or the disease is remaining stable or responding, you continue the 4 cycles of GemCis. GemCis is uniformly used. My experience with MVAC is probably limited to 1 or 2 patients. So it is very toxic. So GemCis is the protocol. So after 2 cycles of GemCis, do a CT, no progression, continue 4 cycles, and then send for cystectomy.
In case if the patient has taken 2 cycles of chemotherapy and they are opted for surgery.
Okay.
So will you be giving adjuvant chemo in that setting?
Oh yeah, that is a very difficult question, because we will probably find no information if they have already received 2 cycles of neoadjuvant and 2 cycles are pending. So whether you give it as adjuvant, okay, I think we will have to take it on a case-to-case basis and take a call. If the patient say comes back post-op histopathology comes back as more than PT2 and node positive, maybe we should be considering giving the adjuvant setting. But if you are giving an adjuvant therapy, maybe we should complete another 4 cycles as adjuvant. So 2 may be inadequate if you are giving as an adjuvant strategy.
And the last question.
Yeah.
Dose-dense MVAC and GC. Is a comparison in the adjuvant and neoadjuvant setting. Is the Vesper.
That's the Vesper. Yeah. The
Vesper. Still, why are you preferring GC in our scenario?
So dose-dense MVAC versus in the Vesper trial showed significant progression-free survival with the use of dose-dense MVAC. But the issue is it can only be used in very young fit patients. So the toxicity with the dose-dense MVAC is primarily multiple toxicities, mucositis, neutropenia, severe fatigue, because it uses adriamycin, methotrexate, and vinblastine, all of which are kind of very, very difficult to tolerate drugs. So I've used maybe in 2 patients while I was at Amrita. So it was very difficult to manage, toxicities, especially mucositis. It's a big concern when you're using adriamycin and methotrexate simultaneously. Toxicity is the primary reason. There is some data in the neoadjuvant setting, so I haven't put it up because of lack of time. So the dose-dense MVAC and GC, there is comparable responses and survival. Numerically slightly better with dose-dense MVAC, but survival has been comparable with GC and retrospective data. So I think GC is a fairly good option because many of these patients tolerate it very well. So we can at least, and if you see the dose-dense MVAC, 60 to 70% were the 60% was the completion rate. 30 to 40% had to stop dose-dense MVAC in between. So the default rates are also higher with dose-dense MVAC. Toxicity is the primary reason.
Yeah, one question, if can I?
Yeah.
Given the context of inability to use dose-dense MVAC in a lot of patients,
correct,
and that GC has only shown non-inferiority, and the ABC meta-analysis also showed that in a subset analysis, that T2 really does not, the outcomes,
adjuvant,
either in the neoadjuvant or in the adjuvant setting. The guidelines recommend that we give chemotherapy to all T2 and above.
Correct.
Do you really think that it will make a difference, or can we safely omit neoadjuvant in the T2 setting, pure T2?
Pure T2. So pure T2 node negative, as I already mentioned, the survival is in excess of 60 to 80%. They are a good subset of patients. But I think as per the current data and the meta-analysis, which have included all T2 patients also, maybe we would still continue offering neoadjuvant chemotherapy to these patients, because the subset numbers would be few, T2, T3, T4. If you look at the VESPER, only node negative patients were included in the trial, and I'm not really sure whether we can, based on the current guidelines, omit chemotherapy in the T2. As you said, the benefit may be less, and we would be over treating a lot of patients. That is true. But I think as per guidelines, we would not be able to say confidently that we can omit chemotherapy in these patients. Neoadjuvant.
Just one comment on this. Yeah. So we had a lot of experience on this neoadjuvant chemotherapy in a hospital because it was a high volume center. We are operating 30 to 40 cases per year. So I think we should all go for a neoadjuvant chemotherapy, because as a urologist, a lot of time we have fear that whether we can operate, but definitely it will not change your planes of surgery. We never experienced any difficulty in that planes. And always try to operate within 3 months of chemotherapy, because that is the best result you can get for your patient.
Correct.
Yeah.
I think the timing of surgery is also very critical.
Yeah,
as you
within
said.
3 months you need to operate the patient.
Yeah. Clinical, pathologically, yeah. Correct. That is probably another reason.
You can't be very sure that if imaging is negative, doesn't mean that the node is negative. So ultimately, you will be knowing that the node is positive after skipping the neoadjuvant and doing the cystectomy. So
yes,
you must have missed the bus by that time.
Correct. Taken as Ashwin also mentioned, in T1 the node positive rate was 7 to 15%. So the T2 the rates must be much higher also. Yeah.
Sir. So have you used nivolumab in your practice?
Yeah, adjuvant nivolumab we have used in a few patients in the adjuvant setting, right?
Yes.
Yeah. So it has been maybe less than 2 or 3 patients.
What is the present cost? Anything?
Cost, yeah. So the company has come out with a revised program where the total cost is for 1 year therapy probably would be coming around maybe around 10 lakhs, roughly, maybe even lesser, depending on the dose. So the 240 mg is the standard dose that is recommended, but many a time we tend to use 3 mg per kg dose for many of these patients. So roughly 10 lakhs would be the cost, I think, for the adjuvant strategy now.
For cisplatin ineligible patient,
yes,
only phase 2 data is there, but still single agent immunotherapy is an option now. Are you using it?
Neoadjuvant.
Yeah.
So we haven't used for in the neoadjuvant setting. No. The data is coming up, but probably it will come into the guidelines, I think, especially in the cisplatin ineligible scenario. Must be a good option for patients if they can afford.
So we'll close the session.
Thank you, doctors, for your wonderful discussion. Now it's time to provoke your thoughts with more interesting session. Moving on to the next session, the quiz competition for the PG students. Our food counters are open. I request the PG students to stay back and occupy the front 2 rows. We'll restart the session at sharp 2 p.m. For the quiz competition, we have a trailblazer in this area, none other than Dr. Rajinikanth, our quiz master for this day. Welcome, sir. I request all the PG students to occupy the first 2 rows.
PGs, please, can you come to the front rows? Please. And try to leave one seat in between. The quiz is going to be actually exciting and there are a lot of prizes to be won. So it will be worthwhile. And please leave one seat in between. Shall we start? Come, please. So, the interesting thing is, it's going to be a revision. Almost all these questions have been covered in the morning session. So there won't be any new questions. If you have listened carefully to what has been taught, said and discussed here, I think you'll get the answers to almost all questions. So I expect a high scoring competition. Please leave one seat between you.
Just to break a big surprise, we have a cash prize for the winners. Third prize is 5,000 rupees. Second prize is 7,000 rupees. And the first prize will be 10,000 rupees. The winners will be announced after lunch.
Can you leave one seat in between? Yeah. So there will be only 20 questions. Please, all of you, please write your names and the institute you're from. Let's start from there. Last time we had a blank papers where we didn't know who wrote those. Please. So each questions will be of 2 marks each, no negative marks. So I'll give roughly about 1 minute for each questions, or maybe little less than that, and then we'll go to the next questions. After the quiz, I'll be announcing the answers and we'll correct the question. So all are seated? Comfortable? Can I start? All of you got your papers? Back rows? You got your paper? Yeah. Your name and institute. Please write the name and institute. So okay. So the first question is, so this was the ad Amul gave in 2017 when one of the finest actors in the Hindi film industry succumbed to bladder cancer. Can you identify the actor? So okay, the first question. So write down the answer. I want the name. So can you identify this personality and how is he related to bladder cancer? So his name and how is he related to CA bladder? So you can see an X-ray there. There are pointers giving you clues. So my question is, what is the histological type of associated malignancy, and what's the organism associated with this condition and its intermediate host? So an easy question. So this is a procedure being done. So identify it, and when do you do that? What's the indication? So Lynch syndrome, it's not associated with, or it's least associated with which of the malignancies? So what's the risk factor for squamous cell carcinoma? The risk factors for squamous cell carcinoma of the bladder includes all except. So recently, last year, with a large international multicentric study was published evaluating the prevalence of urinary tract cancer in patients with hematuria. So can you name the study? And what was the prevalence of bladder cancer in patients with visible or gross hematuria? So identify the study or name the study, and what was the percentage of bladder tumors in gross hematuria? And Sheldon's grading or Sheldon's staging is done in which type of bladder cancer? Another thing, which type of TCC can mimic adenocarcinoma of the bladder? Which subtype of TCC can mimic adenocarcinoma of the bladder? So these are the various pouches, the pictures representing the various pouches and the name of the pouches. A is Indiana, B is Maine, C is Gonim, and Studer. The numbers are 1, 2, 3, and 4. You can match the pouches with the names. So boundaries of the triangle of Marsil and its significance. So we do send a lot of CT urogram in bladder cancers. So what is the average radiation dose? You need to just give me a range or a number. If it's within the range, we will give the mark. So in the background of radiation exposure, this question is, in CT, we do take CT in almost many of these patients, but in which patient it is most indicated? Or in which patient you can't avoid getting a CT urogram? Is it in a 50-year-old male smoker who has 15 years back years with a routine urine showing 3 to 4 RBCs, a microscopic hematuria obviously, 70-year-old female with dysuria and gross hematuria, or a 65-year-old female patient, non-smoker, a routine urine showing 3 to 10 RBCs? Or is it a 45-year-old male, non-smoker, routine urine showing 10 to 20 RBCs per high power fluid? So, who has to have a CT urogram must in this scenario? Like now. So who described the classical pubic method of obturator block for preventing obturator jerk or reflex during TURBT? The block is known in known by a name. So extended lymph node dissection CA bladder include all except presacral nodes, Lockett's nodes, obturator nodes, or none of the above. Means all nodes are taken in extended lymph nodes. So another 60-year-old male, type 2 diabetes with preserved renal function, a performance status 1, diagnosed to have TCC bladder stage 3A disease. So what is the most preferred regimen for neoadjuvant chemotherapy? DDMVAC with a growth factor support for 3 to 6 cycles, gemcitabine plus cisplatin for 4 cycles, gemcitabine plus carboplatin for 4 cycles, or single agent gemcitabine. So, out of the following, which is not a valid treatment option for high-risk NIMC with TIS who is refractory to BCG therapy? So, a patient refractory to BCG therapy, high-risk and non-muscle invasive bladder cancer, which of the following is not a valid treatment? Is it cystectomy, intravesical chemotherapy with mitomycin, or pembrolizumab, or nadofaragine firadinovac VNCG? Which is not a treatment option. So among the following, who is a candidate for surveillance alone in the case of non-muscle invasive bladder cancer? Low-grade urothelial carcinoma with the multiple CIS, high-grade urothelial carcinoma single lesion, TA lesion less than 22.5 centimeter with no CIS or any other lesion. Low-grade urothelial carcinoma single lesion with no CIS. High-grade urothelial carcinoma with multifocal disease and large lesion size of greater than 3 centimeter. BCG unresponsive T1 high-grade urothelial carcinoma. Which is the fibroblast growth factor receptor tyrosine kinase inhibitor used in the treatment of bladder cancer? Erdafitinib, enfortumab vedotin, avelumab, pembrolizumab, sunitinib. So, which is a fibroblast growth factor receptor tyrosine kinase inhibitor? So, an 80-year-old male, CKD, diabetes, presenting with gross hematuria, diagnosed to have TCC stage 4 disease, bone mets and nodes, ECOG performance status 2 and anemia. What is the best treatment options available for him? Pembrolizumab, gemcitabine and cisplatin, gemcitabine alone, or best supportive care, or radical cystectomy? So, okay, before going to the answers, shall we collect the... So all these questions, most of the answers are from the previous talks we had. Let's go through the answers. 5 minutes, I'll just rush through the answers so that you'll know what all things, what did you answer and what I think is the answer. So it was Vinod Khanna. This was Morales. We talked about him, he doing the first intravesical BCG. And this was his paper in 1976 that changed the treatment of non-invasive muscle cancer forever. So this is squamous cell carcinoma. You can see the stone, and then you can also see the calcified bladder wall. The calcified bladder wall. That shows to a probable infection with schistosomia, and the snail is the second vector. So procedure is, you can see the CA bladder, the carcinoma bladder. So this is a transarterial chemoembolization of the bladder tumor being done. We do it for MIBC with intractable hematuria. So Lynch syndrome, there are controversies. It can be associated with renal cell carcinoma, but the other malignancies are common, and it's very rare for renal cell carcinoma to occur in Lynch syndrome. So the answer is smoking. Smoking usually causes TCC, squamous cell carcinoma. All other causes are well established. Prostate cancer incidence is, that was another question. Yeah. So the study was identify the recent multicentric study, which include 11,000 persons with suspected urothelial carcinoma, and they found that in a visible hematuria, the incidence of bladder cancer tumor is 25%. So any person, beware, 25% is the chance of having a CA bladder. So Sheldon staging is for urachal carcinoma. So it's a microcytic variant of TCC that can mimic the adenocarcinoma of the bladder. So these are the correct answers. Studer, Indiana, the mains. You can see the transverse colon, the in non-irradiated bowel that can be used. And the guanine, where it's a W-shaped reservoirs. So this is a... I think this was a question, sorry. The boundaries of triangles of Marseille is medially the border of L5, the medial border of psoas muscle, and the L of the sacrum. 4 nerves and 6 vessels are there. It's a landmark for our lateral pelvic node dissection. So radiation dose of CT is around 15 to 35 millisievert. So in this patient, the 65-year-old female patient, because of her age, is at the highest risk of having a malignancy. So the other patients, actually there is an AUA guidelines where they stratify the patient into mild risk, intermediate risk, and high risk. In this, the 65-year-old female, because of her age, falls into high risk category, and she has to undergo a CT urogram. Because on the intermediate risk patients, ideally the first sitting, we need to do a cystoscopy only. So this is a patient who should get a CT urogram. So Labat was who described this procedure and perfected it. So extended lymph node dissection in CA bladder. You'll have to know the boundaries. You'll have to learn the boundaries. So it's all these nodes are removed in extended lymph node dissections. So it's a dose done. It's MVAC. He is an young guy. So the progression-free survival has been demonstrated mostly with dose-dense MVAC. Not a valid treatment is intravesical chemotherapy with mitomycin. BCG failure, high grade, not preferred. So the surveillance alone is a low-grade urothelial carcinoma, TA lesions with no CIS. So this answer is adaftinib. So that is a fibroblast growth factor receptor tyrosine kinase inhibitor. All these questions we have already discussed here. So this is pembrolizumab has a role in palliation even. It palliates better than bed supporting care. The answer is pembrolizumab. Thank you.
Thank you, sir. Thank you, dear doctors. A gentle reminder, kindly fill the feedback forms and please remember to collect your certificates from the registration counter. The afternoon session will commence sharp at 2 p.m.
localized curative bladder cancer. Do not offer TURBT or radiation. Then partial cystectomy, yes, favored. And for solitary tumors, very good locations like bladder dome. Single tumors, single point, no carcinoma in situ. But again, NCCN says avoid as monotherapy, preferably with NACT you can think of as bimodal. Then again, lots of studies on bimodal approaches, which I'm not going into, but then this slide, which shows TURBT with chemotherapy, is now, it was an earlier talk, but see the recurrences, the local recurrences were 71 when you stopped after chemo. The problem is, this slide now becomes the 2023 hot topic. This was the base on which now the most novel approaches are going on. But as of now, bimodal is again not favored in 2023. Trimodality, the most evidence, the most supported by all the guidelines. 3 components, maximal TURB, concurrent chemoradiation, close surveillance. Now coming to the third point, close surveillance. This is the most key point. If you don't get your patient onto close surveillance, then TMT is not for your patient. Then choosing the ideal patient. All the criteria that I mentioned is for ideal criteria, but unfortunately only 6 to 19% of patients fit in this criteria. If you get this highly select patients, then you get good results. But that doesn't mean you can ignore T3, T4, N0, M0, incomplete TURBT. Sometimes it's not possible to do a maximal complete TURBT. You need to prime it with NACT, undergo a relook. And then maybe you can undergo a relook TURB. As the size of the tumor increases, the response with TMT decreases. That is why they keep the cutoff. But still NCCN offers its as category 1 evidence. Then TURB, you all know we need to have a maximal and complete TURBT. And the 5-year outcomes, all the complete response rates were all better when it was done incompletely. NACT. NACT is not a actual part of TMT approaches. All the studies that have been were with radical cystectomy. There was one BA06 UK trial which was given CMV chemo followed by surgery or radical surgery or concurrent chemo radiation. That's why UK trials still adopt, and their NICE guidelines also give NACT. There are pros and cons. Now, response to NACT has been associated as a significant predictor of overall survival. If the patient has shown good response to to NACT, that means he will really do well in bladder preservation. But there is a con to it, and that is when the patient comes to the active definitive treatment, that is concurrent chemo-RT, there is a delay in the treatment, they develop neutropenia, and then there is a definitive treatment outcome problem. Still, the preferred regime is gemcitabine or dose-dense MVAC, which was already dealt with Dr. Arun. Concurrent chemoradiation, the 4 pillars of the studies, where all the RTOG studies, the Erlangen series, the BC 2001, MGH series, umpteen number of studies show chemoradiation makes bladder preservation possible. The standard was earlier, was a longer course, 6.5 weeks duration of radiation, Monday to Friday with weekly chemo, usually cisplatin, but that has now changed to a shorter fraction, that is 55 gray in 20 fractions. So you don't have to go through a longer course. Earlier there was split course, continuous course, in between stop at 20 fractions, go for a relook TURBT, but that's also now not needed with hypofractionated dose. And hypofractionation, that means give a larger dose with shorter fraction. Does that decrease your outcome? No. Every study has shown that the loco-regional control and the overall survival was better with that. So how do you deliver RT? The patient positioning is important. You have to make him or her actually comfortable during the entire procedure. So it should be a position that you can reproduce daily. What are your target volumes? Post TURBT bed, difficult to identify after a complete one. entire bladder with any extravesical extension. You don't include the prostate or the vagina if not involved. But if the bladder neck is involved, you have to give an extra margin, and then you create an outside margin to make your planning volume. Radiation technique, this was when I was doing my PG. We used to delineate out the bladder with contrast and then look at the bony marks and just give a 4-field like box. But that has now changed. When I passed out, that time it was the start of CT scan images. You take CT scan, you see the image, you see the tumor, draw it out, and that brought out to 3D conformal. That is, to the general shape you can conform. With that blue lines you can see you can conform to the general shape of the tumor. Again that evolved with intensity modulated, where you don't conform to the general shape but to the actual size and contour of the tumor. So here you could give more dose. You see how the higher dose, these are the higher dose volumes which have currently moved away from the rectum. So that was possible, and bladder cancer was able, we could do hypofractionation. Now with the advent of new machines, IGRT is possible, that is image guided. That is, RT has more become precise because bladder is always subject to variation. You have filling, emptying, all this. Usually we plan in empty bladders because it is reproducible. You don't have larger volumes. But if you have a patient you want to give boost or you want to escalate the dose, you plan in actually a full bladder so that only the microscopic bed area needs to be escalated. So IGRT has a capable of, see the areas which I have marked, it is possible in the machine to take a CT scan at the time of radiation. So what happens is that this is your planned CT scan where you have drawn all your volumes. That is the CT which you take after you position the patient on the couch and see how well the soft tissue you can match. So you can see the bladder filling, look into it and just give radiation. So more localization and decreased dose to normal tissues. It has become more adaptive, that is you create plans, daily plans, and take up plans which you like. Like you create a number of plans, how does the bladder each day, as per that you can conform your plan. Now they are thinking about dose escalation, that is give higher dose to where the tumor is, not to the whole bladder. So you can get better outcomes, and that is the latest Raider trial. The Raider trial is possible just because you have IGRT. You cannot do it without that because you need to daily see and monitor with CT scans. So you can give a higher dose to the bed and a normal or a tolerable dose to the bladder. So unnecessary toxicity is avoided. And it has also shown better survival outcomes. So dose escalation is also now possible in bladder preservation. Surveillance is, again, I'm telling you, that is the key. If you can get the patient on surveillance with regular cystoscopy, imaging, urine cytology, then only you can attempt a bladder preservation. Evaluating tumor response. The evaluating tumor response is no visible tumor, but bladder preservation, we actually achieve it slowly. 80% of people usually achieve it. Where we fail is often in the distant. Recurrences, majority of the recurrences are non-invasive. You can manage it locally, and the residual ones can be managed with salvage cystectomies. Comparisons. As of now, there is no RCTs which directly compare because the UK SPARE trial was closed, but there is a latest trial that is the best data that is outside an RCT, that was the Zlota and colleagues, radical cystectomy versus trimodality. This is the best data which has shown comparable survival rates and regional free rates with both TMT and radical cystectomy, and the quality of life was scored higher in the TMT group. The latest update in Jan 2024, again a 2-year study, also favored TMT. Now what is the practice patterns? Actually everything looks rosy, but we never get bladder preservation. Actually I think, like the morning speaker told, if you offer radical cystectomy for a non-metastatic MIBC, in the same platter you should also offer bladder preservation. Brachytherapy, a word, it is only considered as a boost to external beam radiation. You give 20 fractions by external radiation, and then you can consider of a boost. There are two schools of thought, the French school and the Dutch school. The French school says you get in and you do a partial cystectomy and then do brachy, and the Dutch school says it's lot of complications, so avoid a partial cystectomy, just do a brachy and come out. Tetra model therapy. Now this is gaining interest. This combines TURBT, a maximal TURBT, induction chemo radiation of 20 fractions followed by partial cystectomy with pelvic nodal dissection. If you see, the MIBC recurrence-free survival was 97%, the cancer-specific survival was 93%, and the overall survival was 91%. The number of patients were 105. Now it has to come up in a big way, but many are favoring the Tetra model too. Novel approaches. So what does 2023 have for us? Combining immunotherapy with radiation. That is chemo-RT with PD-L1 inhibitors is one arm. Second, retained bladder study. The retained bladder study is a risk-adapted approach. That is, if you respond well to chemo and you undergo a TURB, you have no disease, then why should you do a radical cystectomy? That was the question. So they did mutations. The mutation genes were ATM, the excision repair genes, and the FAN genes. If you have mutations in those genes, that means you will respond well to cisplatin-based chemo. So that is the retained bladder study, and that didn't meet its endpoint. So the retained bladder 2 study was also started with immunotherapy along with NACT. And to summarize, bladder preservation paradigm shouldn't be offered as a choice when the surgeon doesn't want to operate or when the patient doesn't want to do surgery. It should be in the informed consent decision making itself. And I think MDTs also will help in that. And this is the current paradigm. You see, it stands equivalent with RC. And with this, thank you so much. This is our latest machine capable of IGRT, SRT, and SGRT, and it was our New Year gift. Thank you for your patient listening.
Excellent presentation. And as rightly mentioned in the first slide itself, only 6 to 19% of the patients are fit for ideal candidates for a bladder preservation protocol. So the basic problem with the bladder preservation is that we don't get ideal patients. So what patients who are undergoing bladder preservation are usually not offered surgery or patient not wanting surgery. So we can't actually, we don't know whether the results are fine or not. And one or two questions I want to ask is, are there any new inclusions like molecular markers, anything biomarkers?
Yeah, biomarkers to assess response to cisplatin chemo and radiation response was there, MR11. But that was also not showing any promising result. Again, they have started the restudy of the MRE.
Okay, they can't be included in the current scenario. And how will you assess, once you start the patient on neoadjuvant chemotherapy, how will you assess the response rate? Because
in between, earlier there was in the longer trial, when you used to give 36 fractions. When the patient didn't have a complete TURBT, we split it in between at 20 fractions. We send the patient again for a RURBT, and if the patient has not responded or is having residual disease, the patient was supposed to undergo cystectomy, what was the school of thought. But as I told you now, if you have a maximal and complete TURBT, then that continues, you needn't take the split. And also, if you are not able to do a TURBT, you give the chemo, which is of the protocol, which is actually not in TMT, but everyone practices. After chemo, the tumor might disappear. You can take a biopsy and see, and then go ahead with the chemo radiation. In between, nowadays, no assessment. You assess only after 3 months.
The split approach is not?
No, because the fractionation changed to 20 fractions.
So the topic is open for discussion.
Thank you.
Radiation-induced second cancer. What are those rates that you discuss with the patient?
Actually, they only when the patient comes first, they bothered is first is preserve the bladder. So even though we try to explain, can I keep my bladder is the first question. Yes, you can keep, but then you should be on close surveillance. Within 2 years is the chance of a first non-invasive superficial recurrence is what we see. But studies have shown, though that they have shown that in the range of more than 20%, invasive recurrences are less than 20%. Because radiation response is slow. That is why initially you get to see superficial recurrence. Salvage cystectomy, I think by the LOTA study is 13%. Actually, very, very less. Yeah, but then we don't get very young patients, so no one gives us. No, but I don't, the chance of, if any of the studies you take, no one has mentioned a considerable rise of second cancers. Yeah, not a significant rise. They have commented on many, I'm not saying they have said zero, but the 2001, right.
So if you see the all data on second malignancies after, say, chemoradiotherapy in pelvic malignancies. So we give chemoradiotherapy for pelvic malignancy, various indication. Carcinoma cervix is chemoradiotherapy. Adjuvant radiotherapy for CA endometrium. CTRT for bladder. So there are millions of people who have received RT or chemo RT to the pelvis. And the RTOG and the Porter group have done a systematic analysis of second malignancies in the pelvis, and then they have compared it with general population. There is no difference. I don't know from where you got this 5%. I mean, I don't know about that data. I will definitely look into that. But the 5-year risk of pelvic malignancies is comparable to that of general population. So your pelvic malignancy as a whole, you can have rectal cancer, you can have cervical cancer, endometrial cancer, prostate cancer. Everything will be included in the pelvic malignancies. But these are not purely radiation-induced malignancies. So some, the people are, 1 out of 3 at some point of their lifetime will develop some kind of malignancy. So that is the statistics. So somebody survive longer, they will develop pelvic malignancy. They have a very good chance of developing prostate cancer if they are males. It's a very high risk, provided they survive long. A rectal malignancy, bowel, another cervix and endometrium. But when you see as a whole, when you compare those patients who received pelvic radiation versus someone who have not received pelvic radiation, as a general, no increase in second malignancy due to RT.
One of the original paper is actually by Kishore.
Irrespective of 5 year or 10 year, there may not be. I mean, I'll check and I don't know about your data. I'm sorry, but this is what we have learned in our textbook, and traditional teaching was this.
One of the paper is by Kishore, I think, isn't Kishore? Yeah, can you just?
There is a study which was like on radiation to prostate producing secondary bladder malignancy, and that was incidence was high with the bladder actually. The other way around. I'll tell you 1 second. I don't remember exactly.
When we talk about second malignancy, we should have thousands of patients in both arms. We should not be on it, hundreds of few number of patients.
It was it was 44 patients of bladder cancer. Of bladder cancer.
44 patients, it's a very small study, and to make that comment that 5% risk of second malignancy is truly an injustice to radiation as a modality of treatment.
You talk about the complications. See, you have delivery methods, modifications, all those things have come down the complications. But when the patient has got the bladder complications, contracted bladder and telangiectasia, that will make the life miserable. So those things are the negative points. of radiation?
Usually, acute reactions set in
No,
within 3 to 6 months.
Not acute.
Late reactions, when they start, they take minimum 2 years, but they don't go above that. Usually, patient gets. This is not like for lifelong.
Usually, because we are the
because
we are the people who
we also see them during follow-up.
Difficult because it is extremely difficult. Their life will be miserable, bleeding every now and then, and clot retention, irritative bladder symptoms. They are so miserable. They will require you to remove the bladder, request you to remove the bladder. So it is so miserable if they have it. But all these modifications, the incidents are.
But that is all possible due to the advanced RT techniques. Not in all the studies wherein earlier.
It happens, and their life, the person who is getting that, their life is so miserable that they'll come and beg you to remove the bladder.
But that, I think it's an acceptable toxicity not seen. We also do bladder preservation, and we have patients.
I am not against radiotherapy or bladder preservation, but when you have this, my question is, do you have any other methods, suggestions, apart from what you have told, that to reduce the bladder complications?
No, only the evolvement techniques.
I think, so we are running short of time. I think, Dr. Jenny, you have the new gadget now. I think that can have a better precision regarding the delivery of radiation to bring down the adverse events with regard to the radiation.
One of the practical point I want to highlight is the follow-up is very important, and majority of the case what happens is what we have sent for bladder preservation, majority of the patient doesn't come back to us because they assume that it is cured and they don't follow up. So if at all bladder preservation has to be a protocol, the follow-up has to be very stressed.
You said you can just target only the tumor part, but bladder is a compliant organ, mobile organ.
That is what I told by IGRT. The plan of the day approach, you can
treatment also when bladder distance with urine.
No, that is what I told. We treat in empty bladder.
Oh, you put a catheter.
We treat in empty bladder. Yeah, we treat in empty bladder. That was the first thing that I told. And in case the treatment takes only less than like 10 minutes.
So do you catheterize or you don't?
No, we don't catheterize. We ask the patient to empty his bladder. We make him lie down, take the CBCT, and see if it is not completely empty. We ask him to wait out little more. Sometimes some patients need us 2 to 3 times of voiding. And then we treat the patient.
So the entire duration is 10 minutes?
Yeah, less than 10 minutes.
Okay. So if there are no more questions, we'll close this session. Thank you for the excellent presentation.
Thank you, doctors, for the illuminating insights. Now it's time to announce the winners of quiz competition. I request Dr. Rajnikant to announce the winners, and I request Dr. Ginal Kumar to distribute the prizes.
So that it was a very closely fought quiz competition, and the third prize goes to Ravi Gaur from TD Medical College, Alapi.
Man of the match.
And the second prize to Mr. Prithvi Vasant from Trivandrum Medical College. And the first prize and the star, Nishant P. GMC Calicut.
As we move further, the next topic is variant histology management. To chair the session, I request Dr. Mohammad Farooq, Consultant Urologist, MES Medical College, Perinthal, Dr. Siddhalingeshwar, Assistant Professor, Department of Urology, KMC, Manipal. No, sir, we changed it. Sir has to go.
Next is a very interesting topic. Interesting because it is very rare, and with respect to its therapeutic implications. We already had a small discussion about the plasmacytoid variant. So we want to hear about all the variants. Dr. Seeval, sir.
Very good afternoon all. Thank you chairpersons, and thank you Suresh Bhatt sir for having me here. It's a great opportunity, and sorry for cutting into line. I think I'll be late for the flight, so I requested for a rescheduling of this presentation. So I have been asked to talk about variant histology. I'll be touching upon the introductory part as well as the management of variant histology. I beg to differ, sir, that variant histology is rare, and you will find out why in the next few slides. So what do we know about variant histology till now is that, it constitutes to almost about 25 to 33% of cases which are documented in the literature. However, the literature is not very specific about the true incidence of variant histology. But what we know till now is that it has a very aggressive behavior. It has a higher propensity to have a locally advanced disease at diagnosis, and they are more commonly upstaged at radical cystectomy with a significant hazard ratio of 2.77, and unfortunately they do not respond uniformly or equally well as expected with a conventional urothelial cancer. So coming to the definition, variant histology, it describes any distinctively different histomorphological phenotype of conventional urothelial cancer that is believed to be derived from the urothelial cell line and is typically admixed with conventional urothelial cancer in the same tumor. So it's a proportion of a differential histology within the urothelial carcinoma that is seen in the bladder. The recognition of this kind of a differentiation is important because, like I mentioned before, it may be associated with a differential clinical outcome. It may have to be dealt in a different manner with a different therapeutic approach, and the awareness of this unusual pattern may be critical in avoiding diagnostic misinterpretations. Now, is the terminology variant appropriate? In the recent WHO definition, they recognize that variant is a terminology which is typically associated with a genomic alteration, and therefore the recommendation now is to use a subtype. So typically any differential histology should be categorized as a subtype of urothelial cancer, and the terminology variant should be preferably avoided. A more appropriate or a better alternative definition would be to title them as urothelial carcinomas with divergent differentiation. This is the 5th edition of the WHO classification, and these are the variant or the subtype of histologies that are possible in a bladder cancer. So to sum it all, if you look at a bladder cancer as a whole, there are 3 different categories now. One is a pure urothelial cancer. The other subgroup where there is a urothelial cancer with a divergent differentiation, all these squamous differentiation, glandular differentiation, so on and so forth. And then we have pure non-urothelial carcinomas of the urinary bladder, the squamous cell carcinoma, adenocarcinoma, so on and so forth. Only the small cell category or the neuroendocrine variety of bladder cancer is categorized separately because it has a differential, distinct prognostic and therapeutic implication. So, in the initial slide, I said that variant histology is bad, higher aggressive behavior, higher propensity for upstaging. But is this true? Are all variant histology is bad? This paper from Ashish Kamath, published in 2015, looked critically at all the varieties or all the variants or subtypes of bladder cancer and found out that not all variant histologies are bad. There are few which are very low risk, like the lymphoepithelioma like cancers or the villus like cancers, and a few low risk cancers like the squamous differentiated urothelial carcinoma, the microcystic carcinoma, so on and so forth. In fact, a pure urothelial carcinoma can behave more aggressively than certain subtypes of variant histologies. Now coming to the management aspect, the key to management of variant histology lies in the identification of the variant histology. The cornerstone of identification of variant histology lies with immunohistochemistry and not with the conventional histopathology. So we'll start with IHC. What all is IHC useful in variant histology for? Almost all aspects of variant histology evaluation is dependent on IHC. For confirmation of diagnosis, for subtype differentiation, for a predictive biomarker evaluation, and IHC can also help the doctors and clinicians in therapeutic treatment decision making. So coming to the subtyping, IHC can be utilized to find out what kind of a subtype we are dealing with. So this is a table. I am not going to confuse you with all the details, but what I can tell you is that the moment the pathologist identifies that there is something more than a conventional urothelial cancer, a panel of IHC markers need to be employed to find out what the accurate subtype is. This is the panel of IHCs that needs to be used to assess the biomarker evaluation, wherein presence or absence of a particular biomarker can not only prognosticate but also help in therapeutic approach. For instance, if there is presence or upregulation of TP53 and RB1 are present in a small cell carcinoma, these are tumor suppressor oncogenes, and if they are present, the outcomes of this particular small cell carcinoma will be favorable rather than when it is absent. Similarly, if there are mucin stains which are positive in an adenocarcinoma, the outcomes are going to be poor. So the IHC panel will not only subtype, it will also help us evaluate with certain biomarkers and assess or predict the response possible in these patients. Coming to IHC for therapeutic assistance, there are certain markers, if when expressed, can have a targetable or an actionable therapeutic approach. For instance, in adenocarcinoma, which is known to secrete HER2 in excessive quantities, the presence of HER2 overexpression can be preferentially targeted using trastuzumab or any other targeted molecule with a favorable outcome. Similarly, there are targetable genetic alterations like the FGFR3, ERBB2, DLL3, especially in small cell carcinomas. And we all know that presence of immune checkpoint inhibitor overexpression like the PDL1 expression can make these tumors more amenable with a better outcome for the immune checkpoint inhibitor therapies. A combinatorial approach needs to be adopted when we use these IHC kits to find out what type it is and to see if there are any targetable molecules so that these patients can have a better outcome. The second important or the second integral aspect of evaluation of variant histology bladder cancer is the molecular analysis or the molecular classification. This is a consensus molecular classification of muscle invasive bladder cancer evaluated from the Cancer Genome Atlas and published in 2019, which has a repository of around 1750 transcriptomic profiles. And this can actually act as a good data set for any further evaluation that we need to do. What this told us is that bladder cancer can be, in a molecular parlance, classified into 6 subcategories, and surprisingly, historically what we know is that 80 to 85% of all bladder cancers are urothelial based on the histopathology, but when we look at it from a molecular perspective, we find out that only about 60% of them conform to a pure urothelial carcinoma category. Not only that, only about 47% of them in the upper block that I have mentioned are of the luminal variety, which is attributed to have a favorable outcome to treatment. So molecular analysis has also significantly altered the way we look at variant histology. I'll take another 2 minutes. So these are the subtypes possible, and the same consensus classification also evaluated and noted to have that there is a significant difference in the way these patients are treated and their outcomes are. Therefore, it is important for us to understand the exact subtype of bladder cancer that we are dealing with. Not only does molecular classification subcategorize these patients, it also helps prognosticate into patients who have low risk and intermediate risk as well as high risk bladder cancers with variant histology. I'll skip this. The molecular analysis also looks at certain expressions like the BRS3 enrichment, which can also tell us whether a particular individual can have a favorable response to intravesical BCG therapy in the presence of a subtype of bladder cancer. I'll skip this. Yeah. So briefly about management of NMIBC with a variant histology. The understaging rates are pretty high, almost 50% of them are understaged. The occult metastasis rates are close to 44%. The progression rates are also quite high compared to the standard 17%. You look at 40% in patients with variant histology tumors. This is again a paper from Ashish Kamath et al. Published in Journal of Urology in 2015. They have shown that both progression of disease while on intravesical BCG therapy and immediately after intravesical BCG therapy is complete are significantly different than in a conventional urothelial carcinoma. So this is the cartoon which shows the broad way we manage NMIBC with variant histology. For a conventional urothelial carcinoma or patients with squamous differentiation or glandular differentiation, nested variant or any other rare variant, the pathway is more or less same. The only difference comes when there is a recurrent TIS or a recurrent T1 disease, you offer a patient's early cystectomy. For all other patients with non-muscle invasive bladder cancer, it is a direct consideration of early cystectomy. It's only the small cell variant which has been shown to be very amenable for neoadjuvant chemotherapy, where neoadjuvant chemotherapy can be considered, and subsequently patients are offered radical cystectomy, and this is for a non-muscle invasive bladder cancer. Coming to the systemic therapy in variant histology or subtypes, the optimal strategy is not yet known. Initially it was thought that all these were biologically very aggressive and therefore should be treated with systemic therapy uniformly, but what has been now shown is that systemic neoadjuvant chemotherapy may not be helpful in all variant histologies, and therefore it is important to understand the subtype that we are dealing with. Only of late, all these guidelines have come up. The latest is the ASCO GU 2022 consensus guideline, which has told us what to do and what not to in this realm. Coming to role of immunotherapy, immunotherapy has shown a marginally beneficial response in different subtypes of bladder cancers. It is most noted in the sarcomatoid variety, and when present, they respond much better to immunotherapy than to chemotherapy. I'll skip this. This is the algorithm for management of muscle invasive bladder cancers with variant histology. Wherever possible, we should consider offering a radical cystectomy. If there is a small cell variant, we should consider neoadjuvant chemotherapy because it's a very aggressive disease and can have a significant occult metastatic rate even at diagnosis. And for pure squamous adenocarcinoma, we should, in addition to cystectomy, also consider adjuvant radiotherapy after the surgery is over. I don't think I have time to discuss each variant in detail, but what I can tell you is that cystectomy forms the cornerstone of treatment in a majority of these patients. Whenever adenocarcinoma is present, it is most of the time locally advanced and it is responsive to 5-fluorouracil, leucovorin and oxaliplatin. The micropapillary urothelial carcinoma is again one of the commoner variant histologies. What has been shown is that neoadjuvant chemotherapy or intravesical BCG therapy do not impact the treatment of micropapillary carcinoma, and therefore whenever diagnosed they should be offered upfront cystectomy. I will not go into this. The nested variant is a milder variant which has equivalent outcomes like a urothelial carcinoma. It's only the neuroendocrine variant which is very amenable to systemic chemotherapy upfront. There is some data now to show that radiotherapy can also be equally effective in the unresectable subset of population. The urothelial carcinoma with the squamous differentiation is the most commonly reported. It is a relatively lesser aggressive pattern and very amenable to intravesical therapy with BCG. The urothelial carcinoma with glandular differentiation is also a milder variant and amenable for intravesical therapy. And to summarize, the knowledge of variant histology is evolving and the incidence is definitely higher than that is thought, especially with the availability of molecular data. Certain variant histologies are aggressive and needs differential approach. There are unfortunately no standard guidelines as yet. Systemic therapy should be contemplated when possible, and in situations where the subtype is aggressive, upfront cystectomy is the cornerstone of management of these cases, and the best way forward in managing these cases is by a tumor board discussion. Thank you very much.
Thank you very much, Dr. Srivatsa. The topic is open for discussion. It's a highly heterogeneous group of,
yes.
It's a heterogeneous disease. So the therapeutic separate tumor type will have different
therapeutic approach. Yes, sir. Yes. Sir, if I can I announce, yes. So I think it stopped there. Slide is there? No, the announcement slide. So we at I come from Shankara Cancer Hospital in Bangalore. It's a 560 bedded cancer hospital, and we have recently started a intuitive supported robotic urology and uro-oncology fellowship program. The duration of this program is for 18 months, and we are planning to start this course from first week of February. So any candidates who have just completed their urology, who's interested in pursuing a career in uro-oncology, please do apply. My email ID and number are there. So any doubts and clarifications, I'll be happy to discuss. Thank you very much.
The next topic is orthotopic neobladder. For chairing this segment, I would like to invite Dr. Bijoy Abraham, Senior Consultant Urologist, Caritas. Dr. Kishore T.A., Senior Consultant Urologist, Aster Medicity, Kochi. Dr. Manu M.K., Additional Professor, Department of Urology, Government Medical College, Trivandrum, to the dais.
So good afternoon. So my topic is orthotopic neobladder. At the outset, I'd like to thank Ginil sir for giving me most of the videos and the pictures in this presentation. So orthotopic neobladder means a new bladder, literally translates to new bladder in its correct position. It allows volitional voiding through the urethra while eliminating the need for a cutaneous urinary stoma or intermittent catheterization. So a brief history. The first urinary diversion was done about 200 years back, by Simon in 1852. Uterus Zygmunt was used. Then Bricker advocated the ileal conduit in the 1950s. Gilchrist and Skinner, they really promoted the cutaneous continent diversion. And finally, in 1979, Cami, Lido, they did the first orthotropic diversion. And subsequently, multiple other surgeons have advocated their own form of urinary diversion. So there are three basic principles. One, there should be a healthy urethra with a functional external sphincter. The bowel loop that is utilized should be entirely detubularized to eliminate intrinsic peristalsis and high pressures, and it should be of spherical shape. And it should hold a 300 to 500 ml capacity. Patient selection, so in the morning when we were discussing dosed and Semvac, we were talking about young, fit and healthy patients. So unfortunately these are not the patients that get bladder cancer. These are the patients. So there are some key oncological and patient factors that you need to assess before you decide on performing new bladder. So the chance of a urethral recurrence, if there's prostatic stromal infiltration of this bladder neck involvement, a frozen positive of the bladder neck, we definitely don't go ahead with the orthotropic bladder. If there's a locally advanced tumor stage, that is likely to require postoperative RT, like T3 higher, T4, multiple nodes. We don't advocate a orthotropic bladder. Age, extreme age, as in a senile patient who's frail and unable to take care of himself, no. Renal function, most texts would describe a GFR of less than 40. I would say less than 60 in our population. We wouldn't really think of a neobladder. Body habitus, an obese patient might have a fat, thick mesentery, bowel might not reach. Prior radiation therapy, although textbook and evidences you can proceed, but probably it's not safe in our population. Prior bowel dissection, if you were to go ahead and resect more bowel, he'd end up with a short bowel syndrome. We don't do it. And the patient should be able to perform CIC and should not have a urethral stricture. So there's a good flowchart in Campbell actually. It's very useful. So if the patient has a GFR of more than 60, an intact functional sphincter, adequate available bowel, and he's not frail, and there's no oncological contraindications, then he or she can proceed for the orthotropic bladder. So the two key parts of the neobladder creation, the preservation of the continence mechanisms in the urethra and preservation of the reservoir. So I think preservation of the continence mechanism and the apical dissection is actually the most important part of it. So the robotic surgery actually holds a big advantage in that the pneumoperitoneum kind of controls the venous bleeding. Visualization is excellent. You can actually see a good length of the urethra there. The dorsal venous complex is oversewn, and the puboprostatic ligaments are preserved. So that's why in the apical dissection is key in retaining male continence. The same with the female. There's an open neobladder in a female. The urethra is circumferentially defined and dissected off the anterior vaginal wall, and there it's nicely exposed for anastomosis. And preservation of the reservoir. So if you open Campbell, there are 24 reservoirs, and it's all very confusing. So I'll just go through a few that I have had some exposure to. The Hotman W bladder, which is what Dr. Guru used to do. So this is a W pouch. It's basically a W pouch that's actually hitched with a catheter, and the bowel is not divided initially itself. The bowel loop is entirely detubularized and it's folded onto itself. So ultimately, it's a nice sphere with two channels, and the ureters are anastomotic. So one, the biggest advantage, it's a nice sphere. Second is there is no problem in doing a retrograde procedure because the ureters are directly anastomosed to each channel. This is a small video of it. It's drastically abridged. So that is a catheter that is holding the neobladder there. This is the bowel that is opened. One limb of the bowel is opened. The posterior plate is created, and the other limb is then opened, and that posterior plate is created. All the while the neobladder is kind of attached to the catheter there. Then finally, the whole thing is folded onto itself. And the biggest advantage, I think, of this is that the once you open the bowel, the whole posterior layer of the bowel is actually anastomosed to urethra. So that becomes the most dependent position. And only in the end you actually divide the bowel. So the whole neobladder stays in position. You don't have to figuring out which end is which. The pitcher pot neobladder is what Dr. Ginnell does. So basically a U loop is defined. It's detubal raised and it's folded onto itself to form a pitcher with a single channel. And that's a loop of bowel that's isolated. It's detubal raised. It's configured in that pitcher pot position. It's detubal raised there and folded onto itself. And an SPC is put, splints are placed, and a small buttonhole of mucosa is removed, bladder mucosa, and the serosa is removed, and that forms the neo-urethra. That's anastomosed to the female urethra over there. So the same thing is done robotically also. That's the catheter. The bowel loop is actually anchored onto the posterior fascia there. That's a neo-urethra that's, urethral meatus that's created, and that's anastomosed. And it's all well under vision. And that's a completed conduit completed reservoir over there. So just for completion's sake, the Studer neobladder, so it's a U-shaped neobladder, and it's actually twisted, it's actually turned 90 degrees, and the urethra is anastomosed to one side of it. So it's basically the same thing as the pitcher pot. The U loop, instead of anastomosing the urethra to the end over here, you anastomose it to the side, and you fold it on itself. So that's the Studer. And in Cancer Institute Adyar, Dr. Satishan had devised something called a sperm head neobladder, which is again the same U loop. The urethra is anastomosed at the end, but the whole loop is actually folded back onto itself. So which one is best? When I'm asked this question, actually I remember Felix sir from Calcutta Medical College. One day he had done 3 urethral reimplants for pediatric patients. One he did a Parkman, one he did Cohen, and one he did something else. And I went up to ask sir, which one is the best technique? So he said, your technique, my technique, all techniques, wrong techniques. So it's the same thing. I don't think the reservoir matters at all, as long as you have a spherical reservoir with a 300 ml capacity. So how do you manage post-op? ERAS protocol, as for any cystectomy, neobladder washes initially at least 8th hourly, and as needed. Drains are out when it's less than 100 ml. The splint and the SPC are out on day 12, and the catheters are out usually on the day 14. We only perform a cystogram if we have a suspicion of a urine leak. Complications related to any cystectomy, those complications are always there, and related to the reservoir, which is basically a urine leak. That's our most devastating complication. So most urine leaks, they will heal with adequate drainage. Retain the SPC, retain the Foley. You can place percutaneous nephrostomy tubes, but sometimes you need to do an open repair. So this was a lady that had a neobladder placed, and the whole anterior wall actually opened up onto the anterior abdominal wall. But we were able to salvage it. So that's the neobladder that was again taken off the anterior abdominal wall. It was closed, and she did well after that. So late complications: incontinence, urinary tract infection, ureteroileal anastomotic strictures, pouch stones, and pouch rupture. So other than incontinence and pouch rupture, these complications are the same, and they occur at the same rate as for an ileal conduit. So trends in urinary diversion. Actually, Apu Thomas sir was discussing the other day that neobladders have slowly gone out of vogue. There was a lot of initial enthusiasm for it. So if you look at the previous edition of Campbell, all the graphs were actually going up. Then after that, it's all started coming down. So why this decrease in enthusiasm for orthotopic neobladders? About 30% of patients actually have a contraindication. If you look at Western literature, it's around 20%, but in our population, poorer GFRs, more comorbid conditions, it's about 30% are actually unfit or have an oncological contraindication for a neobladder. So what happens to the others? So that is actually a surgeon factor. So the orthotopic part of the procedure is actually equally long as the cystectomy part. Complications do occur, and usually they're very dramatic complications that can cause a lot of sleepless nights. So most surgeons actually don't prefer to do a neobladder. And when a patient who's had a neobladder comes after a year of surgery, he comes for follow-up, and that's what his abdomen looks like, and he's perfectly continent and is fine. It actually makes it worth it. So this whole concept of bladder preservation and CTRT, all that stuff, if we were able to do a neobladder for every patient, this CTRT wouldn't even have stand a chance. Radiation oncologist has left, right? Okay. So the take-home points: patient selection is key, but normal key. Don't look for exotic, highly selective keys. The reservoir does not matter. The apical dissection does. Complications do occur, but they have excellent outcomes when managed appropriately. Thank you. Any questions?
Thanks for the excellent presentation. How long will you put the patient on CAC?
So actually, once the catheter is out, if we assess what the post-void residues are, if they're not high, we don't put the patients on CAC at all. But we do make sure that the patient is actually able to self-catheterize prior to the surgery.
The problem is, as the time goes on, immediately patient will void. As the time goes on, the pouch will get distended, contractility will decrease. So on long term, I think CAC will be necessary.
We actually, to be honest, I've seen patients who were 10 years post neobladder construction, and they don't go. They do timed voiding, but and they all void with abdominal pressure. But I haven't seen any patient that actually required. If the conduit falls or kinks, then they might not be able to empty it. But otherwise, no. But again, they have to know how to self-catheterize.
As you said, the selection of the candidates is most important. Of course, CIC is something which is unusual, but in females there is a thing called hypercontinence. We would expect that females would leak more, but generally they have more continence episodes, and therefore sometimes they have to be cautioned that they may require CIC.
Absolutely.
A second thing is, after doing a conventional cystectomy in a female, leaving the vaginal cuff alone without putting in at least an omental pad there. There have been a few problems with
Fistula.
Fistula there. So probably it may be well to put an omental wrap there.
Absolutely.
To separate the two anastomosis.
Actually, Dr. Ginil sir was telling me, Dr. Murugesh Manoharan, he actually splits the omentum into two and places one on the anterior suture line and one behind, between the vagina and vaginal cuff and the bladder.
Yeah, I remember our first experience in RGCI. We forgot that step and we lamented for that. So that is important. The other thing is, patients need to be told that at night they may have incontinence episodes.
When you compare the open and robotic neobladders, say you do a robotic cystectomy, and would you do extracorporeal diversion, or which one would be your preference, or like completely intracorporeal?
Absolutely. I think the whole benefit of the robotic is lost when you open the abdomen. So so one key thing is you don't have those fluid losses that you have with open surgery in robotic. Bowel handling, so those fluid shifts and more turbulent post-op period, it doesn't happen if you do it entirely intracorporeal.
But I find technically demanding for a single surgeon to do the whole robotic procedure. That is what.
It's a small marathon. It is.
Yeah.
As you said, the commonest diversion is not the continent diversion or orthotopic diversion. It's the ileal conduit. And ileal conduit has had a bad say because Bricker did not do it for cancer. He did it for meningomyelocele.
Okay.
So that is 50 years later they are telling us. 20 years ileal conduit doesn't seem, that is giving 20 years, ileal conduit is not. So probably a very select population, good fit population is the one which will do with this thing. But this is the biggest selling point for radical cystectomy.
Yeah, absolutely.
Arun, do you have any experience with anastomotic site recurrence? Erytrovesical site recurrence?
Not with the conduit. No, I'm sorry, not with the reservoir, but with an ideal conduit we've had.
Not with the neobladder?
No.
Orthotopic neobladder?
Hello.
Last
Arun.
question.
Just one thing, like, no, you have said the number of orthotopic neobladders are coming down. So what Dr. Kishore said, it's a long marathon.
Yeah.
So you have a single team approach or a two team approach if you do it. What would you advise?
So I mean, now I am there, but I think Ginil sir has been doing this, and even Dr. Guru, he finished it quite quickly. So the team is important. So there are 200 steps to this. So if the team member doesn't know what the next step is, he's going to add 2 seconds. So 200 into 2, that's another so much time that's going to.
Probably in all the centers that are doing right now, probably they are going for a two team approach. That is because it's a long procedure.
Yeah,
that's one reason probably why the orthotopics have come down. Yeah. Second thing is, what is your the preservation, prostate preservation, and at least the prosthetic capsule.
I wouldn't advocate prostate preservation. I think there's a paper by Ebolini in I think.
No, it's coming up in UK, and I think now Dr. Manimenon is also talking about it. Precision. Okay. He's talking about precision prostatectomy.
Okay. Yeah, but I think there's a paper by Hassan Ebolini from in BJA. It says prostate sparing cystectomy, a step in the wrong direction. Yeah, because one, as they get older, the prostate is going to become bigger. Second, there's a chance of a prostatic cancer in these patients. And once you have a neobladder there and prostate malignancy, it becomes quite difficult to treat.
So what they're doing probably is, like UK, they have got a different set criteria for taking up these patients, where they evaluate and they, for the prostate cancer as such, do the MRIs, do the biopsies, and then the capsule is taken out. Okay. The capsule is preserved and rest of it is taken. That's what it's coming up.
Okay.
Thank you.
How do you increase the number which can undergo? If your bladder neck is positive,
you can't compromise on oncological principles. Sir.
Is there any step that we miss, which Tudor himself did when we had presented this recently, before he passed away?
Okay.
He used to do an on-table, biopsy of the urethra.
During the TURBT, yeah.
Not during the TURBT, during the cystectomy.
Cystectomy, is it okay?
If that is negative, he will go ahead with, even if the bladder neck is positive.
Okay.
Yeah.
Sir, regarding the anastomosis recurrence, so we had one episode of that at the urethral site. So then we did a urethrectomy, and we could salvage the ureteric anastomosis still. We converted it into a ILL condi, just stapled on that neobladder. So patient is doing good after that. So this could be one of the options that sometimes, like the neobladders lose their elasticity and patient can have a retention, AKI, urosepsis, and that time you can always convert them to ILL condi.
How often you see renal insufficiency on long-term basis?
It's actually the same as an ideal conduit. It's no different, because over a period of time the mucosa becomes non-absorptive, so that load to the kidney goes down, and unless there's a stricture or something like that, it's as similar to an ideal conduit, probably less.
Like you see, like even in the US population,
yeah, absolutely,
this is just the same. And in Dr. Guru and all, he does a lot of large numbers of cases. No, so how much numbers you should actually need? What do you think? No, like with your US experience, no, because to become a good neobladder surgeon per year.
I think initially, even his numbers are slightly down now, but he does about 20 a year. But cystectomies he do about 100. So, yeah.
This is like almost unimaginable in India.
Thank you.
Thank you, sir, and thank you, chairpersons. To continue with, our next topic is metastatic bladder cancer. For chairing the session, I would like to request on stage Dr. Rajiv TP, HOD Professor Shema, Bangalore, Dr. Ajish MA, Consultant Urologist, Benziger Hospital, Kollam, Dr. Jagdishwar, Professor and HOD Department Urology, ESI Medical College Hospital, Hyderabad.
At the outset, I would like to thank Bhatt sir and Unnichetan for giving me an opportunity to come and present in front of my teachers. Lot of them, Apu Thomas sir, Bhatt sir, Ginil sir, were my teachers when we were, and then sir is there. So many teachers are in the audience. And Dr. Unni is, I'm also Unni. Unni Chetan is my senior, so I call him Unni Chetan. His direction, he dictated that I should not cross 8 minutes. So 8 minutes I have to present metastatic carcinoma bladder is a Herculean task, but I'll try to do justice to you. Okay. So the topic I put is navigating the challenges and hope. A new era in MBC, because as Bhatt sir rightly pointed out in the morning, the CMEs are to learn, relearn and unlearn. Now we are going to unlearn whatever we know or we practice so far, because so much of research is happening in CA bladder that soon we may have to unlearn what all we learned till now and to learn everything from scratch. Okay. So generally metastatic carcinoma bladder has a very poor outcome because of many factors, and a good number of patients may not be candidate for any treatment because of their frailty, performance status and organ dysfunction, etc. If you see them as a whole, 40% of this patient will end up receiving cisplatin. 40% will be probably eligible for carboplatin. And 20%, this is among those patients who were fit for chemotherapy. And 20% of them will end up receiving something, single agent apart from cisplatin and carboplatin. So they are really very frail and, bad patients. And the question is cure an illusion? Will be able to cure a patient with a metastatic carcinoma bladder? Students, PGs, is it possible to cure someone with metastatic carcinoma bladder? What is your opinion, your thought process? For all of us, it's an illusion until yesterday, not today. At least some of them can be cured, and this is a radical statement I'm making here. Provided you have an armamentarium, resources and access to newer molecules, some of them are curable. So look at what is their outcome. So you treat them with cisplatin alone, cisplatin based chemotherapy, you get a median overall survival in the range of 12 to 15 months. Any platinum, if this include carboplatin and cisplatin, you get 7 to 10 months. This is the median survival what you are looking at present. So it's a very bad tumor, probably a recalcitrant tumor, and somebody is diagnosed with metastatic bladder cancer is a death sentence. And any chemo is 5 months and only palliative care is couple of months. And now again I am asking, can we cure someone? So this is an example. My relative, so he is Mr. HNN, was diagnosed with a non-muscle invasive bladder cancer in 2018 and underwent URBT and was on BCG. His BCG got over in 2019, and in 2020 February he developed hemoptysis. chest X-ray showed a right upper lobe mass. We thought, okay, this is carcinoma lung, we need to treat it like a carcinoma lung. We took biopsy, we have done PET CT, and to our surprise, it came as biopsy plus IHC came as urothelial carcinoma. I was not convinced. So I sent the specimen to Amrita. They also said it is urothelial carcinoma. Again, I am not convinced. I sent it to Rajagiri. They also said it is CA bladder. So biopsy and IHC from 3 premier institute in Kerala is urothelial metastasis from urothelial carcinoma. And the PET CT showed right upper lobe mass and 3 retroperitoneal nodes. The bladder is free. So at that time, the first line treatment for metastatic CA bladder was this platinum gemcitabine. I gave that. And he had done well for around 10 to 12 months. And after that he progressed. So when he progressed, again, FGFR3 came in by 2020. And I have done a comprehensive genomic evaluation for him. And quite sadly, he was not eligible for any of the targeted treatment. And then, low tumor mutation burden. He was given atezolizumab into 3 cycles and he had a partial response. And then after 6 cycles, money exhausted, 2 centimeter tumor left in the right upper lobe, we have given radiotherapy. And till now, he is disease free. 3 years, almost 3 years and now counting. So now we are into a new era because 3 revolutions are happening in bladder cancer. One is genomic based personalized treatment is a revolution. Introduction is of immunotherapy is a revolution which we have seen with Mr. HNN. And invention of antibody drug conjugate is another revolution. So 3 revolutions are simultaneously happening in bladder carcinoma. So we'll see how that is going to impact. So we know that cancer is a disease of genomic problem at cellular level. And if that is the problem, the correct answer, the answer lies at the cellular level, at the genomic level. So you do genomic assay, most of the time you will get FGFR in 21% of the time, that is an actionable mutation. CDKN2A in 34% of the time, and this is important, not because this has an actionable mutation, because this is resistant to immunotherapy. And HER2/neu in 17% of the time, this is again targetable, and PIK3CA in 20% of the time. So far we don't have a good PIK3 inhibitor in CA bladder. So this is erdafitinib in 2020 has got, compared to chemotherapy, erdafitinib is superior. Erdafitinib is an FGFR3 antagonist. And now this is the article, the Destiny trial published in January 2024, 3 days back. It's a tumor agnostic therapy in trastuzumab deruxtecan in HER2 positive bladder cancer. You see some of them are having long lasting response. So that is the new kid. And now the second revolution, that is immunotherapy. I have 30 seconds, but I will take only 2 or 3 minutes more. So you have atezolizumab, pembrolizumab, durvalumab and tremelimumab. All of them, all of them are phase 3 trials with hundreds of patients, and except durvalumab plus tremelimumab, all other trials have shown an improvement in PFS. When it comes to overall survival, none of the trial has shown, Javelin has shown an improvement in overall survival. Atezo and Pembro did not show. But Javelin was a different kind of trial. It was maintenance treatment after, chemotherapy. Before they fail. You give chemotherapy and then you maintain with the durvalumab. Now this is the new kit. I attended the presentation at ESMO, Madrid. This was the presidential symposium over there. The first time in bladder cancer, a chemotherapy-free regimen has beat chemotherapy. So it's a direct comparison between gemcitabine cisplatin versus EVP, enfortumab vedotin plus pembrolizumab. You look at the data, what a fantastic data. You see, and 1 year event-free survival, progression-free survival of 20 versus 50. 1.5 year PFS of 10 versus 44. And you look at the tail of the graph, there is a plateauing of the tail of the graph. That means that if you are, say, disease-free at the end or progression-free at the end of 2 years, you are unlikely to progress thereafter. So at least 30 to 40% of this metastatic urothelial carcinoma who are put on EVP are virtually cured. That is why I said, if you have resources, access and money, at least 1/3 of urothelial carcinomas are now curable. And this is the data. So with that, it will not move. So yes, bladder cancer is curable, but not in all patients. In some, at least in significant number of proportions of patients, now it's curable. Only problem is finances, and why we know, we were discussing after the lunch, when tamoxifen was launched many years back, it cost many thousands of rupees for 1 month of tamoxifen treatment. Now tamoxifen costs 1 rupee per tablet, and no pharma company wished to make tamoxifen because it's not profitable to make tamoxifen. So in another 10 years, probably all these molecules will become cheaper and will have an opportunity to use this molecule uniformly for all patients irrespective of their purchasing power. With that, I thank all of you for patient listening. Thank you.
Excellent presentation.
Thank you.
You have changed the outlook about the malignant diseases, and especially carcinoma bladder, especially when carcinoma bladder, which present very early with a very horrifying symptom of hematuria, and we don't see anybody in the initial presentation with the metastasis and the locally advanced diseases. And with the advent of this immunotherapy, now there is a almost near curable situation we are seeing. I would like to know that suppose a patient who already had received chemotherapy like gemcitabine and cisplatin, later when you present with metastasis, what is your drug of choice?
So till now the first line treatment was gemcitabine cisplatin. Now that is going to change. It will become EVP, enfortumab vedotin plus pembro. But only rich people will be able to afford that. But so for majority of our patients, first line treatment will continue to be cisplatin gemcitabine. When they fail, the best treatment depends upon your genomic profiling data. You should do a genomic profiling data. At least we should look for FGFR3, and HER2 can be very easy. 1,000 rupees you pay, it can be identified on an IHC. 1,000 rupees, if you can pay 1,000 rupees, we can do in-house in Caritas. HER2. So if you are a HER2 positive disease, I will be giving trastuzumab deruxtecan. That's also very expensive molecule. If you are FGFR3 positive patient, I will be giving you erdafitinib. Or if you are having any other disease, I will be giving you an immunotherapy. It can be pembrolizumab, it can be atezolizumab. So before that, if you have an access to continue, if you are given chemotherapy with gemcitabine cisplatin and patient can afford, we can put them on avelumab maintenance as in Javelin 100, and then there are patients who are doing extremely well on avelumab. I have no experience with avelumab, but my colleague says that there are patients and they are doing extremely well. So that should be the approach.
One question, if this genomic is positive, that means there is hope for the patient. That is the message.
Now in oncology, the chemotherapy era has gone. probably I'll be giving chemotherapy for probably another 5 or 10 years. From thereafter, we may not be giving much chemotherapy. It will be personalized medicine. So by doing genomics, we will be knowing what is going to work for this patient. And I can suggest a treatment which is most likely to work for that patient. So if FGFR3 is there, then I can give erdafitinib. So that's erdafitinib is probably the penicillin of FGFR3 inhibitor. So if you compare in terms of antibiotics, so that's more easy for PGs to understand. That's the most basic FGFR3 inhibitor, or the most primitive FGFR3 available. As time goes on, you will have more better FGFR3 inhibitor, like already somehow came. I think pemigatinib came. They are generation 2, and as time progresses, you will have better molecules to treat these patients. You can do it in blood and tumor. Tumor is, you are doing on the resected specimen. It both has its own advantage and disadvantage. If you are doing it tumor, your yield will be high. You can extract more DNA, and you will get to know about the genomic of that tumor. But the problem is that you have lung mets, liver mets, bladder tumor, bone mets. You will be taking biopsy from only one site. So there will be heterogeneity in tumor character between the organs, between the metastatic site. So you will not be catching the tumor heterogeneity if you are doing a solid biopsy. But then you can do that on the circulating tumor DNA or the circulating tumor cells from the blood. The advantage is that you will also catch the heterogeneity, because the sample will contain tumor cells or DNA from both bladder, liver, lung, or whatever organ you have. But the problem is that it is not as sensitive as a solid biopsy to extract DNA and give you the result.
Trial that you just mentioned.
EVP, enfortumab, yeah.
So what percentage of our patients, in your experience, would have an actionable mutation that can that will make them eligible for that?
So enfortumab vedotin is actually an antibody drug conjugate. Enfortumab is the antibody against nectin-3. Nectin-3 is uniformly present in all bladder cancer. So we need not have to test for any particular mutation or anything to give them enfortumab vedotin. So the vedotin is the chemotherapy part. So all patients are eligible for enfortumab vedotin. And pembrolizumab is also eligible for all patients irrespective of they are PD-L1 positive or PD-L1 negative. PD-L1 positive means they have a better chance of responding to pembrolizumab. PD-L1 negative will have a lesser response to pembrolizumab, but that does not mean that they are not going to respond to pembrolizumab.
The days have changed now. From early, when the metastatic disease means the days are counted.
Yes.
From that, now it has been changed that even if you have resources and with the available molecule and the drastic improvements in the immunotherapy, now even it's curable. A very good message.
Some of the patients are potentially curable, no, but not all. Thank you.
Now, as we approach the culmination of our CME, I invite Dr. Arun RM to moderate the case discussion on advanced CA bladder. I also welcome the panelists for the final case discussion, Dr. S. Vasudevan, Professor and Head of Department of Urology, MCH Kottayam, Dr. Sanjeevan KV, Professor, Department of Urology and Renal Transplantation, AIIMS Kochi, Dr. Balagopal Nair, Senior Consultant Urologist, Rajagiri Hospital, Dr. Flowerlit Thomas, Assistant Professor, Department of Medical Oncology, Government Medical College, Kottayam, Dr. Unni S. Pillai, Consultant, Medical Oncology, Caritas, Institute of Medical Sciences.
Good afternoon. We'll start with these cases. So case 1, 65-year-old male, gross hematuria with clots since 2 months, associated dysuria and storage symptoms. So that is his CT. Sanjeevan sir, any comments on the CT, especially the coronal section over there?
There appears to be a growth and contiguity with the prostate, which is coming into the bladder, especially on the lateral bladder wall.
Yeah, absolutely. It looks like, yeah. Further, I mean, so the abdominal imaging showed that lesion. There are no pelvic nodes or epidural nodes. What further studies are required for staging? Uni sir.
Biopsy is must.
Yeah.
Biopsy is must. So our first priority is to get a biopsy.
Okay.
And since that is continuity with the prostate, we'll also get a PSA.
Okay.
So first the PSA will get in few hours time. Then biopsy we will, and then we'll also go for a PET CT with that mass.
A PET CT. Any other? I'm sorry. Anybody for a CT chest? Would anybody be okay with the CT chest?
Yes, PET scan is an option. CT, thorax, abdomen, pelvis,
Yeah.
along with the urography will do. PET CT is an option. It goes well with nodal disease and the visceral metastatic disease.
So that is his pathology report. High-grade urothelial carcinoma. PSA was less than 4. Invading muscularis propria. CIS was noted, and it's infiltrating prostatic stroma. So what are his options for further management, madam?
65-year-old male. I will assess his eligibility for a NSCT first, neoadjuvant chemotherapy.
Okay.
Basically, I will assess his eligibility for cisplatin. That means we have to consider his performance status. It should be performance status should be less than 2. Then all the 3 well-known toxicities of cisplatin: ototoxicity, he should not have significant hearing loss; nephrotoxicity, GFR should be more than 60, and the neurotoxicity, neuropathy. If you talk in terms of grade, it should be less than or equal to grade 1.
Okay. His performance status is 1. He no Galsky criteria. GFR is more than 60. Is he a candidate for bladder preservation with this pathology report?
Yes, as we have already discussed, we have to give the option for that patient. Okay, we have long-term data with radical cystectomy, it's good, but even, but no, this is T4A. T4A means the rate of relapse is more with T4A.
Yeah. So does prostatic stromal involvement and CIS make him ineligible for?
This is not an ideal patient for bladder preservation.
Bladder preservation, right. Okay, so we decide to proceed with NACT plus chemo plus surgery.
Can I ask a question
Yeah,
back?
sure.
Now, where in this, we have been, since morning, we have been talking about, this genomics and all. So in this patient, where does that come?
We don't.
I mean, in the neoadjuvant setting, we are not looking for genomics. Personalized medicine and genomics role are mostly in the metastatic setting. Metastatic setting will do the genomic study and then personalize the treatment. In neoadjuvant setting, genomic based personalization is so far not the standard of care.
So he is going to require neoadjuvant chemotherapy. What regimen would you advise?
We will give cisplatin gemcitabine.
Madam, any difference of opinion?
Of course, after the Vesper trial, the DFS favors dose dense MVAC, but toxicity profile favors GEMS still.
GEMS, right? Okay. In any case, the NCCN actually recommends dose dense MVAC as a preferred regimen now, but GEMS is for 4 cycles also. Question: dose dense MVAC or GEMS? Do you have to complete it within 3 months? Today morning there was a discussion. A delay of cystectomy of more than 12 weeks would adversely affect outcomes.
So, are you compelled to complete your chemotherapy within that time?
If the patient doesn't go for a prolonged neutropenia, definitely the, both regimens will complete within 3 months.
Okay. When do you repeat? I think a lot of this would have been already covered, but when do you repeat imaging after starting NACT?
So once we decided for NACT, I don't generally do an interim image. I'll tell you why, because if the patient progresses in between, then that patient's biology is bad and they're not going to do well with your cystectomy or whatever protocol we are going to do. So our reassessment will be at the end of 3 months with another CT scan or PET CT scan. So I am not a great fan of interim imaging at 1.5 months. So you have given only six weeks of therapy. There could be someone who is early responder, but it's not, there could, anyone who is early progressor, progressing by 6 weeks, they are going to do extremely bad. We are not going to gain much by doing an interim imaging.
But still, this potentially curable disease, and we're letting him in progress under our noses.
If the patient progresses while on chemotherapy, and if you are doing cystectomy, most of the time that cystectomy is a futile cystectomy.
You have to provide a reference for that.
Because if your patient progresses on chemotherapy, most of the time that patient will come back with metastatic disease.
So the thing is, he's symptomatic.
And there is no recommendation to do an interim imaging in any of the trials. Is there? No. If you do an imaging at the end of 3 months, and if the patient has, is not a metastatic disease, you can do cystectomy. If the patient has a metastatic disease or metastatic disease, then we are not going to do cystectomy. That is the, are you going to, if the patient progresses after 2 cycles, are you going to stop your treatment there and going to do an early cystectomy? No.
Absolutely yes, because he's symptomatic. You're at least going to alleviate his symptoms. He's going to have gross hematuria. He's going to die a painful death. So you will proceed with the cystectomy if it is progressing.
That's what it's basically. Initially when the lymph nodes were positive, before with the diagnosed bladder cancer with a lymph node positivity or a lymph node enlargement, they used to go and take the lymph node biopsies, whichever way, and then see, and then don't give. But no, that thing has changed with the coming of the chemotherapy, and still we practice going for radical cystectomies.
Absolutely.
Now, if the patient is symptomatic anyway, we have to intervene,
Exactly.
irrespective of whether he is responding or not. And here it is presumed that he, having undergone a biopsy, it is presumed that he has had the bleeding contained in one way or other.
But again, the entire lesion has not been resected, and there is a residual mass.
We can keep on discussing on this interim imaging, but that is not the standard. Whoever wish to continue with an interim image can continue to do that, but an imaging at the end of 3 months is also acceptable.
Fine.
That brings in another question. Here, do you mean to say that everybody will be a responder?
Not all. So if you see the trial, everybody may not end up having cystectomy at the end of 3 months. There will be, your response rates, complete remissions are in the range of 20-25%, and your, overall response is close to, I'm not very sure about the number, but it's 80%. And what percentage will underwent cystectomy? I'll ask madam. 100% of them will not undergo cystectomy.
So the thing is, what if those variant histology here that is non-responsive to chemo?
And we thought we are talking about TCC, right?
It is urothelial carcinoma, but what if there was some micropapillary element in there?
In that, if you have a variant histology, then you cannot have a standard approach for all these histologies.
Okay.
If you have a small cell, we definitely recommend neoadjuvant chemotherapy with the cisplatin, etoposide, and atezolizumab, and then go ahead with the
small cell is systemic therapy.
Systemic therapy, but
variant histology, micropapillary. In any case,
it's a very tough question. So
we'll probably there was some response after 2 cycles. This is after 4 cycles. Only some thickening remains. So next step, Balu sir.
It's the radical cystectomy with the urinary diversion.
With urinary diversion. Does he need a urethrectomy because his prostatic stroma is infiltrated?
Yeah. So the prostatic stromal infiltration definitely entails him for a urethrectomy also, because there's a high chance of the, or you will have to follow it up.
Of a urethral recurrence. Any change in opinion, sir? You would also proceed with the urethrectomy, right, sir?
I will have, of course, the time of cystoscopy, we can make out whether this prostatic urethra actually is affected or whether it is confined to the bladder itself.
Yeah.
Some changes can happen accordingly. Otherwise, generally,
prostatic stromal infiltration.
Prostatic stroma is seen in the biopsy.
Yeah.
Okay. Oh, infiltrate, then there's no doubt. It has to come.
Yes, sir.
I'm sorry, I missed it.
No, that's fine. So decided to proceed. So what is the extent of a lymphadenopathy that we typically do, Balu sir?
The standard is what right now, there's been a lot of talk on that, and there's been a change also. They have now the standard that they say is the internal iliac, external iliac, the obturator, and the presacral.
Absolutely. The standard lymphadenopathy, the SWOG 1011 study showed that. So this is extended, and this is what is standard till the bifurcation.
Bifurcation of the common layer.
And do you typically clear out the Marcel's fossa? The fossa of Marcel also on the lateral aspect of the.
No, I don't clear it.
This is a cystoprostatectomy plus urethrectomy assessment. Residual viable invasive malignancy seen. Tumor site, anterior wall, right lateral wall extending to prostate, urothelial carcinoma, muscularis propria involved. Tumor extension involves prostatic stroma. Margins are all clear, and 24 lymph nodes all clear. YPT4N0. Flower, madam, what's the next step?
This patient has received neoadjuvant chemo.
Yeah.
So this patient is the candidate for adjuvant nivolumab for 1 year.
Adjuvant nivolumab.
Yes. Any PT2 onwards or N plus, you have to consider it.
Okay. And I'm sorry. Here, there is a focus of prostatic adenocarcinoma. Gleason 3+3/6 involves 10% of the prostate. Sanjeevan sir, anything additionally needs to be done for that?
Monitor the PSA.
Monitor, absolutely.
PSA was not very high in this.
It was around 2.5.
Yeah, but because it is just adenocarcinoma, I will be monitoring the PSA again.
Absolutely. So in about 10%, at least in 10% of patients who have a cystectomy, there is an incidental diagnosis of prostate cancer also. Adjuvant therapy we discussed. Do you have any patients on nivolumab? How much does it cost per year?
Nivolumab, every 3 weekly, it costs around 1.7 lakhs.
1.7 lakhs. Okay. Any role for adjuvant RT in this setting? T4 disease.
This is another controversial issue. This is T4 disease. Definitely, we have some vague data that local recurrence-free survival is better, but it doesn't affect any overall survival. So for a T4, I may consider RT.
Yeah, absolutely. Even
or
then,
margin positive disease.
Yeah, T3, T4, or absolutely margin positive disease, close margins. You can advocate.
Or if they are not able to afford nivolumab.
No, but that is not an indication to give RT. So, if they can't afford nivolumab, then you keep them on follow-up. So in the MVAC trial, the SWOG trial, and many other olden trials, if you have residual disease, they were not given any adjuvant therapy. They were kept on follow-up. Unless they have a positive margin, they end up receiving RT. So non-affordability of nivolumab is not an indication to give adjuvant RT. No.
Okay. And how do you how do you follow up a patient after a cystectomy, sir? He's had a urethrectomy also, but considering if he hasn't had a urethrectomy, what all would you do?
So baseline they will require at the 3-month follow-up, and then yearly imaging with an upper tract imaging, depending about that, a CT, and the chest CT also nowadays it's coming up. if required, no, because depending upon the, it's a T4 disease, so you will require to have a chest CT also.
Any cytology of the from the ileal conduit or from urethral wash cytologies?
The urethral, if you're preserving the urethra, definitely you will have to do a urethral wash cytology. Otherwise, if you're taking up the urethrectomy, you've done a urethrectomy, probably the imaging and cytology through the ileal conduit, it's got its own issues with the false positives or.
Case 2, 75-year-old male, gross hematuria 2 months, dysuria storage symptoms. So that's the lesion. It's on the anterior wall. The TURBT showed high-grade urethral carcinoma invades muscularis propria. Flowlet madam, what are his options for management?
CT please.
Yeah.
76-year-old.
Yeah.
T4B, right? T4A, okay.
There is definitely some extrasexual extension.
Yes.
But
T4 disease, if he's a candidate for cisplatin, I don't expect actually. This patient will go for neoadjuvant chemotherapy followed by cystectomy. Otherwise, even upfront radical cystectomy is acceptable.
Okay.
And if it cannot be done upfront, then we have phase 2 data for neoadjuvant immunotherapy. We can utilize that.
Any role for bladder preservation protocols for him?
Advanced disease, but still, yes, we can use, but with a higher rate of recurrence.
So someone ideal for bladder preservation are any tumor which is less than 3 centimeter, optimally, resected, TURBT, maximal TURBT done tumor. Then tumor should be well away from the ureteric orifice and should have an adequate renal reserve to receive cisplatin. Now you can do that with the gemcitabine also. So if you have all these things, the MGH data, Erasmus data, everything, you look at them, you have a 5-year cystectomy-free survival of 80%. 20% are the people who underwent cystectomy, if you properly select the patient. So, and those patients who underwent cystectomy are purely not due to tumor recurrence. They may undergo cystectomy for toxicity also. As one of the professor was telling, the people come and beg you for cystectomy due to telangiectasia. That can happen because it's a toxic procedure, but overall it's a very safe procedure. So all in bladder recurrences are not true bladder recurrences, because someone developed bladder cancer because most of the time they were heavy smokers and the entire bladder mucosa is exposed to carcinogen and there is a field cancerization. The recurrence might be true recurrence or it could be a new bladder primary. It's coming up over there. So if you take all this into consideration, then also you have a 80% bladder preservation rate if you properly select the patient. And your recurrences, majority of the recurrences are not going to be in the bladder. Majority of the recurrences are going to be systemic. So bladder preservation is a very good option if you select your patients properly, and it's a competing modality for radical cystectomy. That's my take on that.
And this partial cystectomy can be added on to that. It can be quadruple if this is the only site of lesion.
It is the anterior wall lesion is the only site of the lesion.
I think Ginil sir has want to make some comment.
The selection was different in Shipley's patients and the UK study. So Shipley, the data shows that there is a adverse outcome with hydronephrosis and the worser factors after 20 years of longer term follow-up. But the UK data included advanced T4 everything. So are you again saying that we have to go for Shipley's rather than the UK data?
I mean, the most safest one will be Shipley's, but if you see the MRC data also, the MRC data, some of them are also having a 5-year cystectomy free survival of close to 80%. So, I mean, the safest bet will be to select patients based on Shipley criteria, but we, with the, as you correctly said, we can also use the MRC or the UK criteria also, but I would be very happy and will be safe to select patients without hydronephrosis personally.
So again, only the anterior wall lesion is there. Is partial cystectomy and radiation an option in this patient?
In this one anyway, maximal TURBT is not possible at this site.
Yeah.
So there will be tumor significant tumor residuals if you are doing TURBT alone.
Just a partial cystectomy, an open partial cystectomy.
I am for that.
See, the problem, the partial cystectomy and radiation alone is not advisable, even in this location. And in this location, if you have to have a partial cystectomy, you have to go for a neoadjuvant chemo and then probably do that.
Fine. Triple. Okay. So if he decides on bladder preservation, any role of multiple bladder biopsies? We were discussing earlier this morning to identify CIS. Do we need to do multiple bladder biopsies? Is that something you insist on?
We are not doing.
Okay. And is CIS a contraindication?
For bladder preservation, no. Because,
Okay. And in which patients? I mean, I think you answered this question with patients with hydronephrosis. Fine. So he completed CTRT. How do you follow up these patients?
This patient should be, all patients with who underwent bladder preservation should be on rigorous follow-up. Routine cytology at least every 3 monthly, urine cytology, cystoscopy at least 3 monthly in the first year, 4 monthly in the second year, 6 monthly, 3 to 5 years, and yearly thereafter should be there.
Do you require a biopsy?
If there is any suspicious lesion, they say that you have to do biopsy. Otherwise, it's cystoscopy alone. No, routine biopsies are not there.
To be honest, after radiation, the whole bladder is going to look suspicious only. So,
I mean, that's for the urologist to take a call on that. But
so
not merely suspicious. Even if there is some tumor residual, and if you believe that the radiation must have killed it, is there some way to find out whether it is viable or whether it is non-viable? I mean, because tumor is something.
If your bladder preservation protocol is successful, there should not be any tumor when you do cystoscopy. So if you have residual tumor, you biopsy it, you prove it, then you go for cystectomy.
So 5 years passed. He was on some intermittent follow-up. He's now 80 years old. He has severe storage symptoms, terminal dysuria. That was his chief complaint. No hematuria at all. And he had multiple cystoscopies on the outside, and they said just inflamed areas. So again, he came back. The lower 2 images, Flowlet madam, any comments?
Definitely, we have to go again for a cystoscopy and to find out whether it is active disease or not. In this case, we have to definitely do a biopsy.
Yeah. So post RT, the bladder is going to be thick walled,
yes,
and it will also enhance to certain levels. So how so biopsy is mandatory? Because on the outside, the physician had told him it's probably RT-induced changes.
Only a biopsy can solve the issue because a diffusion weighted image can tell you it may be or may not. Only a biopsy can solve the issue.
You have to compare with the previous images.
Yeah.
So that is the quickest and the best way you can take a decision now.
Okay.
And probably cystoscopy and biopsy.
So he actually underwent a TURBT that showed a high-grade invasive urothelial carcinoma with squamous differentiation, T2. They've written grade 3. So is there any role for, he's 80 years old now. No radiation. And if he decides to proceed with salvage cystectomy, is there an indication for chemotherapy right now?
You can give neoadjuvant immunotherapy rather than chemotherapy if he is fit for cystectomy at 80 years after radiotherapy.
So it was sort of like a palliative salvage cystectomy. So radical cystoprostatectomy, right, left lymph nodes, ureteric margins. So finally, it's a PT3 stage, N0, 22 lymph nodes free of tumor. And again, in the prostate also there was some tumor, 8 to 10%, 3 plus 4. So what would be the next step, Dr. Uni?
The adjuvant nivolumab is for TCCs, not for squamous cell carcinoma. So
it's urothelial with squamous differentiation.
So if it's urothelial with the squamous differentiation, we'll try nivolumab, adjuvant nivolumab.
Adjuvant nivolumab. And how long would you continue that for?
It's 1 year. 1 year of nivolumab.
Okay.
Because already cystectomy done now, sir. So now it.
He's T3.
I mean, any residue, any viable tumor, you have not given any neoadjuvant for him now. It's a tumor recurrence. It's a T2 tumor. T3. No neoadjuvant. You can
It's
give
become
adjuvant
T3 now,
treatment.
no? It's T3 now?
T3.
I mean, TT, I mean, now, since there is no neoadjuvant, we will be forced to give adjuvant.
Okay, next case, 40-year-old lady. She's a spina bifida neurogenic bladder. She has been on CIC since childhood, and she's got recent onset hematuria. So the right low image shows gross hydronephrosis. This is because of a neurogenic bladder, and there's a large tumor on the anterior wall. TURBT done outside features suggest of squamous cell carcinoma. What staging evaluation would you advise?
In this patient, I'll of course go for a PET CT.
PET CT, absolutely. And any role for neoadjuvant therapy in squamous cell carcinoma?
No role.
No role. So what would be our options for management? Absolutely. Yeah, we went ahead with an anterior excentriation, bladder, uterus, urethra, pelvic lymph nodes. So it is PT3B, node N1. Basically, one perivesical node was positive. So what would be the next step now? She's young, only 40.
We don't have a definite consensus or guidelines on this. We have to deviate through some vague data. If I consider adjuvant chemo, I will be adding, the deviations are like this. I will be adding taxanes also into this for a squamous cell carcinoma, because small case series has shown much better response with adding taxanes. Then the next deviation will be on the addition of RT. For squamous cell carcinoma, postoperative has shown definite improvement. Then regarding immunotherapy, Suni said adjuvant nivolumab is for urothelial. But if the patient is not keen on chemo, especially if it is PD-L1 positive, we can try for immunotherapy.
Okay. She unfortunately she did not have a pelvic RT. She got gemcitabine cisplatin actually. So at she completed 6 cycles of gemcitabine cisplatin. 3 month follow up, she was without evidence of disease. On 6 months follow up, her abdomen was perfectly normal, but unfortunately a nodular soft tissue thickening in the retrosternal aspect, likely lymph node. So this is a PET CT now at 6 months post-op. So any comments, sir?
Now this is a metastatic disease. There is a chest wall metastasis, then there is a hilar node is there, likely bone mets is there. So multiple metastasis, prognosis is obviously bad. We need, and if there are no recommended second line to be given, we need to discuss the option with the family. One is best supportive care is another option. One option. If they are so keen on some treatment, then it should be immunotherapy, systemic immunotherapy.
What immunotherapy would you advise, sir?
For squamous cell carcinoma, we prefer nivolumab. I don't know. Don't ask me why, but that's how I give in my clinic. Also, because among squamous cell carcinoma, for me, I got better response with nivolumab. So we used to give nivo for squamous.
That's fine.
Squamous cell carcinomas are mostly high tumor mutation burden tumor, and mostly they may not have a driver mutation. You can do, there is no harm in doing that, but we may not, most of the time we may not get any actionable mutation.
So
more radiotherapy.
For symptomatic relief, so if her bone mets is having pain, then we'll give palliative radiotherapy.
She was actually asymptomatic till the
So
last.
otherwise, then we can add solindronic acid to prevent bone events. That can be done. Solindronic acid or denosumab can be given.
Okay, that's fine. So 75-year-old male, gross hematuria clots, storage symptoms, creatinine is 3.2. That's his GFR that we estimated. This is a plain CT. Malubal sir, any comments on the bladder tumor and the kidneys?
Yeah, so there's a hydrouretronephrosis on the left side, and then the left side of the bladder shows a thickening, and it's not non-distensible, and the ureter also. And just go back. Node is there?
No nodes.
No node. So those are the dilated ureters that are there.
Yeah.
Yeah. So that's.
Yeah, some bowel loops and dilated ureter. That's all. So 300 TRBT, large tumor occupying entire left lateral wall and trigone. Left luteal orifice is obscured. It was a visually complete resection. Pathology: high-grade urothelial carcinoma, focal glandular differentiation, syncytial trophoblast-like areas, in which muscularis propria. Sanjeevan sir, while you are doing the TURBT, if by any chance you see the ureteral orifice, would you try to stent it in this patient?
Stenting will be practically difficult, but to see whether the kidney function can improve, then you can stent it.
Okay.
So what is the HCG like, syncytial trophoblast-like area?
Actually, I don't have I looked at this retrospectively. I don't have the HCG value.
It's very interesting.
Yeah.
Yeah.
That's what I was wondering at.
It's one of the variant histologies, divergent histologies rather.
Okay.
Described. So
my preference there would be directly to consider cystectomy with cutaneous ureterostomy without involving the bowels, without getting the bowels in the picture, because creatinine is high.
Okay.
No, the thing is now there is a elevated creatinine. There's an obstructed system there. So if you see the ureteric orifice, then whether to put in a stent or not. If the ureteric orifice is open, I don't think stent. See if the creatinine is improving or not. If it's not improving with that, put in a PCN and see.
Exactly. So any concerns about seeding the upper tract? Because it seems like a very aggressive tumor with putting in a stent.
Would you one reason, difficulty, as I said, difficulty in putting the stent.
Would
but
you
if you would prefer to put in a PCN rather than put in a stent.
Okay.
Difficulty, and if the orifice is seen and if it's unobstructed, whether it improves it without doing anything, whether the creatinine improves or not.
Okay.
The seeding, does it occur in raw areas as well, or is it
this is potential concern because it's an implantable cancer?
Because we can resect that particular area. It is very thick, and I have bilateral obstructed systems with a very high creatinine. Resect, and you will see the ureteric opening. It is very safe to resect, I believe, because this obstruction is within the tumor, and you can see the ureter very clearly. I mean, I have succeeded in a few times.
Okay.
And stenting is feasible. So we have had patients with improving creatinine, improving urine output after that.
Fine. So if this patient were to present to you with hydronephrosis, and his creat is 3.5, would your attempt be to try and make him fit for NACT, or would you try to push him for surgery and let him come back for adjuvant therapy?
We had few patients like this. What we have done is we have done a PCN, and with the PCN, the renal function will improve over time. We will be able to give neoadjuvant chemotherapy. At least we will be able to give neoadjuvant immunotherapy. We will be able to give you a better patient for surgery than taking a upfront surgery.
My question is, so the thing is, when you put in a PCN, you have to wait for the creatinine to come down, then you have to start him on chemo. So
or immuno. If they can afford, PCN is a very easy procedure. Daycare procedure. It will be done, and the creatinine will start falling within a week time.
Yeah.
And within 2 week time, most of the time they will have a manageable creatinine. If they are not eligible for cisplatin, I can give pembrolizumab or atezolizumab.
In our scenario, sir, like I know pembro has acetonol, but
neoadjuvant is there, sir. Neoadjuvant phase 2. It's not. It's pembro.
For neoadjuvant, it is atezolizumab and pembrolizumab.
Pembrolizumab.
Adjuvant it is nevo.
But with our feet on the ground, do we have any patients that we give?
I mean, this is a theoretical scenario, but practically what we generally do is that we go for PCN
and try to get him fit for NAC.
Yes.
Okay, absolutely.
This patient is 80. It's not a problem for you.
80.
75.
75. Then probably he'll go for CTRT.
He's got hydronephrosis.
You give gemcitabine based CTRT.
No, but you told me you prefer not going for bladder preservation in a patient with hydronephrosis.
Not an ideal candidate for CTRT, okay. But 75-80, no.
Fine. So he had a left PCN done. His creatinine decreased to 2.4, but it plateaued there. It did not go any further than that. So next step, Balu, what, sir?
See, his for a neoadjuvant chemo, cisplatin eligibility won't be there.
Yeah.
Then you go for a carboplatin. That also an issue, but and the success rate with that. So probably I'd go for an upfront cystectomy.
Absolutely, for upfront cystectomy. Any opinions on carboplatin for any neoadjuvant setting?
No, it's not recommended.
Yeah, no. So, what scenarios would you consider upfront surgery in muscle invasive bladder cancer?
Rare histology.
Okay.
Rare histology, we have no choice upfront. Those who are not eligible for cisplatin-based chemotherapy, but fit for radical cystectomy. Just to be very clear, they are not eligible for cisplatin, but fit for radical cystectomy.
Proceed. Symptomatic patients, gross hematuria.
But the gross hematuria subside with chemotherapy. Okay. If you give chemotherapy, most of the day it will get subsided. So fine. We'll at least try to take a chance, and then only will.
Fine. So he underwent radical cystoprostatectomy with ileal conduit. Pathology was T2B N0, all nodes negative. High-grade urothelial carcinoma with divergent differentiation, glandular, squamoid, and trophoblastic differentiation. That's a size 7.5 centimeters. T2B. Next step.
Creatinine now came down to 1.
No. Creatinine is still 2.4. Okay. Now, what do you do?
T2 disease, this patient does not merit any adjuvant treatment.
I know there is no. Why is that discrepancy? If it's a T2 patient, we would definitely give him NACT, but for a T2, we don't give adjuvant.
That's what we were discussing.
T2 patients in the trial.
We have no data to.
That is the only thing. There is no recommendation, but there is no harm in giving adjuvant nivolumab.
No, adjuvant nivolumab.
If disease patients.
Yeah.
T2, there is no recommendation because the trial does not have T2 patients.
Okay. If it's creatinine.
Not because it will not work in T2.
Okay.
Only if it is YPT2, that means if the patient has received NACT, then only adjuvant immunotherapy comes.
His creatinine is, suppose his creatinine is 1, and he cannot afford immunotherapy. Any role of adjuvant therapy?
Yes.
In T2?
Yes. So there is a, the adjuvant, the data for adjuvant is very, very less. Most of the data for chemotherapy in resectable bladder cancer is for neoadjuvant. But there is a meta-analysis on that, and they found that definitely giving adjuvant chemotherapy improves outcome compared to observation. There is a meta-analysis. I mean, I don't know about the heading or who was done, but there is a meta-analysis on that.
Okay.
So if the patient is fit enough and creatinine is 1, we will definitely give cisplatin gemcitabine. But the problem is that if you have done a ileal conduit or any of those procedures, then it's very difficult for the patient to tolerate chemotherapy. The chemotherapy tolerance is always better when it's given neoadjuvant than compared to adjuvant, because a lot of metabolic issues will come after this conduit.
No, not really. A conduit doesn't have initial metabolic, because it drains out. So he won't have hypochloremic metabolic acidosis or anything.
But we find it very difficult to give adjuvant chemotherapy compared
to. It's a big surgery, so they take time to recover from it. He refused further chemotherapy.
Whatever it is, there will be some stasis, the urine for the user. So some of them can be reabsorbed.
Yeah. Okay. So this is his follow-up CT. This is at 3 months. He's got multiple retrocaval paraortic lymph nodes now. No other sites of metastasis. He could not get a contrast CT. His creatinine is still high.
So what is in this new CT?
Multiple retrocaval and paraortic lymph nodes. All.
It's not the kidney. So it is. There is some contrast given, no?
One kidney is opposite side.
Is it okay? I don't know. Probably the slice I took or something. But the finding is both side
there are some retrocable nodes, para-aortic nodes.
Now this is a metastatic disease. So you treat as a metastatic disease. If patient can afford, do a genomic assay to see whether there is an FGFR3 or something. Do an HER2 by fish, by IHC fish or by genomic assay. Look for HER2 amplification, and then and also get the PDL1 done. Anyway, the patient is platinum ineligible. So, irrespective of PDL1, this patient is a candidate for immunotherapy.
Okay. Can you give carboplatin?
We generally don't give with creatine 2.3 because when atezolizumab was not there, we would have given. But atezo and pembro is there, and then you give carboplatin and induce another renal toxicity is not fair. Not fair.
Fine.
So this is an eligible for immunotherapy, and if FGFR3 is positive, erdafitinib, though not available in India. This is academic discussion. So HER2 positive, we would have given Enhertu, that is trastuzumab deruxtecan, though currently not available in India, would have been the options.
Fine. The patient actually just chose for best supportive care. He did not want any further therapy. Case 4, 50-year-old gentleman diagnosed with muscle invasive bladder cancer, T2, clinical T2, N0, M0, planned for NSAT followed by radical cystectomy. So on the left side is his baseline imaging. And I think he received dosed and Semvac, 6 cycles of dosed and Semvac. That's his post chemotherapy imaging. Flower, any comments on the the lesions on the right lateral wall, post NACT?
CT looks like a complete response.
It's an absolute complete response.
He's 45-year-old now.
Yeah, he's young. And we actually seeing a lot of this with dosed and Semvac.
Yes.
So the thing is, he noted this complete response on his report, and he asked, does he really need to proceed with the cystectomy?
As of current recommendations, definitely I will.
How would you counsel him?
Yes, the strong data, that is phase 3 data, is for radical cystectomy only.
Absolutely.
But the phase data is coming up. As of in rectum and esophagus, data is coming up. The patient goes for a complete response, and should we go ahead with an early cystectomy, or can we wait?
Yeah.
That's the question. And even data has shown that the bladder preservation rate was at 2 years, it was around 80%.
Yeah. Actually,
do you have to confirm it by cystoscopy biopsy?
How do we confirm? That's the fallacy in this.
Yeah.
In SWG data, if we see out of 6 on 10, there was discordance between the pathological T0 and the clinical T0.
Absolutely.
That's the main fallacy in this.
You have to do a
Definitely, we have to go for cystoscopy, biopsy, imaging, and all modalities we have. And again, PET-CT can help us in assessing the nodal status.
Yeah. And so this is that paper that you were just actually talking about. Actually, the conclusion of this paper was, this is from MSKCC. High rates of overall and disease-specific survival bladder preservation, patients who achieved a complete clinical response to NACT. And these patients were confirmed on TURBT. But 48% experienced recurrence in the bladder, that is around 11% with muscle invasive disease. So this is what I usually counsel the patient.
Half of the patients can go ahead with a maintained response.
And probably because he's a young patient also, 45, 50.
Definitely. For this patient, I may not be concerned.
It's likely that they can have recurrence without showing up in the bladder mucosa. You can miss
actually, yes. In that series, I think some three patients had systemic metastasis without having, they had incurable cancer. So another question is, if you have complete response, can we give him RT?
That's also an option. The majority of the data comes from when after NSCT patient becomes asymptomatic. He or she will not be keen on radical cystectomy. That's how the majority of the data evolved. And it has shown good bladder preservation rate and disease-free survival with addition of RT also.
So 80-year-old male, this is a second last case, I think. 80-year-old male, gross hematuria, left flank pain since 2 weeks, creatinine 2.4. So that is his, he had a non-contrast CT, That's his lesion. It's actually in the left lower ureter. So, and it's extending into the vesico-ureteral junction. So, a TURBT was done. The tumor is in the region of the left vesico-ureteral junction. Left ureteral orifice could not be identified. It was actually obscured entirely by tumor. Right ureteral orifice was normal. Pathology report is T1 high-grade urothelial carcinoma, muscularis propria identified but not involved. So, Sanjeev sir, what can we do for him? He's T1, he's not T2, but it's
the ureter could not be seen.
Could not be seen.
So we haven't ended it. The tumor is not cleared properly.
The ureter could not be identified. All visible tumor was resected, but the tumor could not be identified. I mean, the ureteral orifice couldn't be identified.
But the ureter seems to be involved in the lower
It is,
carcinoma.
yeah. Probably that region wasn't resected or.
So,
how would we manage this patient?
So is the upper
Creatinine 2.4.
So is creatinine 2.4 and
If it's good for surgery, then I would consider nephrourectomy for him.
Nephrectomy with a bladder cuff.
How is the kidneys?
It's creatinine 2.4.
No, how is it? No, the kidney. How?
I'm sorry, I don't have an image for that.
No, it's contracted or no? It's gross, thinned out, or usually if it's this long, it must be poorly functioning or
possibly, yeah. And he's 80 years old. Any point in if the proximal ureter and the kidney was normal, can you do a distal ureterectomy with a bladder cuff?
Yeah.
Generally not for high grade, I think.
But no, with 80 years old
80
and
year old.
in the high grade also, high creatinine, you can consider, since he's 80 years old, you can do a distal ureterectomy in high grade. But yeah, as I said, high grades, it's relatively, they say that go for a nephrourectomy, but still 80 years you can consider doing a ureterectomy.
Yeah. He's a frail patient, CKD. Yeah. Fine. I think that's it. Thank you very much. Thank you.
Thank you, doctors, for such captivating presentation and discussions. Your expertise has truly enriched our collective knowledge, marking the successful conclusion of this enlightening CME. In closing, I extend my sincere gratitude to all our distinguished speakers for their invaluable contributions. May the knowledge shared today resonate and inspire progress in the dynamic field of medicine.
Next, we move on to the valedictory function. I invite the ASU President and Secretary, Council Member, and the Chairman and Secretary of the Organizing Committee of Bladder Cancer Update 2024 to the stage.
Those leaving, please collect your certificates from the registration counter. Quiz winners, your certificates are also at the registration counter. You're also requested to please hand back the feedback form at the registration counter.
So, finally, we are coming to the end of a very nice conference, well organized. The academic material was excellent, arranged were excellent, and nobody can, I think, tell anything, any negative points. Everything was excellent. That is what I can say. So, thanks to Caritas team, Suresh Bhatt sir and Vijay sir, Dr. Unni for arranging this meeting, and Frederick, myself, Surya, Jagadish sir, on our behalf, we express our gratitude. Thank you.
Yeah, I totally agree with what our President sir has said. It was really, first of all, it was a great learning experience for me. I've learned so many things, and it would, I think, definitely would have been a great learning experience for postgraduates. And I really congratulate Suresh Bhatt sir, the organizing committee chairman, Dr. Suchindra, and our council member, Dr. Frederick, and all the Caritas team who has put such a great effort in bringing such a wonderful show. Thank you very much. I hope the program is recorded, so it will be available on YouTube. Somebody wants to see it later on. That would be very great. Thank you so much. Thank you.
Any comments from the floor? Participants, if at all, regarding this CMA? Any words of appreciation or criticism? Both are welcome. Thank you. Thank you. Thank you. Okay, thank you all.
Shall we all rise for national anthem?
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all for being a part of Bladder Cancer Update 2024. Safe travels and best wishes to you all.